Morning, everyone, and I'd like to take this opportunity to welcome you to the 10th Annual International Women's Day Conference. And I can't believe that it's been 10 years since we've been doing this. And so it's a real pleasure to have all of you here. Just a few weeks ago, we weren't even sure how many people we could have in person, but thankfully, restrictions were lifted and we're able to have all of your beautiful faces here today, as well as those who are joining us online. So my name, for those of you who don't know me, is Karina Palmer Ford, and I am a medical doctor who works in the Women's Health Department at the Health Services Authority. I want to take this time to just welcome our guests. We have apologies this morning from the Honorable Minister of Health and Wellness, Sabrina Turner, but she has sent a representative in her stead, and that is Dr. Autelia Newton, who is the Chief Medical Officer. Sorry, brain freeze, excuse me. The Chief Medical Officer, so we're happy to have you here. I'd also like to acknowledge and welcome other ministry staff with us today. And I'd like to welcome the senior managers from the Health Services Authority, which include our CEO, Mrs. Lizette Yearwood, and Dr. Delroy Jefferson, who is our medical director. And want to, of course, welcome our presenters and all of the delegates as well. So welcome to everyone. We have a day that I think you'll be very pleased with today. It's going to be filled with lots of informative talks and presentations, as well as some fun activities. So we hope that you enjoy this 10th year celebration of our International Women's Day Conference. Before we get into everything, I just want to take care of a few housekeeping things. So firstly, I want to just say that this conference would not be possible without the collaboration and help of a lot of people. So I want to take this opportunity to thank some of our sponsors here. And so Health City, Cayman Islands, has graciously sponsored our lunch for today, so we want to thank them. We have silver sponsor, which is Miami Cancer Institute, and that is part of Baptist Health. We have our bronze sponsor, which is the Cayman Fertility Clinic, and of course the Ministry of Health and Wellness as well, and they have graciously sponsored the Wi-Fi. Just take a minute here to mention that if you need Wi-Fi and access, the password is Ministry 2022 with a capital M. There's a little card on each of your tables that has that information, as well as there's a QR code on that card that you can use to access and get to the programs and CMEs. We also would like to thank Cayman Clinic for sponsoring our coffee break. And you would have noticed outside there's several exhibiting sponsors, which include Ocean Med, Cayman Rehab Services, Progressive Distributors, MSD Senka, Public Health, the Cayman Islands Cancer Society, and the Breast Cancer Foundation. So I want to just ask you as well a couple other things to please keep your phones on silent, just to try to minimize any sort of disruptions while the speakers are presenting. For those of you who are not aware of where the bathroom facilities are, if you go out the back doors and to your right, and go around the corner, that's where you'll find the restrooms. Also want to ask you to please minimize getting up and moving around during the presentations as much as possible, and just to keep that limited to the break times. And of course, because we're still living in COVID times, we are still observing COVID protocols, which means that we would like you to please sanitize when necessary, and if you're not eating or drinking, try to keep your mask on if possible. We want to also take a minute to thank CIG-TV for live streaming this conference, and that has made it possible for many people who are not physically present to be able to participate as well. So thank you very much for that. At the end of this conference, for people who have attended in person, there will be a link that you're going to receive asking for feedback. It's a survey. And so we would really appreciate it if you take a few minutes to complete that feedback, as it will provide very useful information for future conferences and how to improve those. One final thing is that I want to give special mention to our title sponsor, which is HSA, and specifically in that group, want to make special mention of Mrs. Brooke Moore and Monique Spence, who have worked tirelessly to put this conference together. So thank you so much for that. It was just a week ago, actually, that I was secretly rejoicing that this is the first conference that I would have nothing to do in public. And then it was like, somebody said, no, that can't happen, so here we are. So excuse me if I'm a little bit nervous, but I was prepared to just be sitting down there relaxing. Right, so without further ado, I'd like to invite Nurse Mitzi Morgan, who's nurse manager of Women's Health Department, to please come and offer the opening prayer.
Good morning. Let us pray. Dear Lord, thank you for giving us the opportunity to gather here today. Thank you for protecting the Cayman Islands and giving the leaders wisdom to navigate this season. As we celebrate the women of this country and worldwide, I pray that you will give wisdom, strength, peace, and comfort. We pray that this conference will impart knowledge. We pray for the presenters, attendees, volunteers, and sponsors who made this conference possible. Thank you for blessing our time together. In Jesus' name we pray, amen. We would also like to take this time to honor our colleague, Dr. Edward Corderon, who passed away recently. Dr. Corderon was an enthusiastic supporter of the Women's Health Conference. You could count on him to be here every conference, always sitting at the front, and always very early. He is greatly missed. Can you stand as we observe 1 minute of silence in remembrance of our dear colleague, Dr. Edward Corderon.
Thank you, everyone. You can be seated. So we also have a few remarks that we're going to ask some of our senior managers to make for us this morning. So I would like to invite Mrs. Lizette Yearwood from the Health Services Authority, our CEO, to please come and make some opening remarks.
Thank you, Dr. Palmer. Good morning. With protocol having been established, it is my absolute pleasure to welcome each and every one of you to our 10th annual Women's Health Conference. Thank you all so much for joining us today, whether you're joining us in person or through the live stream on CIGTV's YouTube channel. In fact, this is the first year that we are actually live streaming this event, so thank you so much. Thank you so much to the CIGTV team for making it possible. For those of you who can't physically be here today to attend, you can actually tune in at your own convenience, wherever you are, and benefit from this excellent program that we have lined up for you today. Our annual Women's Health Conference is held in recognition of International Women's Day, which celebrates the social, economic, cultural, and political achievements of women each year on the 8th of March. Out of a desire to educate women on their health and the services that are available, our Women's Health team launched the conference in 2012. Each year since then, the conference has grown from strength to strength through their passionate work to improve its quality. Congratulations to the Planning Committee on achieving this milestone. Give yourselves a big hand. It's truly been an exciting journey, as we've seen both interest and attendance increase from year to year, to the point where we've outgrown our campus venue and we've had to come to the Marriott. And thank you so much to the Marriott team for accommodating us here today. And a big thank you again to our sponsors, which include the HSA, Health City, Miami Cancer Institute, Cayman Fertility Center, Cayman Clinic, Ministry of Health and Wellness, as well as our exhibitors featured in the pre-event area. Thank you so much. Although this is billed as a Women's Health Conference, I want to acknowledge and applaud all of our men who are among the presenters, as well as those of you who are attending in person and virtually in the audience today. The subject of women's health is not solely about women, as will be evidenced through the presentations and discussions here today. We acknowledge that women are the primary health decision makers in their families, and many women who aren't mothers still help to make health decisions for their partners, family members, and other loved ones. So today we'll hear topics such as the effects of menopause on the whole body, mental and physical, a topic that I'm sure will interest many men in the audience as well. Other topics on our program include multi-organ endometriosis, the eyes and sexually transmitted infections, which can impact females at any age. Women have multiple and changing health needs throughout their lives, from puberty through menopause and beyond. Reproductive health shapes not only the overall well-being of women, but also of families, communities, and wider societies, extending far beyond the important experiences of pregnancy and childbirth. You'll also hear discussions on breast conditions in pregnancy and non-genital maternal injuries in pregnancy, delivery, and postnatal. Additionally, there will be a presentation on that one topic that has dominated much of our attention over the last 2 years, COVID-19 pandemic. Studies are currently being done to prove how women's reproductive health has been disrupted because of the psychological burden of the pandemic. Today, there will be a presentation that explores pregnancy, childbirth, and post-delivery in pandemic times. And I'm sure this is going to be very enlightening. I'm most delighted to highlight that among the many speakers you will hear from today are young Caymanian physicians who have either recently returned from their studies or have been making a significant impact in the community working with us. These include Dr. Kendra Chisholm, Dr. Kimone Fraser, and Dr. Colin Charles. Also among our lineup of presenters are our 2 international speakers, Dr. Troy A. Gatcliffe of Miami Cancer Institute, who is no stranger to this conference, and OBGYN and certified menopause expert, Dr. Verna Brooks-McKenzie, who will be joining us virtually. Dr. Brooks-McKenzie also presented at our National Healthcare Conference in 2016. It is always my absolute honor to take part in this conference because of the wealth of information that is presented, and I am confident each one of you will leave here today with greater knowledge and awareness of women's reproductive health. Health affects all aspects of women's lives, not only their family, but their education, social, and work life as well. So I encourage you to share the link of this event with your friends, families, and contacts who may be able to join us virtually or take the opportunity afterwards to listen to the sessions at their own leisure. Before I close, I want to take the opportunity to publicly acknowledge all of our women in the Cayman Islands who serve in almost every area of the industry and sphere of life, whose contributions have impacted all of us in some ways, whether as domestic helpers, nannies, caregivers, entrepreneurs, politicians, teachers, healthcare providers, business executives, and in so many more roles, who do a tremendous job every day contributing to the economic and social well-being of these islands. From our seafaring heritage to the economic giant that this country is today, our women have always been at the forefront, playing integral roles and blazing a trail for generations, and we salute each and every one of you. I want to acknowledge all the women in healthcare who have proven, particularly over the past 2 years, that we as women have known all along that we are the heart and pillars of healthcare. I will take a little bit of latitude at this time to particularly acknowledge the women of the HSA who have been at the forefront of the pandemic in many ways. I also applaud the support of our many male colleagues during this challenging time. I also want to share some exciting new developments about our plans at the HSA to continue to improve women's health services. This year, we will be expanding our services to include a dedicated Center for Women's and Child Health, bringing together all related services into a single building on the main hospital campus with extended operating hours. I'm also pleased to announce that at the HSA, a team of young qualified Caymanians are currently undertaking innovative work in genome sequencing to determine breast cancer risk assessment, which will lead to earlier diagnosis and preventative intervention, improving health outcomes. Our strategic initiatives also include investing in the expansion of our capacity for maternity and neonate services. And in a few weeks, we would have fully opened all outpatient services at the new Smith Road Medical Center location, providing specifically enhanced ambience, accessibility, operating hours, and services. These include general practice, pharmacy, public health clinical services, cardiology, and phlebotomy. Our future plans at that location also include outpatient diagnostics and other services. We aim to continue to positively impact the health of our women, by extension, our entire community. There are also many other exciting things to come, so do stay tuned. And with that eager anticipation, I also eagerly await the many presentations today. So thank you once again for attending our 2022 Women's Health Conference. Have a fantastic day.
Thank you for those words, Mrs. Yearwood. I did mention that I was a little bit nervous. So evidence of that is that I can't believe I got up here and forgot to acknowledge the Women's Health Department for their contribution to making this conference happen. And this was the baby of Dr. Alexander from the Women's Health Department, so I can't forget to mention them. So moving right along, I would like to ask Dr. Delroy Jefferson, who is the Medical Director at the Health Services Authority, to please come and say a few words. He's been on vacation for a few weeks, so we decided to give him some work.
Good morning. Protocol has been established, and so I just want to bring greetings on behalf of the colleagues, the physician colleagues. Yes, I've been away on vacation. I was in Africa, had a very eventful time, but I'm back, and it's good to see everybody. I always enjoy being a part of the Women's Conference. I will tell you secretly, one of the things I look forward to is the decor. And I'm sure you could join me in appreciating the fine detail that's been put into ensuring the ambience of this room. And I want to say a big thank you to the Women's Health team that's taken the time out to ensure that we celebrate women in this way, including the way in which the ambience has been set. So a big thank you to the women. This is the 111th celebration of the Women's Day. Of course, the Women's Day was the 8th of March, but it's been going on for a while. And this is the 10th celebration, the 10th time that Women's Health Department have hosted this event. And they have used this platform to bring awareness to women's health issues. And I want to say a big thank you to the Women's Health team who have taken time out to arrange this. And we've all been blessed, we've all been provided with knowledge, and our awareness has been drawn to women's health issues. But 10 is a big number. And it comes with mixed feelings. Because whereas, on the one hand, it's nice to celebrate the 10th anniversary, it brings to my contemplation something that we're aging. It brings to my contemplation that some of my friends, like the CEO, Ms. Lizette, and my Deputy Medical Director, Dr. Cummins, and my PA, Ms. Darlene, and my wife, they're getting old. But I also want to draw attention to the struggles that's going on now in Ukraine. And I just want for you to just, for a minute, reflect on the fact that here where we are fortunate in that we don't have to deal with some of the issues and struggles relating to what's going on in that part of the world. But at the same time, think about, just for a moment, how difficult it must be for those mothers who, some of them, those women who've had to leave their husbands behind, and the difficulties that they must be facing at this time. So while we celebrate our freedom, and as we celebrate the acknowledgement of what our women have done and are continuing to do, just think about the struggles that these women in Ukraine are probably now faced with. The final thing I want to say is that at HSA, we have made progress with respect to gender equality. Over the years, we've seen where, at least as it relates to the physician services, we've seen where there's been an increase in the number of females that have participated. And whereas I like all my staff, and everybody knows that, I like all my physicians, but I have a particular love for my female physicians and what they bring to the table. Of course, in obs and gynae, there is an unequal mix to the other side, where there's there is a 80% female to 20%. Well, actually, not true. That's not entirely true. But there's a larger percentage of females to males. But in the HSA in general, there's been a greater, there's more equity. Now, I have a little gift, which is a authentic Egyptian plaque that I brought back from Egypt, which I'm going to be giving to a lucky person. In 2012, when we first started this Women's Health Conference, the percentage of females in the clinical practice at the HSA was 35%. So there was 35% females and 65% males. Now, 10 years later, as we celebrate the 10th anniversary of this conference, things have changed. And now we are moving towards a more egalitarian share of distribution between male and female. And so anybody who can tell me what the percentage of females in the clinical practice at the HSA is relative to males, then you'll get this lovely gift, which you'll see later on. There are some persons who can't participate. If you're a part of the HR at the HSA, you can't participate. But if somebody can just tell me, let me see the hands of those persons who know what the mix is. I'll give it to the person with the nearest percentage. Anybody? Make a guess. 55? 55 females. 65% females. 40-60. You made a statement. What did you? Huh? 58 for females. I'm talking about physicians, by the way. Sorry, I should have. Physicians is what I'm talking. So, one last guess. 45%. What? 45%. All right. And we're not going, in order to not go on for too long, I thought I heard somebody, I thought you had said 48, that's why I pointed on you. The closest person that came to the correct answer, somebody said 50%. Somebody said 45. This person, that doctor said 45. You said 45 as well. The person who came to the closest, actually, somebody said 50, and I think, did you say 50? No? No, okay. The person who got closest to it was 45. Actually, it's 48 point something of female relative to male. So a big thank you and congrats. And so we're doing our part in getting this, in reaching that point. A big thank you to my colleagues, and on behalf, of all the physicians, on behalf of the staff, a big thank you and welcome. Please enjoy the conference.
Thank you for those words, Dr. Jefferson. You will have noticed that Dr. Hazel Brown was on your program to speak, but we have apologies from her this morning as she's not well. And I'd like to also take a minute to just acknowledge and welcome the chairman of the HSA board, Mr. Osborne Bodden. And without further ado, I'd like to welcome Dr. Newton, who is representing the Honorable Minister of Health, Sabrina Turner, to come and say a few words.
Well, against the rules of the CMO, I'm taking it off now because otherwise nobody can hear. Yeah, Minister is very sorry not to be able to be here today, but unfortunately it's not very well, and this doesn't bode very well if a minister goes around spreading germs. So this is why she's not here. So it is a great privilege for me to be here today for this annual 10th annual HSA Women Health Conference. I would like to applaud the HSA and specifically their Women Health Department for making this event one of Cayman's most respected and sought-after medical forums. Through this conference, the HSA demonstrated its commitment to keeping the women in our community healthy, advancing women's health through research and educating and empowering women to be catalysts for improving health at all levels in our community. With this being the first and only conference in the Cayman Islands dedicated to women's health, I'm eager to learn from our reputable medical professionals today. While there are here as thought leaders this morning, the Women's Health Department of HSA is renowned throughout the region for providing world-class care to their patients. A prominent example of this is the elimination of the mother-to-child HIV and syphilis transmission, an achievement that comes from the true routine screening for expectant mothers. Now, personally, I've seen the horror of the vertical transmission in refugees camps where I've been working in Africa and so on. It is a true horror, and is something that we need to be extremely proud if here this doesn't exist. The HSA is also home to Cayman's only neonatal intensive care unit, an asset that enables parents to remain close to their premature infants while they are cared for, as opposed to having to travel overseas. And again, that's a personal experience as a mother. When I gave birth to my 2 children, they both ended up in intensive care. I was in an European country, well-renowned for their health services, and yet my husband was sleeping on the floor because there wasn't really appropriate arrangements for parents to stay with their children. In 2021, the HSA reported 744 births, the highest number since its inception. Now, it's an achievement in on its own, because there are lots of countries where the neonatal, the birth rate is going down so fast and so quickly. This equates to an increase in antenatal and postnatal care, pediatric care, and so much more. This is an outstanding feat, especially in the current medical climate, and deserves to be applauded. As a woman, I know how important it is for us to have all the information we need before we make decisions, especially about our specific healthcare needs. As a society, we are still adjusting to speaking freely about women's issues without shame or reproach. We deserve to be educated on reproductive and feminine health without the fear of stigma or embarrassment. As your Minister for Health and Wellness, I'm speaking on her behalf, it is my responsibility to ensure that we have the resources to meet the healthcare needs of women and that there is equitable access to these resources. As a female minister who leads a predominant female ministry, and I can assure you it's great fun to be part of that team, I can assure you that women's needs are top of mind. We hope that this conference may offer new and improved solutions for the unmet needs of people's reproductive health journeys. I'm excited by the range of topics the conference has prepared and the impressive list of presenters who will be sharing with us throughout the day. I'm also pleased by the collaboration established with our partners in the private sector, both locally and overseas, as reflected by the diversity of our presenters scheduled to speak today. Thank you for all your ongoing partnership with the HSA, and please enjoy your conference. Thank you very much.
Thank you, Dr. Newton. And now to the exciting and fun part, which is the beginning of our conference. Our first speaker is no stranger to the HSA, Dr. Troy Gatcliffe has been a part of many of our conferences, and we are pleased and just so happy to have him join us again for this conference. So he is a part of the gynecologic oncology team at Miami Cancer Institute, at Baptist Health, South Florida. He earned his medical degree from the Royal College of Surgeons in Dublin, Ireland, and completed an internship and residency in obstetrics and gynecology at Boston University Medical Center in Boston, Massachusetts. Dr. Gatcliffe then joined the faculty at the University of Texas Southwestern Medical School, Parkland Hospital in Dallas. He was an assistant professor there, teaching in the largest obstetrics gynecology training program in the country. He completed a fellowship in gynecologic oncology at the University of California, Irvine Medical Center in Orange County, California, where his research interests included molecular signaling pathways in ovarian cancer and chemotherapy of cervical cancer. Dr. Gatcliffe is board certified in obstetrics and gynecology and is a fellow of the American College of Obstetrics and Gynecologists and the American College of Surgeons. His repertoire includes minimally invasive surgical techniques, including robotic surgery, for all complex gynecologic and women's reproductive cancer diagnoses. He has a strong personal and professional interest in caring for patients from the Caribbean and Latin America, which we're very happy about. And this is likely because he was born and raised in Trinidad and Tobago. I'd like to have you join me in welcoming Dr. Gatcliffe to come and present to us advances in vulvar cancer treatment.
Good morning, beautiful Caymanian people. How is everybody? Okay, according to the clock, I am starting on perfect Trini time, right at 8:30. It's such a pleasure to be back. I have missed Cayman tremendously. I've been coming here for 10 years, and I think that I was actually part of the first women's conference when we were all huddled together in the room in the hospital. It's so great to be here. I am wearing my green Baptist jacket, which I bought BC, and I'm so glad that I finally have the opportunity to take it on the runway here at the Marriott. I know that anytime I am presenting anywhere around Dr. Stone, I have to bring my high-end fashionista game. Although the issue with me and Dr. Stone is that the more years he spends in Cayman is the fitter, healthier, and more svelte he looks. And I, on the other hand, am sporting my new COVID plus 19 figure. We're going to speak today about vulvar cancer, so if there was any doubt amongst any of you whether we're talking about women's issues, we're delving straight into genitalia. I hope nobody will be offended. I would not expect that. Vulvar cancer is an extraordinarily rare gynecologic cancer, and I really want to take the opportunity in particular to congratulate Dr. Alexander for choosing to have this presented. This was not my idea, this was hers. In all of the years that I've been speaking anywhere around the world on gynecologic cancers, I have never been asked to speak on vulvar cancer. And so this is a unique opportunity for me to put together a talk to reach the health professionals here in Cayman. Vulvar anatomy includes all of the structures listed in the slide. including the labia majora, minora, the clitoris, the main sexual organ of the female, the vestibule, the vaginal introitus, the urethra, and the Bartholin's glands, which excrete secretions important for sexual intercourse. All of these structures encompass the vulva, and vulvar cancers include any of the areas in this slide and can include in the clitoris and as far down as the perineum and the anus. Very important as we talk about advances in the treatment of vulvar cancer, what we're going to spend most of our time really focusing on today are lymph nodes. So it's really important to understand the lymph node drainage of the vulva. Much like the cutaneous structure that is the breast, which drains to the axillary lymph nodes, and breast cancer is such a well-known women's cancer, vulvar cancer being the opposite, not a well-known women's cancer, drains in the same way to the groin nodes. And I'm going to discuss with you a little bit about sentinel lymph node detection and biopsy, which we borrowed from our understanding of breast cancer, and we have now successfully applied it to vulvar cancer. So the drainage of the vulva includes the superficial groin nodes, which in turn can drain to the deep groin nodes, and from there into the pelvis. Some of the central structures of the vulva, including the clitoris and the mons, can themselves drain directly into the obturator and pelvic nodes, bypassing the superficial and deep femoral nodes. For those of you that remember anatomy, the superficial nodes are above the cribriform fascia in line with the saphenous vein, and most of the nodes that drain the vulva congregate here, and this is most often where we find the sentinel lymph node. Lymph nodes are not typically seen themselves at surgery unless they are particularly enlarged. They are contained within the fat pad that lies in your groin. So if a patient is relatively thin and does not have a large BMI, you can actually palpate the groin nodes to see if they're normal. And if groin nodes are enlarged, as it happens to all of us, whenever we have some kind of infection, you'll have an enlarged node in your axilla, in your neck, or maybe even in your groin. These nodes can become palpable. At the time of surgery, though, especially for very early vulvar cancers, they can't be seen. So when we go in to find the lymph nodes, we have to use special techniques to identify their exact location in order to find the sentinel. If you peel away the cribriform fascia and the superficial nodes, you'll come to the deep inguinal lymph nodes. And anybody who's a physician in the room would easily remember the mnemonic from medical school, NAVY, which is nerve, femoral nerve, artery, femoral artery, vein, and then the empty space, which contains very typically the deep inguinal lymph nodes that drain the vulva. From the deep inguinal nodes, these lymph nodes then drain into the pelvic lymph nodes, which are very, very well known to gynecologic oncologists such as myself, because they are the structures that drain the deep pelvic anatomy, including the cervix, the uterus, and the ovaries. So typically, the lymph node drainage, the key point being, goes first to the groins and then potentially to the deep nodes. Some of the structures can actually bypass the inguinal nodes and get to the groin, to the deep nodes alone. Vulvar cancer is mostly comprised of squamous cancer. Other histologies of vulvar cancer include melanoma, basal cell carcinomas, Bartholin gland adenocarcinomas, sarcomas, and Paget's disease of the vulva. Most importantly, this is a highly HPV-associated cancer, with the majority of squamous cell cancers being caused by the HPV virus. Consequently, vaccination for cervical cancers have a protective effect for vulvar cancers as well. In addition, vulvar lichen sclerosis and vulvar dystrophies can also predispose to vulvar cancer. In the United States, where I work in Miami, there will be approximately 6,300 cases of vulvar cancer in a year. When you think of a population of 330 million, this is a really rare cancer. Unfortunately, there'll only be about 1,500 deaths a year. Women in the US have about a 0.3% lifetime risk of being diagnosed, and the average age of diagnosis is 68. And as you can tell from this slide, the overwhelming majority of vulvar cancers are diagnosed post-menopause, with almost 50% being diagnosed over the age of 65. So this is most definitely a cancer of older women. I said older women, not old women. The issue there is one that I haven't put into a slide, and I just really wanted to harp on for a moment and discuss with you. Because whilst everyone in the room knows that nobody ever stops being a sexual being, and many human beings enjoy sexual activity way into their 60s, 70s, and 80s, life happens, as I like to say in a lot of my talks. And for one reason or another, death of a spouse, medical problems, changes in family dynamics, sexual function does tend to decrease as we get older. And therefore, one thing that I have noticed, and that all of us that take care of vulvar cancer notice, is that vulvar cancer is a cancer of older women, and we are always amazed very often when we find an advanced vulvar cancer, how this woman, quote unquote, allowed it to get so bad. The issue really is that when you're not as sexually active as you were in your younger years, in your 20s and 30s, or you might not be sexually active at all. I'm not saying that 80-year-olds are not sexually active, or 70-year-olds. I'm just saying that they're maybe less sexually active than they were when they were 20s and 30s. Typically, then, people are not paying as much attention to that part of their body, and more importantly, they don't have a partner who's paying attention to that part of their body either. How many times have we heard where the first palpation of a lump in a woman's breast was by her partner, right? So we often wonder, why did this cancer become so advanced, and did she allow it to become this advanced? And the truth is that a lot of cancer patients do strive and struggle with denial, but in vulvar cancer, it's really just a question of just not being mindful of an area that you are no longer paying that much attention to. There are two proposed etiologies for vulvar cancer, the most important of which being HPV infection, the second of which is chronic vulvar dystrophy, or some kind of autoimmune process. And this would be a photo that's very recognizable to those of you who examine vulvas and female genitalia on a daily basis. This is a picture of a patient clearly with lichen sclerosis, the typical parchment-like white patchiness on the vulva that is a vulvar dystrophy. And the cancer is actually just a little tiny red nodule up at the top. So certainly vulvar dermatoses, especially lichen sclerosis, is associated with developing vulvar cancer. This would be a more advanced photograph of a vulvar cancer, where the cancer itself is just the small red area with that greeny excoriated dot, and the rest of the vulva is actually just lichen sclerosis. Risk factors for vulvar cancer include vulvar or cervical intraepithelial neoplasia, a prior history of cervical cancer, since that predisposes you to having HPV, cigarette smoking most importantly, vulvar dermatoses such as lichen sclerosis, immunodeficiency syndromes, and Northern European ancestry. It bears at least one slide to say that now, since 2015, about 7 years ago, we now just categorize dysplasia of the vulva either into low grade or high grade, encompassing what we used to use as the terminology when I was in fellowship of VIN1, VIN2, and VIN3. The clinical presentation of vulvar cancer, another reason why it's so often overlooked, is not that the patient is in denial or the patient has allowed it to get that bad. It's just that it's an area of the body that may not be in particular use from a sexual standpoint, and often vulvar cancer is asymptomatic. So unless you're inspecting yourself fastidiously with a mirror all of the time, and let's face facts, who does that? You might miss a vulvar cancer. And the issue is because it can be completely asymptomatic. Really advanced vulvar cancer will have two main symptoms, just like most vulvar dermatoses, which is pruritus, itching, and sometimes bleeding. This would be a very typical presentation of a midline, and we'll talk a little bit about the locations of vulvar cancers and how important it is to know where they are in relation to the midline, most importantly in relation to the lymph node drainage of a posterior fourchette perineal vulvar cancer directly between the posterior aspect of the vagina and the anus. This is a more fungating lesion that itself probably started as a more lateral lesion and now has directly invaded to include the clitoris, probably into the vagina, and is probably affecting the urethral meatus. This is a fungating, fleshy-like tumor that again probably began a little bit more laterally and now has become more definitely midline. Histologic types include squamous cell carcinoma, of which there are two main types, and these are not really important except for pathologists, but 75% of vulvar malignancies are squamous. And I've mentioned some of the other ones before. The good thing about Paget's disease is although it can be difficult for a general gynecologist and even a gynecologic oncologist to differentiate the difference between Paget's disease and vulvar cancer, this is a very typical presentation of a Paget's disease and not a vulvar cancer. The diagnosis is always under the microscope because Paget's disease is almost unmistakable. It's always on board exams, and as soon as you see those large, vacuolating Pagetoid type cells, you know you're dealing not with a vulvar cancer, but with Paget's disease. But Paget's disease can also increase the risk of vulvar cancer. The mode of spread of vulvar cancer is most typically by direct extension, growing into what's nearby. The other two ways are by lymphatic spread to regional lymph nodes, and we've talked a little bit in the beginning about the superficial and deep inguinal lymph nodes, and then from there potentially to the pelvic nodes, or in an upper midline structure straight to the pelvic nodes. Hematogenous dissemination to other parts of the body is typically rare and almost never occurs without lymphatic spread first. Lesions that are on the side of the vulva will typically spread to the ipsilateral or same-sided lymph nodes, and that's important because millimeters and centimeters matter in vulvar cancer. A lesion that is considered lateral must fall with its most medial extent no closer than 2 centimeters to the midline. As soon as a lesion is within 2 centimeters of the midline, it's going to be thought of as a midline cancer and is going to have implications for the lymph node dissection of that patient. And that's really the big advance that I'm here to talk about at the end of the talk, which is coming soon so I can keep us on time. Approximately 10% of superficially invasive vulvar cancers, those between 1 and 3 millimeters, will have lymph node spread. And that's important because that cutoff of 1 millimeter and greater than a millimeter but less than 3 is important for the surgeon to know when deciding how and where to dissect lymph nodes. Other important high-risk factors for lymph node metastases include the presence of lymphovascular space invasion, the stage of the tumor, which I'm going to talk about next, and the depth of infiltration. Staging is now combined and is a hybrid of clinical staging and surgical staging, which has now only been cemented within the last 5 years. Before, we only used clinical staging, but now the addition of surgical staging to form a hybrid stage is really important for vulvar cancer. The shift was made because lymph node metastases is the single biggest prognostic factor for vulvar cancer. Tumor size, depth of invasion, and local extent are typically just measured on physical exam. You just put the patient into lithotomy, get out your ruler, and start to measure. Is the tumor greater than 2 centimeters, greater than 4 centimeters? How far into the vagina does it extend? How close to the midline is it? And millimeters and centimeters matter. In the office, centimeters matter, and when you don't know how big the tumor actually is, it's a really good idea to potentially get some imaging, most importantly, a pelvic MRI. Depth of invasion, which is really important when we get that biopsy back from our pathology colleagues, is measured from the closest dermal papillae to the tumor. And this is an important measurement, and this is how we come up with that more than 1 millimeter or less than 1 millimeter cutoff. So again, the closest dermal papillae to the cancer is measured, and the full depth of invasion of the deepest part of the tumor gives us the actual depth of invasion. And as you can see on a diagram, it's really easy to come up with. But when you're a pathologist, and this is why pathology is such an incredibly important specialty for surgeons, measuring that depth of invasion is key. Imaging studies can be used, and I've already mentioned MRIs, particularly if you don't know the extent of the tumor internally, because sometimes the tumors don't fungate outward, but they could grow inward. You measure the tumor and you think that you're dealing with a 2-centimeter tumor, but then you get an MRI and you realize that the tumor is actually 5 centimeters in size, but it's deeper in than you thought. So when the size of the tumor is in doubt, a pelvic MRI, the tumor is actually there on the inside of the vulva. This is a quite obese patient. What I could measure in the clinic was a certain size of the tumor superficially, but once I got the MRI, I realized that the tumor was actually much larger. In addition, palpation of the groin nodes is much more difficult actually in obese patients than it is in the axilla. So even in an obese patient, the axilla is somewhat relatively spared. However, as all human beings get larger and our BMIs increase, that crease between your groin and your pannus is very, very difficult to get at. And you're trying to assess in the clinic, are there any enlarged lymph nodes in this groin? And sometimes it can be really challenging. Therefore, getting an MRI to help you see what's going on with the lymph nodes is sometimes necessary, particularly in larger patients. The staging of vulvar cancer really all has to do with the size of the tumor and its proximity. So to really quickly run through it, 1A tumors are tumors that are less than 1 millimeter in depth. 1B tumors have a greater than millimeter depth of invasion. Stage 2 tumors are adjacent and growing into nearby structures. I'll talk about stage 3 on the next slide, which has all to do with the lymph nodes. And stage 4 tumors have gone distantly. All tumors that contain lymph node metastases, by definition, are deemed stage 3. So the stage 3 tumors all have lymph node metastases, and the cutoff there is actually 2 millimeters. Micrometastases are metastases that are 2 millimeters or less, and that's going to be the study that I'll talk about shortly to wrap up the talk. And macrometastases are any metastasis greater than 2 millimeters. So again, in a schematic form, central tumors or lateral tumors will go first to the superficial inguinal lymph nodes, from there to the deep, and then potentially onward to the pelvic nodes. Probably the biggest advance in the last 2 decades in the surgery of vulvar cancer is our ability to tailor the surgery to be less and less and less invasive. As you can see, with a midline tumor that is anterior, that patient is going to lose, most importantly, her clitoris. And that's a tremendously disfiguring and dysfunctional creating surgery. At all times, we would never want to have to cut off or remove the clitoris of a female patient. But if the cancer is midline and anterior, unfortunately, we don't have a way yet of sparing the clitoris and only removing the tumor. When the tumor is lateral, you can perform either a right or left hemivulvectomy, thankfully with clitoral sparing. And if the tumor is posterior and midline, you can again spare the clitoris and just do a posterior hemivulvectomy. The biggest advance, though, comes from the way we have evolved, and this evolution has only taken place within the last 20 years. We used to do these really large surgeries with these massive butterfly incisions that were going on still when I was a resident, and the vulvar excision would include the nodes in the groin all in one gigantic incision. And as the years have gone by, we have been able to tailor these incisions to be smaller and smaller and less disfiguring. And now we don't necessarily need to remove all the lymph nodes like we used to. We can find the sentinels. This is the consequence of removing groin nodes. And this is really the biggest advance. So much like lymphedema in the arm of breast cancer patients, which thankfully we see very rarely these days, removal of the groin nodes leads to lower extremity lymphedema. And you can see this very, very exaggerated version of lymphedema, but this is what many patients who had ipsilateral lymphadenectomy would end up with. And this is a lifelong condition with no cure. So now, to wrap up, we've been able to apply the same understanding and the same technology used in breast cancer to the vulva, thankfully. And from the tumor will drain to a sentinel lymph node, the gatekeeper lymph node. And from breast cancer, everybody here should know and is probably really acutely aware of the concept of sentinel lymph nodes. And from the sentinel, then the tumor will drain to other nodes. So there is truly, thankfully, this very particular drainage where the tumor will drain to the sentinel first. And this happens in the vulva. It happens, of course, where we discovered it, in the breast. It also happens in the cervix, and it happens in the endometrium. So we have been able, as gynecologic oncologists, to tailor our lymphadenectomies to smaller and smaller lymphadenectomies, removing less and less lymph nodes, creating less and less lymphedema. Sentinel lymph nodes are always formally evaluated, and 100% of sentinel lymph nodes lie over the femoral vessels in the anatomy pictures at the beginning of my slide. These observations have really important implications for how the surgeon is going to find and dissect the lymph nodes. So what do? The best technology so far is to inject the tumor and the periphery of the tumor with 2 different substances just prior to surgery. One is ICG technetium, which is a radioactive substance, and the second is just blue dye, and there are 2 different blue dyes on the market. The great thing about the technetium is that we can find it with a Geiger counter, which literally leads us to the sentinel, but we get much better pickup of the sentinel if we also inject the blue dye as well. The problem is that the technetium hangs around in the sentinel, but the blue dye does not. So it's a time-limited process where you got to get the dye in, get the patient on the table, and get down to the groin and find that sentinel lymph node. To wrap up, this is the biggest and hottest news, and I'm not going to bore you with all of the details of this study, but this study was published last year in the middle of COVID, and it is called the Groins V2 GOG 270 study, which was a multinational, multi-continental study that had been going on for a really long time in order to study this very rare cancer and figure out whether the use of sentinel lymph nodes would help figure out the patients who needed full lymphadenectomy or could be spared full lymphadenectomy and be treated with radiation. This is a bit busy slide, but I'll just read the purpose of the study and the conclusion so that you can get the gist of what we were able to accomplish with the Groins V study. The Groins V study investigated whether inguinal femoral radiotherapy or radiation to the groins is a safe alternative to a full lymph node dissection in vulvar cancer patients with a metastatic sentinel lymph node. So you're in the operating room, you find the sentinel, you send it to your pathologist, or you send it after the surgery, depending on what you have to do in the surgery, and the pathologist either tells you in the surgery or after that the sentinel was positive. Is it safe to then just give that patient radiation? Once you have a positive node, whether it's sentinel or not, you have to radiate that groin. But could you avoid a full lymphadenectomy, the disfiguring surgery that causes that massive edema? The conclusion of the study was that inguinofemoral radiotherapy is a safe alternative for inguinal femoral lymphadenectomy. It's fine to do radiation instead of the full lymphadenectomy in patients with sentinel lymph node micrometastases. So once the micrometastasis was less than 2 millimeters and the lymph node was positive, not taking out all of the nodes on that side and giving the patient radiation was fine, not having to subject the patient to the full lymphadenectomy. Eligibility for sentinel lymph node biopsy is still evolving and being studied. Among the experts in this field, most sentinel lymph node biopsies are offered to patients who meet these criteria. Their tumors are less than 4 centimeters in size. There is at least 1 millimeter depth of invasion. There are no known palpable or obviously enlarged lymph nodes. The disease is unifocal and just in one place, and the surgeon has sufficient expertise to know how to go about finding the sentinel. I'm proud to say that at the Miami Cancer Institute, we have those kinds of experts available to help patients with vulvar cancer. I'm not going to go through all of these slides. I'm just going to highlight just this one in order to wrap up, which says that when the sentinel lymph node is positive, the patient who had a micrometastasis less than 2 millimeters in size could be treated with just radiation, avoiding the need for completion lymphadenectomy and radiation both together. That's the point of the Groins V study. Last slide, the overall survival of vulvar cancer is not terrible, but it's not great. Stage 1 vulvar cancer has a 5-year overall survival of about 80%. Stage 2, where it has invaded nearby structures and is most likely in the lymph nodes, but not definitively in the lymph nodes, has a 58% or 60% survival rate. By the time the cancer gets to a sentinel lymph node and there is stage 3 disease, the overall survival is less than 50%. So this is still a difficult cancer to survive depending on stage. This is a beautiful Caymanian lady. This is our Nicola O'Sullivan. Nick, where are you? Nicola is the best way to get through to Baptist Health South Florida and to get to me. This is my email, and despite giving it out freely all the time, nobody ever emails me except Gilbertha. and David. But you're more than welcome to have my slides, send me any questions that you may have from today's talk. If you wish to refer a patient to me or anyone at the Miami Cancer Institute, this young lady is your best bet. That's her telephone number, and her email is insanely easy. It's Nicola, except the name, Nickola, Nicola O'Sullivan at baptisthealth.net. If you wish to just go straight to the website and avail of coordination of care yourself to come to Baptist in Miami, you can go to our international email address or just call Baptist Health International, which is available 24 hours a day, 7 days a week. And these are my three: having our continued love affair with 7 Mile Beach, BC. Thank you.
Thank Dr. Gatliff for that very informative presentation. And as a token, small token of our appreciation, I'd like to present you with something here. And in the interest of time, we are going to cut down the Q&A after the presentations very shortly. Not eliminate, don't go. We're going to cut it down significantly, so we're going to just allow 1 or 2 questions. So does anybody have any questions that they'd like to ask Dr. Gatliff?
Shocker.
Yes, Dr. Stone.
Wonderful talk. And I use eugenics, so that's how I stay so nice. My question is there any lifestyle conditions that raise a woman's risk of vulvar cancer? Are there any particular powders or ointments or lotions that maybe increase a woman or decrease a woman for the effect?
So great general question. And thankfully, David, super easy to answer. 2 things is what it comes down to. Smoking. Don't smoke. Don't smoke. I just got a middle finger. Number 1. Number 2, HPV. It's really about HPV. And HPV exists in the mind of all of us in healthcare because of cervical cancer, but it is highly related to vulvar cancer as well. So everything that you know about HPV, vaccination, number of sexual partners, age of early intercourse, promiscuity, no promiscuity, this, that, the other, all of those things become wrapped up into vulvar cancer as well, because 75% of vulvar cancers are squamous, and exposure to HPV is the causative agent. One more question. Banana. Go ahead. Great question. Is there like a pap smear of the vulva? There isn't. There just isn't. And the interesting thing is that the HPV virus gets into the mucosa of skin, but the vulva does not contain the junctional zone that the cervix does, which is the area that we pap and obtain cells from when we do a pap smear, right? So the vulva, unlike the cervix, doesn't have a zone that we can go pap. And we have not ever found it beneficial to pap or to scrape or to obtain cells from the vulva in order to screen for vulvar cancer. It really is about awareness. And this is why I say vulvar cancer is so tied into sexuality, because as people become older and they become less, not sexually active, just less sexually active, they're paying less attention to that area. And then in those postmenopausal, post-65 years, even more so. Yes, ma'am. We all missed out on it, yeah. So it's a great question. Currently, our initial indications for the vaccine started at the age of 26. It then went up to 35, and now I think the vaccine is up to 45. I can tell you something, that I don't have a problem giving the vaccine to any woman of any age. The question is am I going to get a health insurance company to agree to that? And I think it really depends on knowing your patient and knowing what their sexual history is and having a conversation with your patient. Because I have women all the time that come to me that are later in their sexual debut and they need the vaccine, right? The prevailing wisdom is that, of course, most women, most human beings by the age of 35 have been sufficiently exposed to HPV in order to have innate immunity. And of course, we're all now immunity experts, right? Right, we all understand immunity now in so many ways that nobody understood immunity before because of COVID. But the issue is that really and truly, most people by the age of 35 have seen HPV in their life and have developed their own immunity. But if I have a patient come to me and she's 37 and she's virginal and she's about to start having intercourse with a new partner, I'm going to give her the vaccine. Absolutely. Thank you.
Thank you again, Dr. Gatcliffe. I also want to mention now, just to acknowledge the Deputy Chair of the HSA Board, Ms. Joy Vernon, and the Chair of the Clinical Subcommittee of the Board, Dr. Luana Lecloy. So welcome to them as well. And moving right along, we are going on to our next presentation, which is extragenital multi-organ endometriosis by Dr. Stone, who's also no stranger to us at these conferences. Dr. Stone is a board-certified obstetrician gynecologist, surgeon, and an educator. He has over 25 years of experience and has delivered 6,000 babies. That's a lot of babies. And he is very highly skilled in minimally invasive gynecological surgeries and very active in numerous societies. He has performed and trained colleagues in advanced traditional laparoscopy, robotic-assisted laparoscopy, and operative hysteroscopy for numerous gynecological conditions. So without further ado, Dr. Stone.
Well, good morning, everyone, and welcome here. It's good to see faces, some with masks and some without. I want to thank Dr. Gatcliffe, Troy, for starting us off so well, and I think I'm going to continue the theme of using green. Green I always think of as fertility and growth, so a lot of my slides are going to have green, so bear with me. My talk is to make us think outside of the box, and in terms of the entity of endometriosis, and what we hope to do at the end is have us get a deeper appreciation for the fact that endometriosis is not just a condition that involves a couple of spots in some parts of the body, but how it can have a total body effect. And I hope to tap on your brains about looking at how this has a different impact than just having painful cramps or pain during intimacy. So without further ado, let's see if I can get going. So my objective is, of course, to understand endometriosis, lay the foundation for that. Let us have a deeper appreciation for me, or multi-organ endometriosis, and to consider ways to diagnose and treat me. So the definition of endometriosis is simply, it's an inflammatory condition that involves tissue that we would normally expect to be inside the lining of the womb, the endometrium, and finding it outside of that confine. So endometriosis is just that, tissue that's found in the wrong space. It is also important to understand the criteria of it being estrogen affected, and that estrogen can be the pump in the wrong way to the manifestations of endometriosis. So if we look here, this kind of gives us, an understanding of what we think of endometriosis when we think of it traditionally or inside the box, right, of the pelvis. We think of endometriosis involving areas on the lining of the uterus or perhaps on ligaments or the actual ovary inside or out, or the fallopian tube, and maybe involving some neighborhood outside surface of the intestines or the rectum or the bladder. And certainly we do know that does occur. And when we do a laparoscopy, that keyhole surgery that allows us to do a look-see into the window of our cavities inside of our abdomen and pelvis, what we can see is this. And what we're looking at is collections of endometriosis. This is endometrial glands and stroma that are encapsulated within an area, in this case more of the lining of the peritoneal cavity. And it's just sort of sandwiched in. Just imagine if you took some peanut butter or something like that and put it in a Ziploc bag, and you'd see it sort of sandwiched in those layers, and it's trapped. So when we think of endometriosis, think of the fact that there's this tissue that's very similar to the tissue that a woman may menstruate and release every month, but it cannot escape. So there is a real problem with that. And what I hope to explain to you is that that problem is not just local, but it's global, it's systemic. So we know that there are multifactorial effects that endometriosis has throughout the body, the intestines, the kidneys, the liver, the lungs, the brain. About 10% and maybe more of women have endometriosis on some level. We really don't know the full extent because not everyone knows they have endometriosis or not. About 50% of all women who have infertility issues can expect to have endometriosis on some level. And in fact, it's a very costly condition. And these are conservative numbers of 22 billion just within the United States. So let's look at the signs and symptoms of endometriosis. Pain. That could be the end and beginning of my description of it. It is pain. The pain can occur for a multitude of reasons and in a multitude of areas. It can certainly be looked at as the traditional pain that happens when a woman has her menstrual flow or just before she has her period come on, or it can be pain with women during sexual intercourse, particularly a deep penetration, because sometimes these nuggets of endometriosis can be found in areas near the back of the vagina or along the walls of the vagina and cause pain. But the pain can also be due to, or can cause pain to the areas of the bladder, or to the areas of the rectum or colon, and that's why you can get pain when you urinate or pain when you defecate. And of course, you can have pain in the abdomen if it's involving the intestines. It can be local or it can be global. It can be cyclical and it can be non-cyclical, meaning with respect to the menstrual flow. It can involve pain with women who have coinciding rectal bleeding and maybe involving the lining inside of the rectum. And of course, there can be pain with bleeding, and that can cause bloody urine. And then there's pain that can be involved with the thoracic area and can cause shoulder or chest pain. And then finally, there can be conditions where it's thoracic endometriosis, and you can have air get trapped into the wrong areas in the cavity of our lungs, or our pleura. And it can also have an impact on causing people to have blood when they cough. And of course, if it's trapped within an incision, there can be problems, and that can cause pain in a scar that has been placed from any number of procedures. So, other features to consider with endometriosis in general is that it can be responsible for infertility in itself. I won't touch much into that because that's another talk, and we're outside the box, if we will. But it can also cause fatigue, not just fatigue in dealing with the consequences of endometriosis in terms of the symptoms, but it can also be fatigue in a way in which it involves the certain cytokines and other chemicals that may actually lead to people feeling tired because it's affecting their brain or it's affecting their body in general. Because even though endometriosis is found in one neighborhood, the impact of it in terms of its release of the chemicals from the events of the endometriosis can be widespread. So it can cause fatigue. I put in here low body mass index. Well, low body mass index
doesn't obviously mean that every person who has endometriosis has a low BMI. I can be the first to attest that in fact, many of the women, or the majority of the women I see, don't have a low BMI, but it's relative. And if it's in the absence of other conditions like polycystic ovarian syndrome or other conditions that might lead to weight gain, you can see a pattern in that women who have more exclusively endometriosis may have a pattern where they seem to be thinner. And this becomes a sort of a double entendre, because now you're dealing with a person who looks thin, who doesn't have this weight issue, and you're saying, well, what's wrong with them? Why are they having these problems? They should be happy with the way they look. Well, that's another issue all to itself, but they should be appreciated that a person, even with a lower BMI, can have problems, and endometriosis could be one of them. When we, let's see if I've got, there you go. So when I talked, oh, sorry, going back the wrong way. There we go. So when we talk about psychological impacts from endometriosis, we should think about how it affects the quality of life. If patients are having pain and discomfort and having embarrassing moments with this pain and discomfort, it's going to interfere with them. It's going to interfere with the activities that they do, either at work or at play. It's going to have problems with causing interpersonal relationships, particularly adult relationships that involve intimacy. Patients may have pain, and then this is going to become a problem through that life of that relationship. And there's going to also obviously be anxiety and depression from all of that poor quality of life. But as we're going to touch on, it can actually be that the anxiety depression is organic. And I'll tell you what I mean by that. So systemic effects, low body mass index, what's that all about? Well, we do understand that endometriosis can have certain conditions where it actually works at levels outside of where that endometriosis is focused into other organs, like the liver. And it can actually alter the gene expression of these genes that really have an impact on us having sort of anorexic tendencies. So it's something to think about, that we may be stumbling upon the fact that endometriosis plumes or releases chemicals that we haven't quite elucidated that may actually result in impacts to other parts like the liver and have an effect on body mass index. And then there may actually be these microRNA. I think we've all learned about RNA from the last couple of years, but there may be mediated changes at fat cells in terms of their gene expression for metabolism. And so the fat cells may burn off quicker. There may be less body mass index in some patients. So systemic inflammation. Think of inflammation as the sort of architect for pain. Inflammation can be affected in endometriosis by this estrogen. This estrogen sort of is an elixir for pain with endometriosis. And in particular, you can have the release of prostaglandins, and particularly prostaglandin E2, which can have contractile and inflammatory implications that can cause pain, not just locally, but spread out through other parts of the body. You can have this aberrant microRNA expression that can also lead to inflammatory conditions beyond just the local area of the endometriosis. There's also not just local, but systemic effects of the immune cell function that may create conditions of release of chemicals that cause more inflammation. And of course, there can be increased production of cytokines themselves, local and systemically, and then that releases out into the bloodstream and has effects in other parts of the body. So pain can really have a bad neighbor and partner with this inflammation. So mood disorders, we talk about how it can affect a woman who has endometriosis because of all that's happening to her from the symptoms that she's dealing with in pain. But we now are looking at the fact that there may be direct implications on centers of the brain, and these areas that may have expressions for anxiety and depression are associated with these regions of the brain that may be manifest because there's chemical release from endometriosis that's affecting it. So it's not just the events of the pain, but it's actually the chemicals that are causing problems in the brain and causing these moods to occur. I think it's also important to note that women who have endometriosis oftentimes have a decreased volume in the areas of the brain that are associated with the emotion and sensory nerve processing. So with diagnosis of endometriosis, we really look at two pillars. Traditionally, we've always said, we don't know we have endometriosis until we got tissue. We have to look inside, grab the tissue, send it to a pathologist, and you have endometriosis. That's a rather old and gold standard measure of saying that you have endometriosis. But that's just not fair, because not everyone's going to have a laparoscopy, whether they're not a candidate, or there's maybe a thought that they're too young, or they just don't want to take the chance of the risks of surgery, and that's legitimate. But we shouldn't deny the fact that endometriosis could be there whether we see it or not. And so it's really important to understand that we should embrace the idea that endometriosis can be diagnosed in the absence of a laparoscopy. And I'll be the first to admit that I have been prejudiced forever in thinking that, nope, until I see it, you don't have it. That's not fair, and it's no longer necessary in terms of qualifying for a person to have clinically suspected endometriosis and act upon it. So I think that if there's one message I want to send out here is don't necessarily feel that we have to have a pathologic diagnosis to make the diagnosis. The point that I want to mention is with clinical diagnosis, which now I want to tie more over to, can be incorporating complete exam from head to toe, listening to the patient, not just the physical, but the history. And the thing we want to pick up is the simple question: are you noticing something that's happening, maybe pain or otherwise, that's happening around a certain time in your cycle? And just at that point, shut up and listen. And you might actually learn something. You might find out that, yes, I have pain, and I don't know why. I have it up here. Or I have pain right in this area near my incision where I had a C-section. Or I've got pain, and sometimes I have this cough, and I don't know why I cough while I'm having my menstrual flow or right before it. These could all be indications that there's endometriosis outside the box. So it's important to understand and appreciate. So this is the traditional laparoscopy picture. You're inflating the air or gas or CO2 into the peritoneal cavity, and that allows us to look at things really well, sort of like an inflatable tent, and we can see the structures real well. And when we do this, what we're going to look at is sometimes we're going to see structures like this here. This is a powder burn, that lesion of endometriosis that's sitting on top of the uterus. And that's sort of a traditional introduction to endometriosis 101. You can then cut out that segment of tissue, and if you resect all the tissue, that's not only going to be diagnostic if you find the tissue pathology, but it's going to be curative because it's no longer there. It's out of that person's body, and it's in a pickle jar in the pathology department. So that can be curative, hallelujah. But obviously, not all endometriosis can go out that way so easily. There can be sometimes endometriosis found encapsulated within or on the outer surfaces of the ovary, and that can cause pain and discomfort, and until you remove that tissue, you're going to have problems with it. And it also means that that endometrial tissue, or endometriosis, I should say, could have an impact on the functional ovarian tissue for fertility. So removing it is important, but how you remove it can be equally important. If you remove it in a poor fashion, where you're not removing the tissue gently and carefully, you can destroy all of those vital tissues that are important for fertility that Dr. Joseph Davis spends his life now trying to help cultivate. So we don't want to mess with those precious eggs. And so how we remove it out of the ovaries really matters. This is interesting because this is not anywhere inside the box, but this is actually at a level near the diaphragm. And so you can see this collection here, and that could have been from a patient who is having left upper quadrant pain, and you can't explain it why, but the key punchline is that it happens during the time of their cycle menstrual flow. This is another area. This is involving the small intestines on the serosal surface, and you can see how it's involving a sort of knuckle of endometrial, or correction, intestinal tissue, or the intestines, and that can cause pain. It can also lead to constipation and dysfunction because there could be associated scar tissue and other features that are interfering with the normal digestive function of that tissue. This here is actually inside the rectum, and what we're looking at is an area where endometriosis is going to plume at certain times of the cycle and cause bleeding that may be also associated with pain in the rectum. And then this is just a smattering of some endometriosis along the surface of the peritoneum. And this was one that's just showing that chocolate cyst, that large endometrioma that's involving an ovary. So it can be anywhere, but let's talk about why it's a challenge to pick up endometriosis. Well, besides the fact that I told you endometriosis traditionally is just thought to be a tissue diagnosis that you have to have with a laparoscopy, if that's not enough to delay the diagnosis, there are other stumbling blocks that can be in play. Sometimes it's because we're not familiar with that territory. As healthcare providers, we often play to our strengths and we run from our weaknesses. If we're not familiar with a condition like endometriosis, we don't think of it as much in our toolbox, and we don't think about it when that patient's in front of us. We may not have that same passion or drive or just that same knowledge base to know how to act on it. I am going to say that we are extremely blessed on this island because I have found the primary care physicians on this island to be exceptional in their ability to identify or even suspect endometriosis, and I have been incredibly impressed with patients who have been referred to me who had that suspicion and they were spot on. So I think that in this environment, in this jurisdiction, we're doing a very good job. But in general, it can sometimes be an unawareness of that primary care provider that causes problems. But it's also the fact that these are non-specific symptoms that can sometimes afflict women. So it's not like you can just put your finger on it and say, ah, that's endometriosis all the time. And that becomes the curse. If it doesn't fit the box, then it must not be endometriosis. And that works against that diagnosis when it's beyond the areas of the pelvis. We also know that there's a subjectivity to menstrual changes. And what I mean by that is some women just don't think that's much of a big deal, and so psychologically they don't think it's a deal to bring up with the doctor or the provider to execute onto it. And then lastly, social norms. I think this is important to understand, that in social norms, we always are cognizant of the fact that we are influenced by the people that are closest to us. If I'm a woman and I have menstrual flows that are painful, if my sister or my mother or my best friend or some other member tells me, you know, girl, that's just the way those are, don't fuss about it, this is the way it is, that has a huge impact on whether that person's going to even be forthcoming the time they see the doctor. Why do I even want to bother the doctor on something that I know is just supposed to happen? And so, forgive me for sounding like I'm mansplaining, but I'm mansplaining. It's true. I mean, I just really feel bad for so many women who have held it on for so long. And I really appreciate when they confess the fact that they're having these problems, and we can try to do things to help them. So, what causes endometriosis? Well, historically, there was the Samson theory, okay? So, once again, a man figuring out what's going on with women. Retrograde menstruation simply means that when a woman has a menstrual flow, besides the menstrual flow happening out through the vagina and into the outside world, and that's a period, there is the idea and the reality that some of that menstruation actually goes out through the fallopian tubes. And when that happens, it's trapped within the areas of the peritoneal cavity, or at least the pelvic cavity. And that makes some sense to think that can happen, and there were some really amazing studies done with animals that sort of reproduce this notion, but it doesn't fit the bill when it's outside the box. What does that explain, or how does that explain or account for endometriosis that's found on the diaphragm, or found inside the lung, or found inside the nose, or any other part of the body? So clearly it can't be just that. And maybe that's just one feature, but maybe it's because we, when we're born, all have these stem cells, these cells that are incredibly strong and we still carry, but at a much smaller degree, that have the potential to express themselves into other things than the tissue that they're involved in, the neighborhood that they are. They can become outliers or ectopic tissue. And that's what I think is happening with patients who have extra genital or extra pelvic endometriosis. And of course, that estrogen exposure, which is systemic, can lead to the worsening of that condition. So when we talked about endometriosis, one of the areas we want to think about endometriosis being involved with outside the box is the abdominal wall. And the most common area is the area of an incision after a cesarean delivery. And we'll talk about that in a minute. But other incisions or procedures can also be involved. Interesting to note, the mean time from the time that that surgery was done to the time that it's expressing itself could be as much as 3 to 4 years. There we go. Let's see if I can get it. There we are. Most common site is from a C-section scar. And if you look at the numbers, it's saying about 1% of all cesarean deliveries, and you go, nah, that's not a lot, 1.5. But consider the fact that of using our environment from last year. We had roughly 850 deliveries between the two departments of both HSA and Doctors Hospital. And you could argue that maybe at least 30 to up to 50% of those were C-sections. I'll let you do the math. That's not just one event that might be happening every couple of years, but there literally could be dozens every year patients who actually are developing endometriosis, and we need to be aware of that potential and be sensitive to it. Umbilical involvement is really rare, but as we do more laparoscopic procedures, particularly for procedures, we're doing laparoscopy because a person has pelvic pain, and we look inside and maybe we find endometriosis, or maybe we don't. Doesn't mean that it couldn't be literally at the site where we went through with our trocar and found to look for endometriosis. And it doesn't mean that in the process of dealing with the endometriosis that we're looking for, that it may not find itself embedded within that scar that we made in the belly button area, or that it just happened to be there in the first place. Episiotomy. Many women know about episiotomy. It scares the crap out of them, scares the crap out of me. I don't want to do an episiotomy, but it's true that in times when we do extend that incision in the vulva to help a baby be delivered, there is the possibility of transfer or the aggravation of endometriosis in that area. This is an example of endometriosis really small in a lady who had endometriosis at an incision from when she had her cesarean delivery, and it took about 2 to 3 years. I think it was, in this case, 5 years before she actually had the diagnosis made. It was a very simple procedure. We didn't have to do a deep dissection. We just removed that incision area, and it came back with endometriosis, and she felt great, and she got a cleaner scar. This is more dramatic, but nonetheless, this is endometriosis, and if you don't remove it, it's going to continue to have problems. This is another one that's kind of subtle, but if you look right at the edge here, there's a line that's from a actual hysterectomy, and this patient had right in the lateral wall area or lateral recesses a bump that represented endometriosis. So in imaging endometriosis, you can look at 3 avenues. You can either do an ultrasound, a CAT scan, or an MRI. What I will tell you is, and I apologize because it comes out so bright, I think you might want to look at this level here, but when we think of doing a transabdominal sonogram, we want to think about that being usually the first imaging that we try to do. And it's one that's usually more cost-effective to do to start off with. And because you have the technician doing it, they can be more dynamic in their expression. You think about it with a CAT scan or an MRI, the patient's still and you're getting a still image. But with ultrasound, there's interplay between the technician and the patient, and they can get feedback during that exam. So it can be very powerful to help understand what is there. Let's see if I can go here. This is an example of finding the endometriosis within the subcutaneous layer, and just above where the area here is the muscular layer, or not muscular, a subcutaneous layer, muscular layer, and then right under here would be where you're going into the peritoneal cavity. But this was a endometrioma or a tumor of endometriosis that was found within the scar itself. In CAT scans, we think of that being a little more sophisticated. You're going to see better tissue planes in CAT scans because of the way the imaging is done. And we recognize with contrast, it may even be better at helping us delineate where the endometriosis or that focus of tissue is and where the normal tissue is. And sorry about this, I'm going to have to figure out where I'm going. This here is actually where that endometrioma is from the C-section scar. This is just bone from the pelvis. This is the vertebral area. So this is a CT, and this is what's helping us pick up what is that, and that's actually some endometriosis. MRI, last but not least, is the best of the imaging products that we have because it's so good at being able to clearly delineate the different tissues, structures, and densities. And when we look at on MRI, you can see very clearly the image that is of concern. And so MRI is really good at being able to focus on where are my tissue planes, where am I going to be best at removing this tissue completely and solely. Because the name of the game is if you see endometriosis in certain areas, removing it completely can have a huge impact on whether you still have residual endometriosis that causes problems afterwards. So let's get into some area of the thorax. There's a condition or syndrome called TES, which is thoracic endometriosis syndrome. And what we recognize is that it's a diagnosis that's based on clinical findings, not a laparoscopy. We recognize that it's cyclical or catamenial patterns of pain or expression. And what we typically see that it's occurring 24 to 72 hours prior to the onset of the menstrual flow. So the endometrial tissue, this endometriosis, is actually sort of blooming in anticipation of its release, and yet it can't go anywhere. So this is where the problem lies. We can delineate this form of endometriosis in the areas of the chest or the thoracic cavity into two chambers. One that can involve the lining, which is the pleura, and one that involves the actual organic process, the tissue or the parenchyma of the lung, or lymph nodes that are involved with it. This is just going to give us a schematic to look here in this box to see that we're seeing the area where this is the actual cavity, and these layers, these sort of casings that involve both the casing of the lung and then the casing of the lining that's containing the lung can be involved with endometriosis, and that can lead to the problems and expressions that we see with thoracic endometriosis. And so with catamenial or cyclical pneumothorax is a potential condition that can be involving endometriosis. We want to see it happen in a pattern of 2 or more. We can see that it mainly involves the right side in terms of the right lung or the right thoracic area. Your symptoms are generally going to be localized, and you can use laparoscopy if it's involving the diaphragm. If it's involving the tissue actually in the lung or in the area of the thorax, you're going to have a harder time using a laparoscope for that, but you can do the imaging to help you identify it. So the syndrome, by definition, has been expressed as a clinical finding that has cyclicity to it with the symptoms that we can have associated with it. And 90% of the symptoms are going to happen on the right side, and 90% of the time, it's going to be pain that's the symptom that you're having. So in the diagnosis of it, you can diagnose this with the clinical findings of pain, shoulder pain that's happening cyclically, or coughs, sometimes with even blood that's being released, or hemoptysis. Sometimes you'll find enlarged nodes with the imaging that you do. MRI is a superior imaging center or imaging study that will help us better be confident in the identity of the endometriosis, and ultimately confirmation of the presence of it with tissue confirmation can be helpful. But now we've done our diagnosis, let's get on to treatments. boils down to the fact that in the end, with extraperitoneal or extrapelvic, or extragenital endometriosis, removing and resecting it is not only diagnostic but curative. And so in most cases, when it's possible, remove that tissue completely. It has a relatively low recurrence rate with the abdominal wall, and oftentimes with the abdominal wall, it's very localized and you can remove it with good tissue resection and be able to get that tissue. It's diagnostic and curative. At the same time, we also need to think about the possibility after the surgery of long-term medical therapies and a new emerging technology using ultrasound technology has come out. It's still in its early stages, but there's some promising data that's looking at how high-frequency ultrasound, it's not your typical ultrasound that you do to look at how the baby's doing or doing other imaging. It's a high frequency that can actually destroy that tissue where it stays. Surgical treatment is always recommended, particularly if the patient's having pain. So if the patient's having no pain and it's asymptomatic, you can question whether you need to go in there and take tissue. But the person's having pain, you need to get rid of it. Consider the excision instead of just ablation or destroying it using either diathermy or what have you, because that can lead to scar. And removing the tissue completely gives us the opportunity to have removed all of that producing endometriosis pain. And that leads us to the next thing. As Dr. Gatcliffe mentioned, sometimes we're just scratching the surface when we do with pathology. Be mindful of the potential of there being this deeper infiltrating endometriosis. So it's not just what we see on that surface, but what lies beneath that. So that's why imaging can be helpful to let us know, are we just dealing with surface endometriosis, or are we dealing with something that's deeper? Multidisciplinary mindset. If I'm going to surgery with a suspicion of a patient that has this thoracic or diaphragmatic involvement or abdominal involvement, I would be best serving this patient if I go in with a team that is experienced not just in the areas of the pelvis and structures of thereof, but also experienced in the areas of the abdominal cavity that involve the intestines, removing tissue, maybe even doing a partial resection or a discoid resection of tissue on the small or large intestines or on the rectum. Or if we are dealing with involvements of the thoracic area, a thoracic surgeon. And after the procedure is done, think about hormone treatment. When we think of long-term medical treatment, we do think of three things. Pain relief, principal piece to the pain relief will be with NSAIDs. We think of hormone therapy being our friend, and also aromatase inhibitors, not by themselves, but in conjunction with the other therapies that we'll mention. NSAIDs, or nonsteroidal anti-inflammatory drugs, are best used when they're preemptive. If they're laying into the body, or you're taking the tissue, or taking the account that the pain relief is wanting to be maximized, you want to have it on board about 2 to 3 days before the onset of the pain that you're experiencing. We need to consider about side effects and contraindications and drug interactions, and it's, again, an adjuvant therapy. So these are some of the major players: naproxen, Ponstan, which is methylmedic acid, ibuprofen or Motrin, Toradol, ketorolac, or Celebrex. And in general, when we think of hormone therapies, we think of traditionally birth control pills, but now we need to call them hormone therapies for those who are sensitive about using contraceptive labeling. It can either be oral, it can be the vaginal ring, which we use NuvaRing, or it can be the transdermal patch. Remember, this is not going to just have an impact on the pelvis, but these expressions of these therapies can help extra or genital endometriosis. For those patients who really need to be more attentive to the idea of eliminating the estrogen component in their combined therapy, because that's what combined therapy is, estrogen, progesterone, you can look at just using exclusively progestin. And we can also be looking at certain agents that work directly with an area called gonadotropin-releasing hormone, and I'll talk about that in a minute. This, by the way, are some of the ones that we use oftentimes, and I made the mention to say, remember add-back therapy. Some of these medicines that involve GnRH agonists or antagonists are so strong that they're going to make the woman feel like they're going through menopause. So you may need to give back a little exogenous estrogen and or progesterone to ease off those symptoms. So I'm just going to take a moment to explain. You have two headquarters in your brain or in your head, the hypothalamus and the pituitary, that are headquarters that have an impact on the ovaries. And of course, that then entails the ovaries releasing estrogen and progesterone. But you can give agonists, which actually in some ways mimic the natural gonadotropin-releasing hormone. And what it does initially is it creates more of a surge of signal to the pituitary to actually have more of a surge of these hormones that are going to have an impact in making more estrogen and progesterone. But eventually what happens is those signals from estrogen and progesterone really knock down the we call negative feedback inhibition. It actually knocks down eventually what the hypothalamus is going to express, what the pituitary is going to express, and it's going to cause suppression to the ovaries. So that's how we eventually get, when we use Lupron and other such products, Zoladex, to a point where the person is actually getting into almost like a menopausal state or a hypoestrogen state. But with the newer emerging brand of GnRH or gonadotropin-releasing hormones, what you're getting is an antagonist. So you're immediately getting something that's working against what these gonadotropin-releasing hormones doing from the hypothalamus to the pituitary. So you get a more smooth transition where you're automatically not having to go through that surge and maybe a surge of those symptoms before it starts to extinguish. You get to go directly into that extinguishing phase. And so in both those types of therapies, you need to think about how much of an impact it's going to have on estrogen, progesterone in general, and too much impact might result in these hot flushes, mood swings, insomnia, and so forth. And so you really want to be mindful of maybe add-back therapy. So just a couple more slides. Aromatase inhibitor, or AI. This is a little newer technology or newer therapy that should not be used alone. It's typically used as an adjunct to existing technology or existing therapies like the NSAIDs and the hormone therapies. But the idea is that there's another reservoir of estrogen that's being produced in the body, and it's being produced in the adipose cells, in the fat cells. Well, if we're dealing with the ovary and taking care and suppressing that, in most women, up to 50% of their estrogen is coming out of these areas beyond the ovaries. So we need to think outside that box and think about how sometimes an AI can be helpful because it's going to help cut down the production of estrogen in those areas in the fat cells. And so now you get sort of both houses covered, and that can lead to great suppression of those endometriotic cells, which are so sensitive to estrogen, and therefore extinguish them. Finally, we would be remiss not to include non-medical therapies that can be helpful for women who have endometriosis, regardless of where the endometriotic tissue is. We do see a relationship between endometriosis expression and the presence or reduction or lower levels of omega-3 fatty acids, so supplements will be helpful. Vitamin D supplements can be helpful in a variety of ways, and we're seeing promising data that shows that vitamin D supplementation may lead to less expression of endometriosis in terms of the symptomatology. It also shows that in women who have endometriosis, there is a pattern where they may have lower intake of animal protein, they may have lower vitamin C and B12 levels and magnesium levels. And these same patients may have a higher prevalence of food intolerances. And so it's a good idea to consider in some patients the teaming up with a nutritionist in their help. Finally, we should always consider the fact that other therapies have been around since 2,000 to 3,000 years before Jesus walked the earth. And that's talking about traditional Chinese medicine and acupuncture therapy. I almost feel embarrassed when we think of us being the traditional forms of medicine because we're really the juniors on the block. But there is certainly good evidence in some cases where acupuncture therapy, in particular with Chinese traditional medicine, can be helpful in helping patients who have pain in areas both within the box and outside the box. And of course, the other therapies should be recognized and respected as well. So in summary, I just want you to think of me, and that's the cases that oftentimes have cyclical symptoms, but not always. We want to consider that imaging options for affirming the condition. We want to think about the fact that when it's possible, removing the tissue is our best way of getting rid of endometriosis, but it's not the only way to address endometriosis. Think of that multidisciplinary approach, and of course, think of the hormone therapies in conjunction with other therapies. And remember, as a team, we're better at working at endometriosis. So thank you so much.
Thank you, Dr. Stone, for such an excellent presentation. And please accept a small token of our appreciation for your participation in our conference. And don't go away. We're going to take 2 questions from the audience. And okay, so 1 and 2. And just hang on, please, for the mic to come to you, just because online the people can't hear if there's no mic. Yeah.
It's on now? Okay. Thank you, Dr. Stone, for a great presentation. I would just like to say, in my 20 years of practicing medicine, I have never been able to wrap my head around endometriosis. It's such a bizarre condition. The fact that you can get ectopic deposits of endometrium in the lung, on the diaphragm, on the intestines, I still don't get it. Thank you for a great presentation, but really what I want to ask is, do we actually know what causes endometriosis? I was wondering if there are any, schools of thought that this could be like an autoimmune condition, because I see some similarities with things like psoriasis, where you can get psoriasis in scars, and it just doesn't make sense to me. And I just wonder if that's because we actually don't know what causes it. We're treating the symptoms, we have some understanding of the processes, but do we actually know what is the etiology of this condition? Please.
Great question. Answer, no. The truth is that we feel we're getting closer to the idea that we recognize that stem cells, which are cells that have the potential to express themselves in a variety of tissue forms, are probably nestled and given the wrong information for some reason to now develop into endometriosis. We do know that once you remove that tissue can't come and get you in the night anymore. And that is the problem, because you don't always find the endometriosis that you're looking for. And I know I didn't spend a lot of time on that, but that is sometimes a very frustrating feeling, to look inside the cavity and not find the endometriosis that you just knew was there. And it's partly because it may be laying there in front of you, invisible, meaning it's diffused in a way that's sort of microscopic, and until we get X-ray microscopic vision, we're gonna miss it even in cases that we just knew was gonna be there, and we look inside and we don't see those really gorgeous, obvious endometriotic lesions. So to answer your question, no, we don't. We're still, the more you learn, the more you realize how little you know.
Yeah. On? Yes. Thanks, Dr. Stone. Yeah, we were always taught that it was the great mimicker, right? So if you didn't know what something was, I mean, endometriosis should always be in the background because it floats around everything, and it should be in your differential for a lot of, certainly pelvic pain or anything like that. I remember seeing recurrent epistaxis in a lady and only realizing after about a year that she had, she had endometriosis in her nasal cavity. I wonder how often, have you seen it in sinus? I mean, ENT people see it in sinuses. And the last question is, when you resect endometriosis, is there not really a danger that it actually comes back in the same place again? I mean, how deep do you have to go? And obviously you're causing more damage the deeper you're going, because, obviously surgery is is a much more involved procedure than treating it medically.
Thank you for that question, or two questions. The first is, yes, there has been documented evidence of endometriosis seen in the sinuses. I have not made that diagnosis. I have heard of patients, there's sort of urban legends of people who had this bleeding in their bloody noses that came around the time of their period, and they ended up finding the diagnosis. But with regards to resection, you're absolutely right. You need to be very meticulous in your dissection. And sometimes endometriosis is just the tip, it's like the tip of the iceberg. You're seeing it maybe a little bit on the surface, but it can be deeper in. And that's why it's so important that if you're having endometriosis or surgery for endometriosis, that the person be very skilled in knowing the anatomy and feel comfortable with dissection, 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 dissection. I know Dr. Gatcliffe is very astute on doing that, particularly with robotic surgery and how we can have that advancement using laparoscopic technologies to our nth degree. But if you get good tissue dissection and know where you are in the anatomy, you can get all of that tissue out, and it's the key. Removing all that tissue is the key to getting rid of it. Sometimes there's going to be adjacent residual tissue that actually causes some more problems at the same site, but the data is there. When you do very good tissue dissection, remove all that visible endometriosis, that patient's likely going to feel much, much better. Other question?
Yeah, not just so much a question. Thanks, David. I was texting with Gilbertha and some of the other folks in the audience. Is Elagolix, is Orlissa here? It is?
Yes, it is.
Yeah.
I've got a couple patients on that right now.
Yeah, so I just really wanted to, full disclosure, I don't speak for the Speakers Bureau of AbbVie, and I have no investments, but for me, I'll tell you, along with cancer surgery, I do a tremendous amount of endometriosis surgery, and I just have to say that, I'm hopeful that Orlissa might actually put me out of business in that regard. For me, it has really been a huge change in the paradigm. And you had it on your slide, but I just really wanted people in the audience to know about Orlissa or Elagolix, because the alternative was Depolupron. And Depolupron was, once you put it in, it's in there for a month or 3 months and you can't take it out. Orlissa has really changed that, because Orlissa is an oral, right? An oral antagonist, a GnRH antagonist. If the patient doesn't like the side effects, they can stop. Whereas I tell patients, you put in the shot, you're on the train. And I've had in my practice really, really amazing results with Orlissa. So Diana said she didn't know, but Orlissa is here. It can be prescribed.
Yes, it is. And in fact, I can't agree with you more, Dr. Gatcliffe. Orlissa has been a game changer for many patients who felt that they had to be beholden to a more severe expression of GnRH manipulation. And you've said it and hit the nail on the head. So I agree with you. And just remembering, too, that it's a combination of things. It's not just the Orlissa or the Elagolix. It's also sometimes, even in those cases, giving a little bit of add-back therapy. But I actually find that those patients are far more tolerable for the side effects of Elagolix than they are with the traditional agonists that we talked about, like Lupron and Zoladex. So that's absolutely right.
Thank you again, Dr. Stone. So we're going to move on to our next presentation, which is done by one of our own at HSA, breast cancer conditions in pregnancy. Dr. Omar Felix, who is one of our general surgeons, was born and raised in Kingston, Jamaica. He completed his training in general surgery, began it at SUNY Downstate, but completed it at the University of the West Indies in Jamaica in 2011. He is a fellow of the American College of Surgeons and has a keen interest in anaplastic breast surgery, minimally invasive surgery, among other things. He has worked at the HSA, I believe it's since 2017, in the general surgery department, so welcome him.
Okay, so those were two tough acts to follow, but I guess with that being said, I'll try. Good morning, beautiful Cayman people. All right. Okay, so good morning, everyone. All right. So today I'm going to talk to you about breast conditions in pregnancy. So this is a very broad topic. Every aspect of it and every slide that I'm going to present, you could easily have its own talk about each of those topics. So I'm going to try and hone in and not get bogged down with everything. All right. So during pregnancy, there's a lot of physiological changes that take place in all parts of the body. We're going to focus on the breast in this one. And if you can see here, all right, the breast is basically composed of skin, fat, basically 15 to 20 lobules and ducts. And essentially, due to the changes, due to the influence of hormones, right, estrogen, progesterone, prolactin, there's a number of changes that take place in pregnancy. There's vascular hyperplasia, proliferation of the lobules, ductal proliferation, the alveolar cells produce colostrum. So in all these changes, the woman starts to detect these changes from early in pregnancy and throughout. So there will be a feeling of fullness or tingling. All right, there will be breast tenderness, the breast size increases as you get all this development, under the influence of all these hormones. The areola becomes larger, about 3.5 centimeters to about 5 centimeters in size, and becomes darker. And as you can see here, the Montgomery glands become more pronounced and larger, right? And then the veins become more prominent on the breast. These large blue veins start to become more noticeable. And as the body prepares itself for breastfeeding, there are essentially about 3 stages of lactation. There's lactogenesis 1, where the foremilk and the hind milk is produced due to progesterone. There's lactogenesis 2, where there's a drastic reduction in the progesterone levels and then an increase in the prolactin levels, and then which starts to synthesize the lactose and the protein. And then you have lactogenesis 3, when the breast milk is actually secreted by the oxytocin and the neuroendocrine interactions, and there's a stimulation from the suckling of the baby during breastfeeding. So again, this is a whole talk by itself, but we just want to move through to tell you about the different physiological changes that take place. So here in the breast, you can see that there's becoming enlargement of the glandular tissue, and the milk is being produced. So as we move forward, the breast conditions in pregnancy. Essentially, a pregnancy-related disorder is defined when a diagnosis is made either during pregnancy, during lactation, or within 1 year postpartum. They can be benign or malignant. The benign conditions, right, can be due to physiological change, as I discussed earlier, where there is gravid breast hypertrophy. There can be gestational and secretory hyperplasia, lactational bloody nipple discharge, galactocele. The condition could be due to inflammatory and infectious conditions, such as puerperal mastitis or postpartum mastitis, breast abscess, idiopathic granulomatous mastitis, IgM, and also tumors such as fibroadenoma or lactating adenoma can present. So, gravid breast hypertrophy, it's a rare condition of unknown etiology. We're not sure what the cause is. It's also known as gigantomastia of pregnancy. It's more common in Caucasians. As you can see here, this is a person of African descent. The breast can enlarge to a very large size and become very, disfiguring and uncomfortable for the patient. But despite, in addition to that, it may actually progress to necrosis of the breast. And if that happens extensively, they can become septic and even be fatal. All right. So luckily, in most cases, the hypertrophied breasts do recede to the previous volume in the immediate postpartum period. However, they do, if someone is inflicted with this condition, in subsequent pregnancies, it can recur and most likely will recur. All right. So because of this risk of skin necrosis and necrosis of the breast, it's very important that there is good skin hygiene. It's usual, the condition is usually self-limiting, but it's important for them to have proper bra support. And again, as I said, good skin hygiene, because if you do get necrosis, that can lead to sepsis and become fatal. Bromocriptine, which is a dopamine agonist, has been shown with variable results to reduce the size of the hypertrophy. So it's considered first-line medical treatment before you move on to any other surgical treatment. The way the bromocriptine worked is that because it's a dopamine agonist, it's thought to prevent the production of prolactin, which will cause all of these engorgement of the breast, and so there can be some shrinkage with the use of bromocriptine. However, in some cases, there can be severe intractable pain, which is not resolving with any medical treatment or any conservative treatment. There can be infection and sepsis from the extensive necrosis of the breast due to the size's rapid enlargement. It outgrows its blood supply. In that case, you may need operative intervention. The main operations that are available for this would be a bilateral reduction mammoplasty. In this operation, though, where you're basically doing surgery to reduce the size of the breast, recurrence is possible because you are leaving breast tissue, which can then get engorged, and you'll have recurrence. The best chance of avoiding recurrence, where you're removing all of the breast tissue, is to do a bilateral mastectomy, and of course, with reconstruction, either immediate reconstruction or delayed reconstruction. And in some cases, depending, some women will say, you know what, reconstruction is too big a surgery. I'm good. Just remove them. I'm done. All right. But standard of care would be a bilateral mastectomy with reconstruction. So a bilateral reduction mammoplasty, there are different methods in terms of this type of skin incisions that's done and the way it's done. But essentially, you remove some of the breast tissue to reduce the pain and the risk of necrosis and skin issues, and then all of the other symptoms that go along with it. But as I said before, there's a very high risk of recurrence because you're leaving breast tissue. The alternative would be a bilateral mastectomy with reconstruction. The options for reconstruction could be implants, or it could be flaps, like a tram flap or a latissimus dorsi flap. But it depends on the body type and on the patient's desire and the skill set of the surgeon. So historically, there's some other examples of gravid breast hypertrophy. No, these patients were not done by Dr. Miami. This is actually a condition. But luckily, in most cases, it can be, this will resolve after the delivery. In the cases that it doesn't resolve, then again, you may need to do either medical therapy or surgery. So gestational and secretory hyperplasia, I'm just going to go briefly through this because this is basically microcalcifications on a mammogram, and it can be either due to the gestational hyperplasia, which is associated with pregnancy, and secretory hyperplasia associated with breastfeeding, in where basically the tissue becomes hyperplastic, as the name suggests, and it's usually round and focal, but it may be diffuse in distribution. Only really mention this to say that because of the microcalcifications that form, they can mislead you to think that there's suspicious microcalcifications that may result in unwarranted biopsies or confusion and diagnostic dilemmas. So with experienced radiologists that study breast images regularly, they may be able to avoid unnecessary biopsies. But if there's any doubt, it's better to do the biopsies just to make sure that there's no malignancy there. Lactational bloody nipple discharge. So essentially, any woman can have a nipple discharge at any time, and it can be bloody or it can be normal colored. It doesn't automatically mean that there is a breast cancer or anything malignant there, but about 20% of nipple discharges will be bloody during pregnancy, and another 15% of all nipple discharges will be bloody during lactation, right? It usually occurs without any clinically significant lesions, so it's not. It mostly causes concern and worry, but there's usually no malignancy there or any actual lesion causing it. So that's just most times you can reassure the patient. However, and it's reasonable to observe these nipple discharges until the end of the pregnancy and then fully work up the patient at that time. But if there is any reason at all or any concern or even clinically or that there is any lesion there, it should be confirmed with radiology just to make sure that there's no malignant lesions there, right? And it usually stops with breastfeeding. But as you can see here, this is what bloody colostrum. So it can either become blood in the milk and the colostrum, or there can actually be a discharge spontaneously. Another condition is a galactocele, which essentially is that the milk ducts become blocked with insipitated milk and start to develop into this large cyst, right? It's mostly detected a few weeks after the cessation of breastfeeding when the milk becomes stagnant and starts to collect. And it presents as a painless mass. And it's thought to have been formed basically by wall fibrosis because of an inflammatory response in the lactiferous ducts. So a little bit of fluid seeps out, and then it just causes this reaction which forms these cyst walls that cause them to be these masses to be formed. Now, basically, doing the different radiological studies will guide you in terms of its diagnosis, but if necessary, if it's palpable and based on the radiological studies, you can do needle aspiration. The needle aspiration would confirm the diagnosis based on the content of the aspirate, and it also would be therapeutic because in most cases, once aspirated, the cyst will not recur. And even if it does, you can do multiple aspirations before doing any major surgery or major excision. The radiological findings actually vary based on the proportion of the fat and protein in the milk. So here you have this image here where you can see that you can clearly see this. This is what's called a galactocele. Okay then. Okay, just flew past a little bit there. Okay, so basically, based on the content, there's a different appearance on ultrasound. So, for example, if there is a higher fat content, it's more of a radiolucent mass, all right? And if there is basically if there is a high viscosity, it looks like a hamartoma. It's called a pseudohamartoma. This is just basically for the radiologist to kind of, not be confused and think that is a more malignant cause. So clinically, that won't really change much, right? You'll either aspirate it, or if it's necessary, you may just have to do excision. So puerperal mastitis or postpartum mastitis is basically infection of the breast, a mastitis, right? It does not occur very commonly during the pregnancy, and most often, in postpartum, during lactation period and during breastfeeding, right? It's most commonly caused by the pathogens that are found in the nose and in the throat of the newborn babies, which is most commonly Staphylococcus aureus and then some Streptococcus. So basically, the damaged epithelial cells of the nipple areola complex become infected. So there may be cracks in the nipple, and bacteria seeps in through these cracks, and then basically infects the tissue. And then it can spread rapidly throughout the parenchyma of the breast and the skin. So here you can see here there's redness there. It presents with pain, right? Erythema or redness, swelling, and sometimes fever if the patient is becoming bacteremic. Mammogram shouldn't be done usually in these patients, one, because it's painful, and because of the mammogram is not very accurate in pregnancy and the postpartum period because the breast tissue is very dense, so it's not very useful. It's best to do ultrasound, which is obviously less painful, and it's better at confirming the diagnosis, and it will also rule out if there are any abscesses there, because the treatment is different based on if it's just a straightforward mastitis or if there's any formation of abscesses. It usually responds well to antibiotics, broad-spectrum antibiotics such as augmentin or cefuroxime. But in rare cases, the mastitis can be caused by these superbugs, MRSA. They're highly resistant to the most common organisms, and it can be fatal. It can be rapidly spreading. It can get necrotitis and fasciitis, and the patient can die. Right. So in some cases, the mastitis can progress and form an abscess. In other cases, the abscess can form just within the breast without any superficial mastitis. So, but basically, the breast abscess is a collection of pus within the breast. Here you can see in this diagram, it can be either centrally located in a subareolar area or a periareola, or it can be peripherally located, usually in the upper outer quadrant, because that's where most breast tissue is, and so it is most likely to form there. And the stagnant milk in the postpartum period, during lactation, can basically performs a culture for the bacteria. So if the bacteria gets into these cracks in the nipples, it just infects the stagnant milk and is a setup for abscess formation. Okay, so on examination again, there will be a feeling of a mass there. It will be erythema or redness, increased warmth and warmth to touch. There will be fluctuance, which is like softness of the skin that can be detected, and they'll be very tender. If the abscess is deep within the breast tissue, it may not be able to be very obvious, and it may just be this fullness there with some pain, bad feeling, fatigue, and some fever. But if it's very superficial, the skin will start to be affected, and it'll be more obvious. And sometimes you can get to the point where the skin is actually compromised, and as you can see here in this picture. The diagnosis is usually done, if it's not obvious clinically, it can be done by ultrasound. The benefit of ultrasound is that it will detect whether and confirm whether there is the presence of like a simple abscess, a single abscess, or multiple abscesses throughout the breast. And it will tell you the size and the depth. Right? The depth is very important because it is very close to the skin or involving the skin. It changes your management slightly. Right? Again, no mammography should be done in the acute setting because it's very painful, it's not useful. But after resolution, it is very important to get a mammogram after, because you want to rule out any other malignant lesions that could have been the cause of the abscess or missed during the infective process. So the management involves, of course, antibiotics, broad-spectrum antibiotics. If it's a small fluid collection, you can actually try just a course of antibiotics, and it may resolve without any further intervention. Again, broad-spectrum antibiotics, augmentin or cefuroxime. If there is any failure to improve, you need to repeat the ultrasound. If the abscess is getting bigger, or the patient's clinical condition is worsening, you would have to step up the management. Again, you will need tissue biopsy after resolution, ultrasound guided, if possible. Now, you encourage the patient to continue to breastfeed, because a lot of the problem with the abscess is being formed because there's stagnant milk. There's engorgement, so you need to basically void the milk. There's no risk to the infant with breastfeeding unless the patient is placed on an antibiotic based on the the culture-directed antibiotics is placed on antibiotics that is harmful to the infant. Most antibiotics like the cefuroxime and augmentin and stuff won't affect the infant, so they can continue to breastfeed. If the mother is placed on such antibiotics, she may have to do what's called pump and dump. Basically, pump the milk out with a breast pump and then discard that milk from that breast. But basically, you need to frequently drain the affected breast by either breastfeeding or a breast pump to prevent the milk stasis and the engorgement. So the management, as I said, ultrasound-guided aspiration is the first-line treatment for small abscesses if there's no skin involvement. If it's deep and not very superficial, you can do aspiration, either that's based on clinically, but usually, as I said, ultrasound-guided with ultrasound probe. It's successful in about 85% of the cases, and there's improved cosmesis because it's a needle stick that can be done under local anesthesia. There's no need for general anesthesia. It can be done in the clinic. It can be done in the radiology suite. There's no need for large dressings and deep wound packing. And the usual time for resolution is about 2 weeks. And it may be done repeatedly. So after the initial aspiration, if the patient is still stable and there's no sepsis, you can do multiple aspirations once the skin hasn't starting to become compromised, all right? But if there is clinical deterioration or the skin is starting to be affected, obviously the aspiration won't work, and you may need to move to incision and drainage of the abscess. So incision and drainage. This can also can be performed with local anesthetic, but sometimes it's just not possible because with the infection, there's a low pH, tissue pH in the inflamed skin and tissue. So the lidocaine that doesn't work well, so the patient will still experience pain. In those cases, it's just best to just do it under general anesthesia. It's just if you try to attempt it under local anesthesia, if the patient is painful, it's just not worthwhile. So under general anesthesia, the incision is made of the area of maximal fluctuance. You try as best to keep it within Langer's lines for it to improve cosmesis, because if you cut across these lines of skin tension, the scarring is going to be disfiguring. So as much as possible, as you see here, you try and, if it's close to the areola, you can do periareolar incisions. If it's, you can do curvilinear, depending on where it is, or you may have to do transverse if it's in the upper outer quadrant there. You basically drain the fluid and it's sent for culture and sensitivity, so that depending on if it's any of these resistant organisms, you can change your antibiotics from the broad spectrum you have and kind of have a tailor-made treatment. You break down all the loculations there just to make sure that there's no recurrence, and you want to get sure that you get the entire cavity. And then you must always biopsy the abscess wall at that time, just to make sure that it's not carcinoma. It's very unlikely, but you don't want to miss a cancer. Okay, so this unfortunate condition is called idiopathic granulomatous mastitis, or IgM. It's a rare chronic relapsing benign inflammatory condition, like most things we're discussing tonight, of unknown etiology. It was first described in 1972, and affects women mostly in childbearing age. So either within pregnancy or up to 5 years after pregnancy, this can develop. And basically, it's thought to be due to an exaggerated immune response because of damaged ductal epithelium, either by trauma, hormonal changes, infection. We're not really sure. But basically, secretions leak out into the connective tissue of the breast, into the breast parenchyma, and trigger a lymphocyte and macrophage migration to the tissue. And this causes these granulomas and this huge granulomatous response. So here you see you have the breast stroma, and then the terminal ductal, I'm afraid to press this pointer because it keeps moving. But basically, there's this inflamed terminal ductal lobular unit, which becomes infested with, so to speak, with lymphocytes and macrophages, and it causes this huge response. And it, again, it's not as dramatic as the previous picture that you saw, but it can still be disfiguring, and we can be very concerned, and it can mimic a lot of things. So basically, it can mimic a breast abscess, it can mimic inflammatory carcinoma, it can be very, very, confusing, and it can have a diagnostic dilemma. So it presents usually unilaterally in just one side, but it can be bilateral, and it can be either one single lesion or multiple lesions of varying sizes from 1 centimeter up to 5 centimeters, or it can be, in rare cases, very large. There's tenderness, erythema. They can have sinus tract formations, abscesses associated with it. So as you can see there, it can be a very confusing condition and can be mislead the physician in terms of reaching to a diagnosis. There can be nipple inversion, which again may mimic carcinoma. Okay. I think we're having a little issue here. Okay, now it's going to fly. Okay. Okay. I'm not sure if this is Apple or Mac, Apple or Windows, but okay. So, all right. So essentially, because it's such a difficult diagnosis, you need the help of the imaging studies. So in radiology, you again, a mammogram, which is not the best study, can be done. Basically, you'll see ill-defined density with speculated margins and overlying skin thickness. It's not the best study because it's going to be very painful and it doesn't yield much information. The best, again, would be the ultrasound, which can show this hypoechoic mass, either with abscess or the solid. And if it has an abscess, it usually has tubular extensions to differentiate it from just a standard regular abscess. They will be enlarged lymph nodes, but the lymph nodes would not have the appearance as if when it's in malignancy. So that's another reason why it can mimic carcinoma, because you have this large mass with enlarged lymph nodes. It can be very confusing. MRI is another study that's used, MRI of the breast. It will be useful because it can give you the full extent of the disease, because sometimes even clinically and even with ultrasound, you can't tell how extensive the disease is. And it's a good modality for following the lesions over time as they regress. Because, like I said, it's a diagnosis of exclusion, right? There's so many different conditions that this mimics. A needle biopsy, core needle biopsy should be done because you don't want to miss any malignancies. And if there is any abscess associated with it, you should culture the fluid so you can have culture-directed antibiotics. Because it's a granulomatous process, you need to rule out tuberculosis with staining for acid-fast bacilli, PPD test, chest x-ray looking for lung granulomas, and you rule out an autoimmune cause with CRPs, ANA, and a rheumatoid factor. So this is just a list, it's a long list of things that could be the differential diagnosis for IgM: tuberculosis, parasitic infection, fungal infection, sarcoidosis, bacterial abscess, mastitis, giant cell arteritis. The list is a long list here: breast cancer, foreign body reaction. So it's definitely a diagnosis of exclusion where you basically have to rule out all these other things before you can safely say that it's IgM. The treatment, again, in conditions where very little is known about it, the treatment strategies are always controversial. There's always so many, when there's a large variety of treatment modalities, it usually means that we don't know how to treat it well. all right? But luckily, it tends to be self-limiting, and in most cases, it will resolve on its own. But there are various management algorithms. There's a very high recurrence rate and relapse rate, about 20 to 50%. But again, over time, overall, it tends to be self-limiting. Right? So conservative management, initially, you can treat it expectantly. If it's very mild disease, you just basically reassure the patient, manage the skin issues with analgesia, because it can be very painful and tender. And you can just reassure them that this in itself won't progress to cancer. There's no increased risk of cancer. But again, you have to rule out cancer because of how it presents. Any antibiotics may be necessary if there's any associated infection with it. Any aspirations will be sent for culture, and then you modify your antibiotic coverage as such, right? Any abscesses are there can be percutaneously aspirated, as in the treatment for the breast abscess. Other treatments would be steroids. You can have oral steroids. They've been shown to have at least an 80% success rate. Prednisone or prednisolone. And it's a long-term treatment which you gradually taper over weeks to months. Unfortunately, steroids, as we all know, has a lot of side effects that can be intolerable for the patient. And then after stopping the steroids, if you stop it prematurely, you can have up to 50% relapse rate. Immune modulators like methotrexate, they have been used with variable success, variable results. And this again has a multiple side effects, of which alopecia would be one that is in most cases not tolerable, and it can affect the liver. The other, if there's no improvement with conservative management or medical management, again, that's where the surgeons come in. If there's any associated abscesses, they may need abscess drainage. For small single lesions, a wide local excision can be done. However, but this usually has a high recurrence rate, and it can result with delayed wound healing and disfigurement and poor cosmetic outcome, and fistula formation if all of the affected tissue is not removed. For severe cases, like you probably in the initial pictures that you saw, and if it's intractable symptoms, pain and sinuses and these recurrences, and it's just not resolving with any other approaches, you may have to resort to mastectomy with or without reconstruction. Fibroadenoma, which is it's very common throughout life, and is also the most common lesion during pregnancy and lactation. It's basically a benign lump which has mixed stromal and epithelial components. It's mentioned here because we have most women throughout life may develop these benign lumps that can be watched, or they can be excised based on their desire. But they may have very, very small fibroadenomas that are not noticeable before pregnancy. But because of the influx of the hormones during pregnancy, and because these lesions are very sensitive to the hormones, they can increase significantly in size during pregnancy. And if this happens, you can reassure the patient and tell them that, okay, we can wait until after delivery to see if they go back down in size, because they usually will reduce in size after pregnancy. If they persist in the same size, they don't go back down, or they still are relatively big after, then they can be either excised, if the patient desires. But there's no malignant potential in these lesions, so it would just be really for cosmetic purposes. All right, so in the fibroadenoma, there's an ultrasound, that's the appearance there. It's a benign condition, but in rare cases, you can have necrosis within the fibroadenoma, which would cause sudden pain in the third trimester or during birth. And this is caused by embolism within the vessels. It's usually, again, self-limiting, and it will resolve, but it can be extensive, and will need either biopsy or excision to rule out a malignant lesion. Again, it's recommended to just wait until after delivery to see what happens, because it's a benign condition, It usually will regress after delivery once the effect of the hormones is removed. So it's best to wait. Another condition, which is very similar and very hard to distinguish from the fibroadenoma, is a lactating adenoma. This typically occurs in the 3rd trimester or in the postpartum period. And this is differentiated from a fibroadenoma, where this is a tumor of secretory epithelium. Again, it will be palpable. It's very slow growing. It rarely gets to a very large size. It rarely gets bigger than 3 centimeters. It can sometimes grow to 5 centimeters and be disfiguring. Again, in most cases in pregnancy, the ultrasound is the best imaging modality. It has distinctive features. They can be distinguished with some difficulty from fibroadenoma, but other lesions. And you can reassure the patient that it's not malignant. But if there's any persistence post-partum, then it would need to be either excised or biopsied. Again, there's no increased risk in this lesion of breast cancer, and it usually regresses after pregnancy. If it doesn't, you can try bromocriptine as well. And if that doesn't work, again, the surgeons come in and surgical excision can be done. Again, if it persists, if it's larger than 2.5 centimeters, there's a lower risk of recurrence with excision. So in most cases, the patient would benefit from that. So malignant conditions, it's basically breast cancer. And you have pregnancy-associated breast cancer. Now, breast cancer is a very large topic, and each aspect of it could be its own talk. So I'm just going to try and kind of bring it down for this presentation. So pregnancy-associated breast cancer is essentially defined as the diagnosis of breast cancer during the gestational period, within 1 year of pregnancy, and during lactation. Incidence about 1.3 to 3.7 per 10,000 deliveries. Right? Median age at diagnosis is 33 years, so it's a very young age. So they tend to be very aggressive, not so much because of this being in pregnancy, but because any cancer, even in non-pregnant patients that presents at a young age, tend to be more aggressive. So the diagnostic and evaluation and staging during pregnancy, there's slight nuances to managing the patient during the pregnancy because of the effects on the fetus, and also because of the physiological changes that take place in the body and in the breast. So the hypertrophy that I mentioned earlier and the proliferative changes makes it more difficult to examine the breast because it's engorged, the tissue is more dense, the parenchyma is dense. It's not easy to detect lesions, so they may be missed, right? But the ideal time for examination, if there is during the 1st trimester before all of those changes really take place. Any abnormality that's detected should be evaluated as soon as possible without any delay, because if you're trying to delay too much, then you can get a worse outcome if the cancer progresses. But there's a lot of nuances with the timing because of the pregnancy. So again, mammograms is typically not done in pregnancy. The radiation exposure for mammogram has been reported very low to the fetus, and it can actually be reduced further with abdominal lead shielding, further 50%. But it's still not usually done because of the increased parenchymal density of the breast. Just the studies is not very sensitive. But if there's any on ultrasound, if you find any mass that needs clarification, you may still have to do the mammogram, because it's very good at determining multifocality and multicentricity of breast lesions, which affects your management and affects what you can offer the patient in terms of surgery. So the ideal study for the breast during pregnancy would be the ultrasound. It's more sensitive than a mammogram during pregnancy or lactation for the reasons I discussed earlier, which would be the breast tissue is very dense. So the the ultrasound is better than the mammogram at detecting. It has a very high negative predictive value for excluding malignancies. So if the ultrasound, and it's user dependent based on the ultrasonographer, but most of them, especially here at HSA, they're very good, and in Cayman in general. So if you don't pick up a cancer on ultrasound, it's usually very predictive and accurate. Sometimes, based on this, the ultrasound, you may need clarification with an MRI, but it's very limited use in pregnancy because it's thought that the IV contrast that's used has a potentially long half-life in the fetus. There's been some association of teratogenicity in animal studies. No major studies. There's no large number of studies in humans, but because of the paucity of the data, the lack of data, it's not really recommended. We can't recommend its safety in pregnancy, but may be used in postpartum period, even if you're breastfeeding and lactating. So again, most of the staging studies that were done, like with the CT scans and so forth, use ionizing radiation, and so that can affect the fetus. And the most important period is the first 8 weeks, organogenesis. That's when the fetus is most sensitive for the radiation-associated malformations. And so basically, there's some guidelines in terms of timing, but basically the indications for using the staging studies should follow the NCCN guidelines as for non-pregnant patients. The timing of it varies, but the decision to use these staging studies are the same. But basically, we would tailor it because of the pregnant state. So chest X-rays would be used to rule out any lung lesions, with shielding of the abdomen with lead. Ideally, you would avoid CT scans if possible, and then ultrasound would be the modality of choice for imaging the liver to check for any liver metastases. If there's any suspicion of brain metastasis, or any headaches, or any dizziness, or any vision issues, then you do a MRI of the brain rather than a CT of the brain. And bone is the most common site for metastasis in breast cancer. You can't use the alkaline phosphatase blood levels, blood tests as a little indicator to see if there is any bone, because that is already increased during pregnancy. Bone scan is considered safe, but it still should be avoided if possible, and an MRI could be used to look for any bony mets if it's suspected. PET scans, again, that use is very limited during pregnancy because there's not enough evidence to support its use for safety. The FDG, which is the contrast that's used for PET scans, they're not sure the full effect on the fetus during pregnancy, so it's not recommended at this time. But they know for sure that there is a low amount of it produced in the breast milk, so you can, after delivery, very soon after delivery, a PET scan can be done, and then the mother just has to avoid contact with the infant for about 12 hours. So again, if there's any suspicious lesion, it should be biopsied. It can be done under local anesthesia. There are risks for doing it in pregnancy, like you can get a milk fistula. There are sporadic reports of it. It's very low rate of occurrence, but it is possible. Fine needle aspiration is not done usually because it's very difficult in interpreting the psychological findings because of all of the changes that are taking place in the breast with pregnancy. So ultrasound probe is used to detect the lesion, and then a needle is introduced under local anesthesia, and pieces of the tissue of the lesion are sent to the pathology, and then it's determined whether there is cancer or not. So the majority of the lesion of the carcinoma will be what's called invasive ductal carcinoma, which is carcinoma from the ducts rather than the lobules. That's the case in non-pregnant patients, and that holds true in pregnancy. The tumors in pregnancy tend to be larger at presentation and more aggressive, and most likely present with axillary metastasis than non-pregnant patients. Like I said, usually more aggressive, whether it's due to the fact that they're pregnant or because they're presented at a younger age. I'm not sure, because when they've done age matching with non-pregnant patients to pregnant, it's very similar in the type of aggressiveness of the tumor. So there's a high grade tumor, about 50%, and then the tumors can exhibit lymphovascular invasion. In terms of the receptor profile, there's a shift towards it being estrogen and progesterone negative, which again kind of shows that it is more aggressive nature, because if it's a triple negative cancer, those tend to be more aggressive than receptor positive cancers. So in about 50% of pregnant women versus 40% of age-matched non-pregnant females would be ER, which is estrogen receptor negative. And again, HER2 positivity there are a lot of studies lacking. There's still a lot more to be done in terms of studying that. So we can't really come to any strong conclusions with HER2. So, surgical management. Historically, mastectomy was the only option that was considered. That has changed somewhat now with breast conserving therapy, but there's a nuance to how, in terms of the timing of how you're going to approach it. Because the keys is that radiation cannot be given at all throughout the whole pregnancy. And breast conservation is key to have radiation, because the recurrence rate, if you do breast conservation therapy, is very high if the breast is not irradiated. So because of that, the lumpectomy or breast conservation surgery is not offered in the first trimester or early trimester, because the delays of the radiotherapy that need to be given after delivery will cause significant increased recurrence. And the general anesthesia is of concern during the first trimester, right? There's no direct risk of congenital abnormalities from anesthesia itself, but because the anesthetic drugs cross the placenta, it can affect the fetus. And there's significant increased risk of spontaneous abortion in the first and second trimesters. And in the third trimester, there can be induced premature delivery, right? And also, of course, it's paramount that you avoid the maternal hypoxia and hypotension, because that can have effects on the fetus. Management of the axilla, again, this is very important, and there's a nuance to it during pregnancy, because sentinel node, lymph node biopsy has become the standard of care for early cancers. There's an issue with that in pregnancy, because the blue dye is not recommended. It's not considered safe, because there's limited data on the teratogenic effects, and because there's the risk of maternal anaphylactic reactions that can cause fetal demise. So it's not recommended to use a blue dye, the isosulfone blue, but ironically, radiocolloids, which use radiation, gamma radiation, is considered safe because the dose given is very low. But still recommended to give it early in the morning, so you can reduce the amount of exposure to the fetus. All right? Sentinel node is pretty similar to what was described earlier in the other presentation. Basically, inject the radiocolloid and then use a probe to find a single lymph node that may have metastasis to it. And that reduces the risk of lymphedema in the extremity. Breast reconstruction, again, can be offered to the patient. Now, there's, again, a few studies on this, but basically, it can be done immediate breast reconstruction, usually in a two-stage procedure where tissue expanders are first put in, and then the final implant is put in after delivery, and completion of the chemoradiotherapy. Again, ideally, delayed reconstruction, should be considered, because until after pregnancy, because the unaffected breast will reduce in size and go back to its normal state. So it's best to wait to allow it to happen so that you can have symmetry with the reconstruction. Again, it's going to fly past. All right, so in terms of systemic chemotherapy, many of the agents are safe after the first trimester, but within the first trimester, it can be hazardous to the fetus. So basically, it's contradicted in the first trimester, and it should be initiated between the first 14 weeks because of a fetal malformation rate of about 14 to 18%. Right? In the second or third trimester, the risk of fetal malformation is only 2% or less than 2%. Right? The common regimens used are doxorubicin and cyclophosphamide, AC, 5-fluorouracil, doxorubicin, and cyclophosphamide. The major risk is for premature delivery, and so no chemotherapy should be given after 35 weeks. So it's really between those 14 weeks to 35 weeks is when you would give chemotherapy. So based on the chemotherapy and the radiation, that's how you kind of time your treatment in pregnancy. So the radiation therapy, as I mentioned before, is essential for breast conservation surgery to reduce the risk of recurrence, but it cannot be given during the entire pregnancy. So basically, because of that, you can't really offer breast conservation surgery in the early trimesters. Right? You have to wait until the second or late second or third trimester where you can do the surgery. That way the radiation can be done in a timely manner after delivery. Right? Because there's a significant risk of teratogenesis to the fetus and childhood malignancies developing at a later stage after birth. Right? As I mentioned, the timing is essential for the radiotherapy. The irradiation of the breast can affect lactation. And so the patient should be advised not to breastfeed from the irradiated breast. Therapeutic abortion, right? That's an issue that should be discussed. If it's a difficult decision, it's informed. The patient has to be well informed and counseled. Essentially, if the cancer is detected very early in the pregnancy, then you have that discussion whether you're going to proceed with therapeutic abortion or not, and then you determine your management after that. If it's a late, obviously, if the cancer is detected late in the pregnancy, it won't be considered, and then you manage accordingly based on the trimester. So there's no evidence that early termination of the pregnancy improves the outcome of the pregnancy-associated cancer. It actually may worsen it somehow because it's felt that the lack of hormones, the change in the hormone profile during pregnancy is actually a little bit protective in preventing the cancer from worsening. We're almost finished. Okay, so the factors involved of this discussion about the termination of pregnancy is that the systemic therapy of future fertility is after getting chemotherapy and radiation is the patient going to be able to have other children. Right? And then the level of family support, the prognosis of this particular breast cancer, and also have to discuss the fetal complications from the exposure to all the treatments that we'll be getting. Okay, this is just basically a summary of the NCCN guidelines to discuss just the algorithm for the treatment. We're going to just quickly go through it. Basically, it involves diagnosis, as we mentioned, and it determines basically the gestational age. If it's less than 14 weeks, you consider termination. If you do have termination, then you continue with standard treatment as in the non-pregnant patients. If there's no termination, then the guidelines shift basically depending on on the plan. If you're going to, if you may have to do mastectomy, because you don't want to have any delay with radiotherapy if it's early, relatively early in the pregnancy. And if it's late in the pregnancy, you can actually wait until delivery to just do standard care as if it's a non-pregnant patient. So the timing is crucial in the management of the pregnancy-associated breast cancer. Running out of time now, so just in conclusion, there are no randomized trials addressing the range of issues in pregnancy-associated breast cancer. The outcomes are very similar, stage for stage, for non-pregnant women, but there's just some nuances in terms of timing of therapies. It's key to have prompt evaluation of any mass discovered in pregnancy, because that would guide your treatment based on the timeline. The management is complex. It requires a multidisciplinary approach. In all cancers, in breast cancer, in every cancer, there's a multidisciplinary approach, but there's another level to it with pregnancy-associated breast cancer, because we're bringing in the gynecologist and the obstetrician, the pediatrician, and they're added to this multidisciplinary team of doctors, nurses, therapists, counselors. So it's definitely a multidisciplinary approach. Counseling is crucial. The treatment is dependent, again, on the gestational age, when you weigh in the benefits of treatment to the mother, and then in the context of a fetus developing, and then the effects on the fetus for any conditions that can affect them. Thank you very much.
Thank you to Dr. Felix for that very eye-opening, informative presentation. I can honestly say that I have seen some things that I will not be able to unsee. And I am now much more attached to a certain part of my anatomy. We would like to give you a small token of our appreciation for participating in the conference and doing that presentation. Thank you very much. So we'll still take a question or two, please. We're going to make it very brief. If anybody has any questions, you can raise your hands and somebody will bring a mic to you. Any questions for Dr. Felix? Sure, Dr. LaCoy.
Thank you, Dr. Felix, for that thorough presentation. I'm asking a question on behalf of someone that's watching remotely. It was regarding the use of bromocriptine for the breast hypertrophy condition. Does that affect the woman's ability to then breastfeed at the end of that pregnancy? And will it affect the woman's ability to breastfeed after future pregnancies? Yeah. And are there any alternatives to bromocriptine other than just conservative management? Thank you.
Thank you for that question. Yes, initially, the use of the bromocriptine will affect her ability to breastfeed, because it basically shuts down the production of the milk. But it's not long lasting. So after the effects, after a period of time, after the effects of the bromocriptine has worn off, after stopping it, in the future, on subsequent pregnancies, it should not affect her ability to breastfeed. In terms of medical treatment, there's not much options, unfortunately, for that condition. But like I said, usually it's self-limited. The vast majority are self-limiting. So it has to do with basically the skincare and reassuring the patient, ruling out any other malignancies. I kind of just, I mean, I showed pictures of like the weird and wonderful and the horrible ones, but the majority are not that bad and tend to be self-limited. But the key is just to basically reassure the patient and rule out any other malignancies, because it's a great mimicker. Okay.
Thank you. Thanks again. Okay, so thank you, Dr. Felix. As was previously mentioned, a conference like this takes a lot of hard work, and I hope that you are enjoying the presentation so far. Yes? Good. And so every year we take a few minutes just to recognize people who have contributed, valuable contributions have been made by them to previous conferences. So I'd like to invite Dr. Davina McCoy to come and just make those presentations.
Thank you, Dr. Palmer. Good morning, everyone. I'm sure we're all having a fantastic time here, and I know many of you are very anxious to get to the break as well, but I'm assuring you that my section will not be too long. In the meantime, you can just shake your legs in your spots, and we'll get this section over and done with, okay? So as Dr. Palmer mentioned, each year we like to highlight a few individuals who have made contributions and supported our conferences. There are lots of persons, and although we can't thank each one in person, we just wanted to take some time to highlight a few individuals. So our first special award will be to Dr. Hazel Brown, our Chief Nursing Officer. Unfortunately, she's not here today due to illness, and we do hope for a speedy recovery for her. But I will ask our nurse manager, Nurse Mitzi Morgan, to accept her award in her absence. And Dr. Hazel Brown, we want to thank her for her unwavering support and her generosity, including reaching into her own pockets to provide monetary contributions towards snacks and refreshments for several years. Thank you, Dr. Hazel Brown. A round of applause, please. Second award is for Dr. Delroy Jefferson, our medical director, for being an avid supporter of the conferences, always pushing for its continuity and improvement. His eagerness to assist whenever and however, and his full participation at the conferences have been greatly appreciated. Our third award is to Mrs. Lizette Yearwood, our Chief Executive Officer, for her unwavering support and her attendance and participation at all 10 conferences and at the Women's Health Fair last year. Her encouragement and her push to constantly improve the conferences allowed for an increase in budget for this year, which afforded us the opportunity to host this year's 10th annual conference here at the Grand Cayman Marriott Beach Resorts. This is a huge upgrade from our previous location at the Hibiscus Conference Room at the Health Services Authority. But to be honest, we drastically outgrew that space due to the phenomenal and increasing turnout with each year. Mrs. Yearwood further demonstrated her commitment to the growth of this conference by providing us with access to Mrs. Brooke Moore, a marketing and communications manager at the Health Services Authority, and to Ms. Monique Spence, one of our marketing and communications officers at HSA. Their expertise has proven invaluable to hosting another successful conference of exceptional standards. Our fourth award goes to Dr. Troy Gatcliffe. He is considered to be one of us as far as women's health care is concerned. And his consistent participation has made him one of the most frequent presenters at HSA. Let's do that again, Dr. Gatcliffe. At HSA's annual conferences. His eagerness in accepting our request to participate and the high caliber of his presentations has been greatly appreciated. Outside of these conferences, Dr. Gatcliffe has also made other presentations, both at HSA and in the wider community on several occasions. So, this year, we actually have 2 surprise recipients, and I'm very, very honored to be able to address these individuals. Our first one is Dr. Jillian Belfonte. One of our long-standing obstetrician gynecologists and a fellow of the Royal College of the Obstetricians and Gynecologists at the Health Services Authority. She is a founding member of the conference and one of the organizers of every conference and fair. She has performed many roles. She has performed many roles, including chairperson, presenter, coach, and monetary donor, including personally sponsoring an overseas presenter. Thank you, Dr. Belfonte. Our second surprise recipient, I feel like we need a drum roll here, is Nurse Beverly Samuels. Senior midwife and nurse practitioner. She is affectionately known to many of us as Nurse Bev, our Mama Bear, our matriarch of the Women's Health Department at the Health Services Authority, and she is perhaps the unsung hero of this conference. I'm going to make myself cry here. Nurse Samuels has assisted in ensuring not only the continuity of the conference, but also its high standards. In addition to being involved in the planning and organizing of every conference since its inception, she has undertaken several roles, including registration clerk, chairperson, fundraiser, radio promoter, and monetary donor. We thank you all so much. Thank you, Nurse Bev. So we just want to, again, give a round of applause to each person. And as I said, there are many others that we would like to individually thank, but we unfortunately are not able to do that. So that's my section for today. Thank you.
Thank you, Dr. McCoy, for that, and thank you to all of the recipients of that special award. Right, so the time we've all been waiting for, coffee break. We are going to just cut it down by 5 minutes, so it's a 10-minute break. It's now 11:40, so if we could have everybody back in the room at 11:50. Coffee break is sponsored by Cayman Fertility, Cayman Clinic, sorry. And so thank you to them, and just take time to go to the exhibits and the booths outside. So back here at 11:50. Sorry, guys. I'm very bad at math, apparently. It's 11:45. We're going to reconvene.
you.
Okay, I did say that that was my section, but I'm back again. I promise I will really be short this time. And I wanted, or we, on behalf of the Women's Health team, we also wanted to highlight another special individual, Dr. Eileen Ebanks. She has also been very much behind the scenes, making sure the decor is in place, and we definitely want to say thank you, Dr. Ebanks. She's way down in the back, way for us, for all that you do each year at the conferences. Thank you very much. And we have another surprise award for the person whose brainchild this was 10 years ago, Dr. Gilberta Alexander. You thought you could get away, huh? I'm actually, yes, a standing ovation for her. She's what our consultant OBGYN and a fellow of the Royal College of Obstetricians and Gynecologists. It is with our deepest, heartfelt appreciation for all of your vision, guidance, your great organizational skills, your leadership. Dr. Alexander, she usually prefers to remain behind the scenes, but we definitely had no choice but to highlight her for everything that she has done each and every year. We thank you tremendously, Dr. Alexander, for all that you have done. Thank you very much.
All right, thank you, Dr. McCoy. And I think we got her, right? She had no idea. So we're gonna get back into our presentations, and just a quick little housekeeping thing. Because of the time and that we're way behind schedule, we are gonna make a few adjustments in terms of lunchtime and all of that, where we will bring our lunch and just eat it at the table and just go on with the presentation. It's a box lunch, so everybody should be able to go get the lunch. We'll give a few minutes for that, and then we'll try to continue so that we can make up some of the time. And at this time now, I'd like to invite Ms. Maureen Nabi of the Business and Professional Women's Association of Grand Cayman, and Bethany Ebanks Pacheco of the Maternity Leave Advocacy Working Group for a brief presentation on a project that they've been involved in that seeks to support a formal policy change on the maternal leave in the Cayman Islands. So just welcome them, please, to the stage.
Well, good morning, everyone. Hope everyone's doing well and enjoying the conference. We'll try to keep this as brief as possible, but you may or may not have seen the article that came out in the Compass on Tuesday in recognition for International Women's Day about two very, very brave and strong moms kind of fighting the battle to legally change the maternity leave within the Cayman Islands. I'm one of those moms. So my friend and my dear friend Lauren and I actually met from a mom's group. I was just heading back to work after 4 months postpartum in the middle of a pandemic with no support, just being told I had postpartum depression, try to get a divorce from my husband, try to give my dog away to the Humane Society, and I wanted nothing to do with my child. And Lauren and I met, and she just couldn't understand how a country like the Cayman Islands that is so welcoming to all different nationalities, all different type of people, had such a leave, a backwards leave entitlement. So we kind of came together and said that it's time to change it. And I'm coming from a place of this happened to me. I didn't have a great time during my maternity, and I don't want it to happen to the next mom. I'm thinking about my daughter whenever she does decide to have children. I'm thinking about the next generation. So that's kind of why we came behind and came together and started researching and understanding the policies and the laws and who kind of is responsible, so to speak, for gender affairs and women equality and this specific issue, maternity leave. So that's kind of us in a nutshell. And we did start with a focus group, and we brought in Marion and Ariel and a couple of other moms just to get a holistic approach as to other people's experiences, because that was my experience, and each person has a different experience and a different exposure to the situation within the Cayman Islands. So that's kind of us in a nutshell, and now I'll pass it on to Marion for BPW.
Thank you. So my daughter Aria is now 4.5 months old. I went back to work 2 months ago. On the 2 months of maternity leave that I took, 1.5 was paid leave. My maternity entitlement was actually 4 days, officially. During my pregnancy and in anticipation of my delivery, I felt incredibly supported by my CEO, the company I worked at, the HR team that was in place, but the fact that I had recently transitioned from one position to another in a new subsidiary of our company meant that my leave was 4 days long. 5 days of unsuccessful induction and a C-section later, my leave was up. So ultimately, thank goodness, I worked with my HR team to find a way to get some additional paid leave. But again, ultimately, that was 2 months of paid leave. Today, I'm actually not here on behalf of my employer. I'm here on behalf of BPW, which is Business and Professional Women's Association of Grand Cayman. We, as an NPO, have an official seat at the table with the United Nations and a number of their women's and gender affairs committees. And the work that Bethany and Lauren are doing in the Cayman Islands aligns perfectly with what the UN have as guiding principles and proposals on inclusive parental leave. So those principles are 24 weeks of paid parental leave for both parents, official designated nursing and pumping rooms and regular breaks, quality and affordable childcare and child support grants, including support, especially during the first 1,000 days, and equal treatment and respect for all methods of becoming a parent. Increasing maternity leave, parental leave overall, and using these as guiding principles is the right thing to do. Family-friendly policies support staff to balance their work and family responsibilities and help reduce stress and conflict that can actually arise from families struggling to manage all those competing demands. And I know we all have an experience with that, whether it's personally or with friends. This special, the guiding principles, if they're applied, enable bonding between primary caregivers and their children, provide a foundation for individual success, family cohesion, and stronger and sustainable lifestyle choices. It's actually the equitable thing to do as well. So as a nation, BPW believes we should be committed to gender parity. Gender equality is a global prerequisite for sustainable development. Time and time again, studies have shown that workplaces that have chosen to implement effective family-friendly policies see a decrease in attrition rates of female employees. Evidence also shows that when policies support greater parental involvement in child rearing, it's beneficial to children's social, emotional, cognitive growth, and actually decreases gender stereotyping in the future. The motherhood penalty is the idea that there's a discrimination against mothers in the form of lower likelihood of hiring or promotion, lower salaries, lower perceived competence and commitment to their job. This diminishes when you apply these guiding principles, and both parents receive equitable leave. It's also the smart thing to do for businesses, because often the argument is made that it's a financial burden, but businesses actually that have family-friendly policies are linked to better workforce productivity, the ability to attract better talent, and motivate and retain employees. Higher morale, job satisfaction, and productivity sounds like it's good for business to me. For families as well, there are better outcomes for learning and cognitive improvements for children whose fathers take paternity leave, and there are studies globally that have shown this. The philosophy of BPW Grand Cayman is that every woman, because BPW is focused on women, but we will say people, as a resident of their nation, must bring to their national policy the contribution of forward thinking and constructive thought, followed by action. So we would like to ask you, and I will hand it over to Bethy in a moment, to reflect on this message really as a call to arms as people who are in this sector, who are working with women day in and day out on their overall health, to fight for better policies to support them physically and emotionally.
Thank you, Maureen. And just to kind of reiterate what she was saying, you may have seen the flyer that was in your goodie bags or delegate bags that you received. If you haven't already signed the petition, I ask that you do sign it, just because the more signatures we get, the better it is for us when our report that we're presenting to the governor, to the premier, sorry. We have surpassed our target, which was 2,500, which I think was incredible. And that was just from Tuesday to Thursday. So you can see like there was a massive jump and definitely support within the community. So now we have set a new target to get 5,000 signatures altogether. So with your help, again, if you haven't signed the petition, please sign the petition, share it with your colleagues, and just kind of get in support and rally around us. We will be in touch with some or most of you, if we haven't already been, just to kind of get your feedback and your support in terms of a quote to say that this is necessary within the community and you support this initiative, and just to get some more information as to what your business or businesses are doing around maternity and paternity leave. So with that, I just want to thank you very much. And I've taken a very horrible experience and turned it into something extremely positive. With the help of my friend Ariel, I'm now becoming a doula because I see the need in the community for women to support other women, especially around birth. So again, it's not just about mothers, it's about the whole community at whole. And I think the change will definitely not only benefit us mothers, but it'll also benefit the children for the longevity of the Cayman Islands. So with that, I hope we have your support, and thank you very much for your time this morning.
All right, so we want to thank you ladies for bringing awareness to a very important topic. So moving right along with our program, we're going to go into the next two presentations prior to our lunch break. And I'm very pleased to introduce one of our very own midwives, Caroline Hopkinson. Caroline works for the HSA, and she has done so for many, many years. She is a midwife in the maternity ward department whose main focus is patient care, and she hopes that one day healthcare and education will be accessible to, and affordable to everyone. She believes, or she agrees with Aristotle, that happiness is what makes life worth living, and it is measured by refraining from materialism and feeling inspired by our coexisting society, and I concur. So I'd like to welcome Caroline to come, and she's going to present on non-genital maternal injuries in pregnancy, delivery, and the postnatal period.
Thank you very much. It's a little bit intimidating. Normally when I have a microphone, I'm singing a song on karaoke, so please forgive me if I burst into song halfway through my presentation. People who know me basically know that I try to use humor because obviously I'm very nervous right now, okay? So please forgive my sense of humor, it's very British. So yes, today's talk was chosen by Dr. Alexandra, and I'd like to tell Dr. Alexandra absolutely how proud we are of her, an amazing job she has done for the HSA, and thank you for inviting me to talk today. I am really very honored. Thank you. Oh, well, I apologize. Thank you, Dr. Palmer. Okay, so this year's theme for International Women's Day is Together We Can Break the Bias, actively call out gender biases, discrimination, and stereotyping. It's a global celebration dedicated to uplifting women and honoring their achievements. We mustn't also forget that transgender males and non-binary people are also included in that because they are identified as females at birth. So as part of honouring achievements of women, I'd first like to mention the poor women in Ukraine. I'm not sure if you've all seen the video about the ladies. I think there was 46 deliveries during airstrikes in an underground shelter in Ukraine. Hats off to these ladies. Seriously, childbirth is scary enough, never mind during a war. I also would like to honour the achievements of all the midwives in the HSA during the pandemic for the consistent hard work and dedication. So to get on to the topic, as I say, I try to use humour because, yes, I'm very nervous. But it's very difficult to actually use humour for this presentation. There is a very serious side when we talk about injuries. Injuries obviously imply there is hurt, there is damage, there is loss, there is trauma. Today's topic, obviously, physical damage caused to the body would suggest injury by violence or by accident, or indeed through pregnancy. The gentleman's eyes are amazing, aren't they? I think he's very traumatized about what's happening, for sure he is. And this is how I've tried to bring humor to this topic. But in fact, when you look at the issues that I won't be covering today, miscarriage, pregnancy-induced hypertension, gestational diabetes, preeclampsia, eclampsia, sciatica, sexually transmitted diseases, they're all worthy of a conference all dedicated to those topics individually. But I didn't think we could let the day go by without actually mentioning them. And certainly, pregnancy-induced hypertension and gestational diabetes are very prevalent within the Caribbean. So the injuries that I've chosen today really come from Dr. Alexander's advice, really from personal experiences, and the fact that some of them are quite rare as well. So the first thing I did when I was given this topic is to Google trauma in pregnancy. And this is what popped up, not what I was expecting for sure. In the USA, motor vehicle accidents account for about 50% of all traumatic injuries during pregnancy, and many are due to the incorrect use of seatbelts. Most of them will cause some kind of pelvic fracture and actually can result in fetal death. So a simple thing that we can all remember today is basically when you see somebody wearing their seatbelt inappropriately, we can just remind them to put it on correctly, especially as we know that road traffic accidents in Cayman are quite prevalent. Okay, so this is obviously something very simple to start with, posture in pregnancy. So the physics of the growing abdomen result in unstable balance, which increases frequency of maternal falls from standing or from a height such as stairs. Just the simple act of the fact that when you're pregnant, you arch your back and your posture changes quite significantly. We do see a lot of fractures, sprains, ligaments, and muscle injury. And unfortunately, if you fall in the wrong place, like on your abdomen, it can also lead to miscarriage. Symphysis pubis diastasis. So there are physiological changes in pregnancy which can predispose women to certain types of non-traumatic musculoskeletal injuries. I have trouble with that word. I think I hit it. It's good. So it's mainly due to pregnancy hormones, relaxing the pelvic ligaments, softening the cartilage of the pubic symphysis. So let me try this. This is the normal pelvis. And basically in pregnancy, because of the ligaments being soft, you get this gap here. Most ladies will come to the maternity ward with lots of suprapubic pain. It's hard to do simple tasks for them, like getting in and out of the car, getting in and out of bed, and walking. We'd be glad to know that basically most of these cases, once you've had the baby, they return to normal and everybody is fine. But while they're pregnant, obviously, we need to give them some analgesia. We need to teach them how to get in and out of the car by keeping their legs and their knees together and swinging them from side to side, as opposed to parting the legs to actually to get out of the car and out of bed. And also, we have a great teamwork with the physiotherapy department. We will send them to physio and have them fitted for a fembrace or a pelvic support belt of some description to take the extra weight off the pelvis. Cholestasis of pregnancy, it's quite rare. It causes intense itching in pregnancy, no rash associated with it, just itching. A lot of women will present with the palms of their hands and the soles of their feet. Others, the itching is just everywhere. It's usually later on in pregnancy that this develops. It's a buildup of bile, which we know is a digestive fluid that helps to break down fats. It eventually enters the bloodstream, which is what makes it itchy. And not really a problem for mummy, although I'll tell you it's very intense. A lot of scratching involved. We can treat the scratching. But the risk is actually to the baby. There's a high instance of stillbirth related to cholestasis of pregnancy. There is no prevention, and the cure basically is to deliver the baby as soon as possible for safety for the baby, really. So amniotic fluid embolism. So this occurs when the fluid surrounding the baby or fetal material of any description really enters the mother's bloodstream. We've come a long way as far as amniotic fluid embolism is concerned. Survival rates have definitely improved. Back in the 1980s, a lady that presented with this had about a 14 to 20% survival rate. Nowadays, they suggest we might have an 80% survival rate, but unfortunately, there is a higher risk of brain damage because of what actually happens during that scenario. And the reason I've got this slide in is because on maternity ward at the HSA in the Cayman Islands, we've experienced that personally. My colleague and my boss, actually, Ms. Charmaine, will tell you all about it. She was present. And this lady actually did, as the clinical signs would suggest. Her blood pressure dropped. She had difficulty breathing. Due to lack of oxygen, she started having seizures, and then she went into cardiac arrest. Unfortunately, both baby and mum did not survive that scenario. It's significantly associated with induction of labor and maternal age. My patient was being induced, but she was a very young lady. She was probably in her late 20s. Placenta previa and placenta abruption also increase the risk of this complication. So firstly, let me say domestic violence is not okay. I don't care where you are in the world or what your beliefs are, it is not okay. There is no excuse for domestic violence or domestic abuse anywhere in the world. With domestic violence, there is an increased risk of miscarriage, premature delivery, low birth weight babies, fetal injury, and even fetal death, not to mention the emotional and physical, psychological trauma that the mum is going through. If you've experienced domestic violence pre-pregnancy, then I'm sad to say that you're more likely that the severity of that domestic violence will actually increase during pregnancy. It's suggested that either 15 to 20% of women will actually experience this issue. Again, it's not acceptable, it's not okay. We have a wonderful facility, the Crisis Centre, and if you know of anybody that has experienced domestic violence, pregnant or not, please refer them to the Crisis Centre. They do an amazing job here in Cayman. So this is an interesting case. It brought a smile to my face when I first met this lady. You probably read in my bio, but it wasn't actually mentioned, that I worked for 2 years in Pakistan on the Afghanistan border with refugees. This lady, she came into the maternity unit. And the first thing we ever do as midwives is just to palpate the uterus and, have an idea of when the pregnancy, how far the pregnancy is and what your implications of why you're there. We found this. It's not normal. I don't think anybody here has found a lock on somebody's abdomen in their lifetime. It was quite interesting. This lady turned out that she had 14 pregnancies, which is not unusual for Pakistan. Contraception is not widely available or seemed to be, it's not something people use. Even if it was available, they wouldn't choose to use it. So 14 pregnancies, she's had 2 live births, so that means she's had 11 miscarriages, and she has 2 girls. Due to the pressures of her relationship, basically she spent most of her life being pregnant, trying to conceive a male baby. Unfortunately, she went to see her local healer in the local village, and they prescribed this. The idea being that you would put a lock on the abdomen, and it would secure and lock that baby in place. So now you're wondering, no, it didn't work. Another nice picture. So injuries related to delivery. So I personally feel that this is where midwives really do come into their own. We are experts in the norm, but to be experts in the norm, obviously we have to be able to identify when things are not normal anymore. So just to, before we lose faith, because everything's quite depressing, for many women, childbirth is a joyous, fulfilling, and empowering experience. My mother would say that. She said, yes, it was painful, but the reward at the end of it made it all worthwhile. Because she had me, right? I mean, for others, actually, it can be the most traumatic event of their lives. So I'd like you to take a minute, if this works, and listen to this.
Cracking stuff. I can't do it! I need the gas! Let's have a baby instead. Come on. Good girl. Go on. I can't do it! Yes, you can. Yes, you can. Right.
I don't know about you, but that doesn't sound joyous to me at all. It's actually a surprise that women come back, and most women in labour will say, I'm not doing this again. But most people do come back and they have more children. So the actual act of giving birth is potentially a very stressful time for sure. So I love the placenta. Seriously, it is the most amazing piece of technology. Us humans, we make this, right? I mean, us females, should I say, unfortunately. You men don't have that capability. Sorry, Dr. Stone, I'm sorry. It is amazing. It's the tree of life. I think that'd be the beautiful picture, right? This piece of engineering, it carries oxygen and nutrients to the baby, and then basically brings back all the waste products. When it works beautifully, really amazing. Unfortunately, there are complications associated with this. The actual leading direct cause worldwide of maternal deaths, and that's 27% of maternal deaths, is caused by hemorrhage. I could go on quite a long time regarding hemorrhage and issues regarding the placenta. We have placenta abruption, retained placenta, low-lying placenta, placenta previa, placenta accreta. It can go on forever. But it's enough to basically say that about 600 to 700 mils of blood go through this lovely placenta to feed our baby every single minute. So if there are issues with bleeding from the placenta, you can imagine we lose blood extremely quickly. And again, we give praise to the midwives because they recognize that effect and they manage it extremely well. The question is, should we eat it? A lot of mammals eat their placenta, right? We're mammals. Why don't we do it? There is a suggestion. Breastfeeding difficulties will be improved. Postpartum depression will be improved if you eat it raw or cooked, or actually you can get placenta pills that are made from dried placenta, a powder. I shall let you make your own decision as far as that's concerned. Okay, I'm going to use uterine rupture because, again, I've experienced it personally. It's very rare. It's resulting in life-threatening maternal and fetal compromise. It's more common when you have a scar on the uterus from previous cesarean sections, but my experience has nothing to do with C-sections. Obviously, working on the Afghanistan border, they have a different kind of culture, different kind of practice oxytocin being one of them that really, there is a campaign to stop the misuse of oxytocin. It's a very dangerous drug to give if it's given in large forms. Oxytocin contracts the uterus with the hope of expelling the baby. If it's used correctly, it's an extremely good drug. The lady that I had was on to her 6th pregnancy, obviously had 5 children at home that she needed to attend to, and was really quite keen to have to be induced. The hospital I work at did not do inductions of labour. We just did normal labour. You'd have to go in spontaneous labour. So she sought a healer. Oxytocin is very cheap. It's about 2 pence a vial in Pakistan. So what tends to happen is that oxytocin mixed with hyoscine, buscopan, and also gravel. All 3 of those are placed together in one syringe, and they're given intramuscularly. Midwives will be cringing because, of course, we titrate it. Very, very sensitive drug anywhere else in the Western world, but in Pakistan it's a little bit different. And inevitably what happened was this lady was given the injection, caused a massive contraction, and because, obviously, of the fact she'd had 5 children before her uterus burst. When she came into the maternity ward, she was she was barely alive. Unfortunately to say that this lady never made it, and neither did her baby. I love this picture too. That poor gentleman really didn't know what was coming. I am an advocate for normal deliveries because I'm a midwife, and if everybody were to have C-section, then of course I think I would be out of a job. So I will always advocate for normal deliveries, but not to harp on too much because the WHO has changed their stance a little. We used to be very pro trying to reduce our C-section rates. But they're not really about that anymore. They actually identify that a C-section is absolutely necessary. It doesn't matter what your section rate is as long as it's done for the right reasons. So if you're having a C-section, you are at risk of hemorrhage, infection, clotting problems, amniotic fluid embolism. And then if you have a repeat C-section again, you increase the risk of placenta previa, adherent placenta, which then could result in, again, major hemorrhage or even hysterectomy. Also, technical difficulties, actually, when it comes to your 2nd, 3rd, or 4th C-section. You can have lots of scar tissue, you can have damage to the bowel and the bladder. But again, that topic can be covered in a whole day's worth of conference, really. It's quite a very good topic to cover. The main point I want to get across as far as C-sections is concerned, when it comes to emergency C-sections, yes, they are essential, I agree. But women having their first baby and a cesarean section were more likely to feel frightened, helpless, and overwhelmed. Having a sense of control is so important to reduce, actually, post-traumatic stress disorders. So as midwives, we really try to empower the women and give them advice throughout the whole. It's very difficult in an emergency situation, but we do our best to try and avoid the stress following the delivery. I think he's happy. So, injuries post-delivery. Again, there is a lot of issues post-delivery, hemorrhage being the biggest one, for sure. But the topic that I've chosen, there's 3 of them, actually. The first one is deep vein thrombosis. When I was a student midwife, we didn't have Clexane, we didn't have any injection to thin the blood. So we were giving lots of advice to ladies not to sit for too long, drink lots of fluid, and keep those legs active. And signs and symptoms to look for, swelling, pain, warmth and redness. So basically, most of the blood clots or thromboembolisms occur post-delivery, it's about 70%. We can actually prevent this happening through screening and treatment most of the time. The actual appropriate use of thromboprophylaxis has improved outcome, although still it's a common cause of direct maternal death. C-section increases this risk 4-fold compared with vaginal deliveries. Well, I think Dr. Felix's photograph of mastitis was better than mine. But thank you, Dr. Felix, for a fantastic presentation. Nipple trauma is quite common, I must admit, you know, not to take away from breastfeeding because it is the best thing to do, of course it is. We have a breastfeeding support group in the Cayman Islands. Their booth is outside. They're a non-profit volunteer group, and they do an amazing job and are available for advice at any stage. So thank you to those girls. I mean, really, to speed up things, there's not a great more I can say about that, or to know it exists, really, more than anything. So postnatal depression, approximately 15% of all women will experience some form of postnatal depression. There's a lot of reasons that might happen, including changes in hormones, feeling tired and sluggish, anxious regarding newborn babies, lack of sleep. And there are certain signs that we can be aware of: mood swings, withdrawn from family and friends, lots of crying, and difficulty bonding with baby. And for a first-time mum, you can have all of these symptoms. Doesn't necessarily mean you do have postnatal depression. So they suggest that 50% experience a shift in emotions. We call them the baby blues. And that usually happens when they're on the maternity ward day 3. Lots of crying, but there's no rationale behind it. They don't know why, and it's usually the hormones. And 15%, as I say, will go on to develop more severe and long-lasting depression. Postpartum psychosis is another story, and of course it can lead to that. It's very rare. It needs emergency medical attention, things like severe agitation, confusion, paranoia, hallucinations, and an increased risk of suicide. What we really need to do globally, really, is to screen for mental health, wellness, and early intervention. If you notice or suspect that a friend or a loved one has postnatal depression, please help them seek medical advice immediately. Don't wait. Thank you.
So thank you so much for that presentation, Nurse Caroline. And guess what? She's my only presenter that I didn't have to hold up a 5-minute warning. So yay! She's helping us catch up on time. As a token of our appreciation, I would like to present you with that on behalf of all of us at Women's Health Department. And again, thank you so much for that. In the interest of time, what we're going to do is sort of cut out the Q&A after each presentation, and then maybe do 1 or 2 questions after the next presenter before lunch. So if you have any burning questions for Caroline, just jot it down, and then we can ask it a bit later. All right, so I think we promised you a day of learning and fun, and I think we have delivered on the learning, right? We've had some very good presentations, excellent presentations in the first half of the conference. And just as a little commercial or advertisement to let you know that the fun is coming. So we will be having some raffle prizes that will be done. We'll do one before lunch, and then we'll do a couple others in the afternoon. And we do have some great prizes, and without telling you what they are, I'll give you a clue. One of them rhymes with vacation. The only thing is that you do have to be present to win, so I want to encourage you, if you can stay to the end of the conference, then you have a chance of winning a wonderful prize. Okay, so we're going to move right along to our next presenter, Ms. Candace Lankford, who will be presenting on navigating your pelvic floor strength and symptoms. Ms. Lankford is a physiotherapist who is focused solely on pelvic health. She is from South Africa and completed 2 Bachelor of Science degrees at the University of Cape Town. She feels very passionate about sharing, educating, and empowering, and she therefore went ahead and created an online platform called Nurture. She also feels strongly about normalizing the narrative around taboo topics to increase access to appropriate care. And just so that you note, I am, in the interest of time, not reading the full bios on our presenters, but I do want to encourage you to look in your program and just read through it to see all of their wonderful accomplishments and educational background. So without further ado, Ms. Langford.
Thank you. Okay, first time using a little clicker, so I will try my best. So thank you everyone for being here, for sharing your precious time with me. My name is Candice Langford, and I'm a pelvic health physiotherapist with a special interest in pelvic and sexual health more particularly. I am speaking today, as mentioned, about pelvic floor strength and symptoms. But I'm going to go into more to do with the misconceptions around strength and the symptoms that may come alongside with that. Oh wait, I must press it that way. So just to get started, I tend to move off, please excuse me. Just to get started, I wanted to make sure everyone knew what the pelvic floor is and where it is, just in case you are not familiar. So it's often termed as a sling of muscles that are at the base of your pelvis or the base of your trunk, so essentially between your legs. This muscle, just like any other muscle, has to have the capacity to fully relax and lengthen and soften. So with regards to the pelvic floor, with that relaxation, we're talking about opening of entrances. So that might be the urethra, the vagina, and the anus. With contraction, just like any other muscle, we're looking at shortening, activating, and now with the pelvic floor, we are talking about closing off these holes that we have just mentioned. And I know the color's not so clear on this side, but what I want to do next is go to a few of the functions of the pelvic floor. So with this full contract and full relax, we're looking at maintaining continence, so keeping pee and poo inside until it is appropriate to let it go. If there's dysfunction here, the individual might be experiencing leaking. Then we can go to allowing passage, so relaxing, opening, letting go, to allow urine out, to allow a stool out. So we have to have this full range of motion. Excuse me. So when we are allowing passage, if there's dysfunction here, the individual might have constipation, urinary retention, and sometimes even frequent UTIs. So if we're looking at load transfer, the pelvic floor integrates into the rest of your muscles, your pelvis, your hips, your lower back. So when you're doing activities such as walking, we need to make sure that the pelvic floor is functioning through its full range in order to achieve appropriate and effective function. When we talk about the pelvic organs, the pelvic floor plays a role in supporting the pelvic organs. The organs are suspended by connective tissue, but when it comes to pelvic organ prolapse, the pelvic floor is playing an even more important role in contributing to support. Then if we go to pleasure and reproduction, with regards to reproduction, especially considering the title of today's event being head-to-toe impact of women's reproductive health, we are talking about the ability to fully relax and let go of these muscles to allow for penetration if the individuals choose to achieve conception through the more traditional penetrative intercourse methods. Then with regards to pleasure, we need to remember that the pelvic floor is supplied by the pudendal nerve, which has autonomic function. So with regards to pleasure, the pelvic floor itself contributes to orgasm through a rhythmical contraction alongside the uterus in some people, not all. So when there is dysfunction here, the individual might have difficulty achieving orgasm, they might have delayed or blunted experiences. So how important is this? Is it worth me practicing as a pelvic health physiotherapist? Is there even a need or a call for this? So let's just speak about the prevalence very quickly. In adolescents, wouldn't think, but in a study where they looked at about 200 individuals around the age of 17 that went to attend a clinic, up to 31% of them had urinary incontinence. So although at this age, it might not be bothersome, according to the study, as we move through life, if these symptoms are not managed, it can only be imagined that these symptoms then become a little bit more bothersome. So if we look at the general population, 1 in 4 people, look at the crowd in this room. 1 in 4 individuals experience pelvic floor dysfunction at any time. Now, when we start going towards perinatal population, 50% of pregnant individuals will experience pelvic floor dysfunction. There are many different types, yes, but 50% is significant. And if we start looking at our athletes, think about the Olympics, we can look at about 36% of individuals experiencing something such as urinary incontinence, which you can imagine is only going to impact their performance, their confidence, and their ability to achieve. And just because, once again, the title of today's talk, we're going to go into postpartum dyspareunia. So dyspareunia is painful intercourse, painful penetration, and we can see that in 35% of individuals in their postpartum time, we're mainly looking at the first year postpartum, experience painful penetration. That is not okay. There's so much that can be done for these individuals. If we look a little bit more specifically, about 2 months postpartum, 40% of individuals are experiencing painful penetration, and up to a whole year postpartum, 20% of individuals are experiencing this pain. So what happens? These topics are taboo, right? They're difficult, they're uncomfortable. We are not always reporting them along the correct avenues. So what do? We Google, right? What can I do if I've got this dysfunction? And we come across the Kegel. I'll go a little bit more into the Kegel now and how I feel about it. But typically, it's strengthen, strengthen, strengthen. Just activate it. Just go and do however you do and perform this activity. Okay, so this Kegel, where did it come from and why are we still using it, right? It was in 1948 that Arnold Kegel realized that by activating the pelvic floor muscles, it can help to resolve pelvic floor dysfunction. And now, all these years later, we're still relying on this Kegel. So I like to relate this to an arm injury, right? You've got a sore arm, you go to a specialist, the specialist says, okay, I'm not going to look at the details of this, but I'm going to just tell you, just go and do a bicep curl. One simple exercise, that's it, just a bicep curl. Sounds ridiculous, right? You want to know the details of this arm injury. You want to find exercises that are specific to that person's presentation. What can we do for them as an individual? So looking at exercise for the pelvic floor, can we potentially move away from the Kegel, this one boring exercise that's really difficult to progress, and move towards exercise? Look at all this research that we've got in and around exercise. We can apply this to the pelvic floor. It should be inclusive, dynamic, include proprioceptive input. It should include the length. Remember that function. You have to have the ability to let go in order to achieve functions such as passing stool, passing urine, penetrative intercourse. We can't just be talking about shorten, 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 Kegel, Kegel, Kegel. There's a lot more exciting work that can be done for the pelvic floor in general. So can we expand this view of what to do for pelvic floor dysfunction? Then, is the person even doing it correct? Are they doing it right? Are we touching this area? If a person comes to you with a knee injury, you don't assess them through their pants and expect to know what's going on. We need to palpate, we need to assess, we need to reassess, we need to progress that individual. So can we make it a little bit more applicable according to the research that we have for every other tissue injury that we've got in the body? So while I'm going through this slide, I would love for you to take your hand and squeeze it. Just hold it in a fist, all right? So now, the pelvic floor in general, we are told disinformation around this region of the body. Suck it in, tighten it up, it must be flat, it must be short, it must be tight. Tight is right, tight is better, right? So we're predisposed to this tension. Then, in a research article done by a lady named Van Velden, I think it was 2006, what she did is she exposed individuals to threat. She wanted to see, when we are exposed to threat, what happens? What happens to our body? What is our behavioral response? So she measured all the different muscles in the body to try and see, when we experience threat, what happens? Two things. The upper fibers of the traps go into tension. Threat, fear, we all familiar with that. We can see it. When we see it, we have the capacity to relax. If someone says to you, oh, your shoulders are looking so tight, relax, right? The other thing that happens, pelvic floor tension. Two things, amazing, right? We think increased heart rate is the first thing that's happening, but we preempt threat by tensioning up our muscles. So the problem is that the other muscle is the pelvic floor. We don't see it. We're often very disconnected from it. We might not be in tune as to how to release this muscle. So society is telling us, shorten, tighten, activate, squeeze. Then fear and threat, whether it's a fast-paced life, stressful life, physical stress, emotional stress, we are activating this pelvic floor that much more. And are we doing the person a service by telling them to go and shorten more? I'm sure by now your hand, if you're still holding it, is feeling tight, uncomfortable. If you were to now release and relax that hand, it's difficult to perform a function, right? You might have altered sensation, stiffness, discomfort. If we are just doing this with our pelvic floor all the time, we're not going to be able to achieve those functions that we mentioned in the first slide. Compare this, for example, an individual that attends a clinic and they say, or they Google, they say, I want to achieve the function of being able to run a marathon. We hope that they're doing things such as proprioceptive input, strengthening, hopefully a little bit of autonomic nervous system downregulation, some stretching, and of course running. Much more comprehensive in order to achieve that goal. Can we bring that into the pelvis for pelvic floor dysfunction? Okay, so you might need to look up at this slide over here behind me. So what does it look like when these people, these individuals, 1 in 4 over here, are trying to resolve these symptoms and they come across this message of strengthen, 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 shorten, shorten, shorten? We might come with urinary incontinence. We do a Google. We might even attend a medical practitioner that advises us. We know that you just need to do some strengthening exercises because we might not feel comfortable to dig into these details because there's most certainly still taboo in and around the pelvis. So if this person some way receives the advice of doing more and more Kegels, you now know what that's going to feel like, further shortening. We're going to have hypertrophy, pain, altered sensation, discomfort, and stiffness in those muscles in your pelvic floor. This then leads to further dysfunction, other forms of symptoms, painful penetration, constipation, not having that ability to let go and downtrain the pelvic floor. And we know that in individuals that do not manage symptoms such as pain after 6 to 12 weeks, they're going to start activating those central mechanisms, and then we get individuals that are moving into the more persistent pain. Used to be termed chronic pain, but now we are using words wisely, and we're talking more about persistent pain for these individuals. This is going to cause frustration, changes in their quality of life, self-efficacy, right? We want our patients to believe that they can influence the way in which they feel. And if after weeks and weeks and weeks of doing Kegels and they're not getting better, they're in fact getting worse, what is happening? We're impacting their self-efficacy. And not only is it having a financial burden on them, but on the entire system. And this is why we definitely need to make a change and just feel comfortable and confident moving into this area of pelvic floor management. So I just wanted to touch on a few things that I see in practice, that you might see in practice, and you might be experiencing on an individual level. So what happens if we're just shortening and tightening these muscles? The pudendal nerve supplies the pelvis with its motor, sensory, as well as autonomic function. So if we're restricting, if we are compressing, if we are irritating these nerves, think about your hand and how you might have had pins and needles. This might then relate to symptoms in the pelvic floor. So it might be vulvodynia. So vulvodynia is just generalized vulvar pain. Right? It's not a very specific diagnosis. If we look a little bit further, we can look at vestibulodynia. So vestibulodynia is pain or burning and uncomfortable sensations at the entrance of the vagina. So if we look at vestibulodynia when it occurs, if we look at the bottom of the clock from 3, 6 to 9 o'clock, if the individual is experiencing vestibulodynia in that region, we can relate that to hypertrophy. If it's above, then we can relate that more to hormonal changes that the person might be experiencing. So when we do that Q-tip test and we're looking at the vestibule, can we identify this person is having vulvar or penetrative pain because of tight pelvic floor muscles? So then moving further, if we look at lymphatics, the pelvic floor is a sump pump. We spoke about lymphatics earlier in today's conference. The pelvic floor contributes to moving fluid. If there is tension, rigidity in this region, we're not going to get this pump working. It's not going to help. And we end up with patients with vulvar varicosities, with pelvic congestion, and this pressure in the pelvis can contribute to symptoms such as pelvic organ prolapse. And funny enough, with this pressure down, what does the pelvic floor do? It says, threat, I'm going to help. I'm going to activate and cause more tension in the pelvis to help support all this pressure that I'm sensing. So a patient might present with pelvic organ prolapse. Their issue might not be just go home and do strengthening exercises, because they may be predisposed to tension that first needs to be released before they then exercise and strengthen with power and endurance through the entire range of motion. So once again, just like the knee, we should be assessing, putting our hands on and really, really seeing what's happening, as opposed to allowing our patients to just go and Google. We need to speak openly about these symptoms. Load transfer, if there's rigidity in the pelvis because we've got this really stiff region that we just have to try and suck in all the time. Squeeze your bum, we want a tight bum. Squeeze your tummy, we want a flat tummy, right? These messages. And go and do Kegels on top of that. If there's this rigidity, it's going to impact the person's ability to sway their hips, to rotate their lumbar when they're doing something such as walking. So individuals with endometriosis, for example, they get something that we call a frozen pelvis. Every month, they're getting threat detection. Every month, you know, oh, in a couple of days, it's going to be so painful, and I'm going to be debilitating pain. So what do? We sense threat, we tension up to protect ourselves. And you'll see in patients with endometriosis, the way they walk, very slow, small gait, the whole pelvis moves. There's no relaxation in and around their pelvis. What can we do to try and help to improve this range of motion, improve hip mobility, improve lower back pain? So in a study by Sinead Dufour, who I've had the pleasure of being able to interview, Sinead found that only looking at 85 people, so given it's a small sample, 95% of those individuals that presented with lower back pain, no concern for their pelvic floor, 95% of them had pelvic floor dysfunction. So in those patients that have got unresolved, long-term lower back pain that's not going anywhere, can we maybe look at what's happening in their pelvic floor? Looking at endometriosis, it's March, we've got her, right? And other pelvic floor concerns that might be relating to pain in the pelvis. Specifically looking at deep infiltrating endometriosis, these were both 2021 studies, so nice and recent. They found that individuals had a higher likelihood of having pelvic floor muscle tension, pelvic floor dysfunction, and lower limb tension. Remember how we spoke about everything being connected? It's not just in the pelvis, it's impacting everything else, right? And here they found it in the lower limbs. Wonderful. In 2021, another study also found that by pelvic floor physio, helped those individuals to release and relax that pelvic floor through their full range of motion, also reduce the likelihood of superficial dyspareunia. Remember we spoke about vestibulodynia, beautiful word, and it also reduced the chronic pain or persistent pain measures in those individuals, and that was a significant reduction that they found by just sending these people for comprehensive insight to see what else can we do to help manage your pain. And then if we look at the canister, so this image on the left-hand side, you'll see how it starts to speak about everything being connected. So every time we breathe, I'm not used to having a mic. Every time we breathe, the respiratory diaphragm moves down, the pelvic floor moves down, and they work together, right? Often termed as the canister or the functional unit. And when we take these beautiful big breaths, if there's rigidity somewhere in the system, we're not going to get as much translation. We're not going to get this beautiful movement. And with a big, nice diaphragmatic breath, when we are activating our parasympathetic nervous system and we're breathing nice and deep, what's happening? We're getting about a 2 to 4 centimeter movement down of the gut. That's going to help with gut motility. It's going to help with constipation. If there's rigidity in the system and this person is now unable to take these beautiful big breaths, allowing their belly to expand, what's happening? They're taking these apical breaths. They're not getting as much vagus nerve stimulation. They're not going into that parasympathetic side of life as much. And now are we exacerbating the sense of threat because we're constantly taking short, shallow breaths because everything is really tight and we live this fast-paced life? Can we maybe influence the pelvic floor, help this person take beautiful big breaths, move their tissue, down-regulate their system a little bit in order to contribute to managing constipation. Think about postpartum. Think about diastasis recti. If there's rigidity and we're not stimulating the abdominal wall, the pelvic floor with each and every breath, or specifically when we're doing breath work with the individual, that's going to then impact that individual's ability to recover when it comes to diastasis recti rehabilitation. And I see this in practice. My little clicker. So what can we do? I'm sure you've picked up through this talk. When we're talking about pelvic floor dysfunction, there are so many factors that we can include in our management. We can look at strength, but not just shortening. We're looking at the full range. We're looking at power. We're looking at endurance. We want it to be functional. If your dysfunction is coming when you're getting out of the car, when you're going for a run, when you are pole vaulting, when you are power lifting, that is what your exercise needs to look like. We're not going to be able to progress to something such as running a marathon if we are lying in a bed very, very still and doing on and off Kegels. That's not functional. That's never going to progress to running a marathon without leaking when you are performing your activity of choice. We can look at range of motion, like I said. We can look at control. Can you control that let go? Or is there let go suddenly without control? And then something such as stress incontinence. Timing, is it coming on at the right time, just before you sneeze? Are we able to get that timing to come on at the right time? Can we intervene in order to help the person to get there? Awareness, and this is where I spend a lot of my time, improving that person's homunculus, their vulva. How does that look? How much representation does that have in their brain? How aware are they of their body? Is there a disconnect? And if there's a disconnect and we know nothing about our body below the belt, how are we expected to identify dysfunction? How are we expected to perform activities to adapt? And how are we expected to progress to our specific goals? Okay, so I just wanted to use this as a reminder that this can occur at any time frame in life, right? It might be a young teen at 17 with incontinence. It might be her first menstrual period, and it is excruciating, and they need to be assessed for something such as endometriosis. It might be in your early 20s, university, going and exploring, expressing yourself as an individual, like traveling the world, trying new things. What's happening with your pelvis then? What about trying new exercises? Are you experiencing pain? Is there laxity? This is not isolated to the childbearing years, although it's still important within the childbearing years. With fertility, conception, is the experience of vaginismus, is that impacting that person's ability to conceive? When they're pregnant, are they experiencing something such as pelvic girdle pain? So pregnancy-related pelvic girdle pain, a lot of amazing research coming out in and around pregnancy-related pelvic girdle pain. And we don't need to keep our knees together. We don't need to keep really rigid. We actually need to move and open and be comfortable with stretching our adductors, and that is more effective in helping these individuals to manage their pelvic girdle pain during pregnancy. Going on into older adulthood, you might have young children, you might be experiencing little niggles, but you've got 3 little kids at home, you're too busy to focus on yourself. That little bit of incontinence that comes every time I giggle, I can put up with it, right? No. A little niggle is not just going to disappear. What often happens and what I see in practice is that as we age, then that little niggle now becomes very bothersome. And if we manage it early enough, because there's no taboo, there's no shame, just like you would treat a shoulder, you can treat your pelvic floor, and there shouldn't be anything holding you back from going and assessing and treating, which is my intention in my educational work that I do. So specifically, just to zoom in on the topic of today and looking at sexual pain in general, let's see what happens. Dyspareunia, you might think, oh, 7.5% is not so much, that's okay, right? But this is 7.5% of the population in the last year, not just a once-off experience of penetrative pain. 7.5% of people have experienced penetrative pain for a full 3 months. That needs to be managed because above 12 weeks, we're going into central pain mechanisms. If you look once again how that increases as you go into the postpartum world, up to 35%, which we've discussed. And looking at Cayman's population, mainly sitting at the 25 to 54 age range, and with the intention of growing the Cayman population, we really need to pay attention to this postpartum dyspareunia that people are experiencing. Vaginismus is an inability or difficulty achieving penetration, and that is seen as and it's also associated with a sense of anxiety. Patients will close their legs, withdraw, lift their bum, hold their breath, and really try and escape in their mind when they're engaging in penetration. And this might be on exam or even when being intimate with a partner. But this is very different when we look at the East and the West. On the East, it's going between 27 and 68%. And seeing that Cayman Islands is a real beautiful coming together of so many different people. We can't look at 8% and ignore it. Then going further into vulvodynia, a little bit higher there, that's that generalized vulvar pain. Is that why our numbers are a bit higher? Because it's quite generalized. If we zoom in a little bit, we're looking at the vestibule in particular, 16%, very relevant. I'm pretty sure it's higher than that because I see it a lot. And then once again, looking at endometriosis, important because it's March, and looking more specifically that 86% of individuals with endometriosis will also have penetrative pain. So what can we do as a pelvic health physio, right? We can look, we can see, we can assess, we can manage, we can work with these people and help them. So that is my role here on the island. And here we'll see I'm educating, visualizing, helping an individual to identify what it is that's going on inside their body, helping them to connect and really see what's happening. Okay, so how does this happen? Referral, might be self-referral, it might be through a doctor. And on assessment, we're looking biopsychosocially. You saw earlier, there's so much more than just go home and do your Kegels. We are looking what's happening internally. As I assess internally, I'm feeling how much strength is there? What's the endurance? What's the power? I get my patients up and standing, and I say, okay, come, let's see what's happening in standing, because pelvic pressure is very different when gravity is working with them, right? So we're seeing what happens to those pelvic organs, what's happening to strength. I also look and I see what's happening at the vestibule. Is there vulvar lichen sclerosis? Is there dryness? Is this person breastfeeding and now there's a hypopigmentation around the urethra, and that's relating to that person having pain with passing urine? Can I then refer them and say, doctor, please can we help this patient with some topical estrogen because they're really, really struggling with pain and it's avoidable. There's so much that can be done. Treatment, once again, we can use assessment, ultrasound, internal, external movement. We're really seeing how this person experiences their symptoms. We can't generalize. It's not just arm pain. We can zoom in and find out what this person is experiencing and when. With regards to treatment as well, we're looking internal and external for that treatment. We're using ultrasound for biofeedback to try and get you to really understand what's happening in your body. Education, helping this person to achieve their goals. When I'm looking at progression, I'm looking at that person's goals, not my goals for them. We can help that person to identify where they want to be, when they want to be there, and how can I facilitate that process. I'm very much maybe a bad saleswoman, maybe. I really like to encourage my patients to be independent. I send them home, and I'm sure this is the same with pelvic health physios in general. We need to make sure that we are working on these individuals' self-efficacy, because this taboo part of our body that is already so difficult to treat and manage, we need to have a sense of control over what we can do to influence our bodies. So I really try and kick them out the door as quick as I can, obviously always as appropriate with the patient and when they're ready for it. And then, of course, there might be some level of referral. I didn't think this was going to work. This is a bunch of videos, so I prepared for it. So that is an IUD. Consent is obviously obtained for the use of these, so it's just in case. I showed this to my husband, and he was like, Candice, you have to tell them what that is because you're going to scare people. So if we look here, that is what we would visualize as a very full bladder. We can look at the pelvic floor at the base of that, so I can help the person to identify, hey, you're holding so much tension. Can you just relax and let go? The person learns, oh, is that what relax feels like? Maybe I can do that when I'm sitting at my desk reading my emails and not holding my breath. email apnea is a real thing. This is now on a sagittal plane, so we can look what happens to that bladder when that person is sneezing, coughing, laughing. Is there organ descent? So this is with the bearing down. You can see that change, that translation of the bladder. How much is that occurring, and when is it occurring? Is it in standing? Is it in lying down? Over here, we're looking at bladder neck closure. So on activation, there's a closure over there. This might then warrant, okay, I don't see much happening there. Let's do an internal and just reassess and see if this is contributing to your stress urinary incontinence. And over here, this might look a little bit abstract, but over there and over there, we're looking at the rectus abdominis muscles, and we're looking at diastasis recti. So we can see how much bulk is there, what happens when that person activates, and how much distance, and can we monitor it and measure it over time. That's a whole lot of references if anyone would like them. And then that's the end of my talk today. I hope that you feel like you know and understand pelvic floor exercise a little bit better, and that you feel confident in helping individuals to head over to the right resources for any dysfunction they might be experiencing. Thank you.
Thank you, Ms. Langford, for your presentation. It was very informative, and we really appreciate you joining us today for our conference. And as a token of our appreciation, we'd like to give you that little gift. Thank you. So I did promise that we would hold the questions until the end of the two presentations. So just in the interest of time, we'll really take one question for Nurse Caroline and maybe one question for Ms. Langford. If anybody has a question for either one of them. Dr. Stone. One second, let me give you a mic, because I don't think we can hear you. For the online people, I mean.
Check 1, 2.
Candace, was a great presentation. I had a question about your opinion on when and how to relate to using pelvic floor strengthening with patients who have had a traumatic birth and maybe they had a repair. Do you have a belief in the delay, or when should one best be told to start exercising, and how to go through that process?
Amazing, yeah, thank you for the question. So typically, if I personally believe that every single pregnant individual, at least in their second trimester, should attend a pelvic floor physiotherapist to learn about their body, to learn how to activate their pelvic floor. In this time, we are teaching them what's going on in their body. We know that during delivery, as contrary to popular belief, the pelvic floor doesn't push the baby out. The pelvic floor has to get out of the way. So in this process, we're teaching them that. In that pregnancy phase is when I'm teaching my patients, okay, those first weeks, 6 weeks postpartum, if you need me, I'm here. But also, this is what you can do. So in those first 6 weeks postpartum, we're encouraging a certain type of exercise, and we might teach them exercises. But I also believe that straight after the patient's been for their 6 weeks postpartum checkup, they've had an internal with their doctor, that about the 8-week mark is when I usually get people in. That just seems to be time-wise. Everyone's too busy before that. I totally understand. But at 8 weeks is usually when we would like the patient to come back in, have another internal assessment, talk about pee, poo, pleasure, pain, periods, pregnancy, all the P's. What is actually going on in their life, and what symptoms are they experiencing now? So yeah, about 8 weeks is when I get people to come back in.
Thank you. Yes, Dr. McIntyre?
Yes. It's addressed to Caroline. It's not really a question, it's a comment. I think you all heard her say that she had spent time in Pakistan. She actually took a 2-year sabbatical from her work as a hospital midwife. She went over there with Doctors Without Borders to give her knowledge and her experience to less fortunate people. In view of this, I think that she probably deserves a round of applause. I think with more people like this, with her willingness to share, then we will eventually maybe eradicate all prejudice and maybe have some peace in the world, which is very important at this time. Thank you.
Thank you, Dr. McIntyre, for highlighting that, and we are very proud to have Caroline as part of our family at HSA. Okay, so I promised you that we were going to do a raffle right before we break for lunch, so we are going to do that now. I believe when you registered, you would have gotten a little raffle ticket. So for those of you who have that, get out your raffle tickets, and we are raffling a gift card to Kirk Freeport and one to Victoria's Secret at this time. All right, so the lucky person is the one who has 586765. That's 586765. Oh, Shantae, come forward, please. Let's verify. Not that I don't trust you. All right, for the second one, we have 586774. 586774. Nobody? All right, do another one. $586,860. Yay, all right, we have a winner. All right. All right, so thank you all so much for your patience during this morning session. We're a little bit behind time, but I hope you have been enjoying it and learning a lot. As mentioned before, what we're gonna do for lunch is have you get your boxes. The box lunches will be out in the hallway there, and then you can make your way back in here. We'll give it 15 minutes to collect your boxes, so it's about 1:50 now. So at 1:30, we will resume to begin our second half. Thank you to Health City Cayman Islands for sponsoring our lunch today.
You and me, we used to be together, every day together, always. I really feel I'm losing my best friend. I can't believe this could be the end. It looks as though you're letting go, and if it's real, well, I don't want to know. but together mighty, fried me. And as we die, both you and I, with my head in my hands and sit and cry. Don't speak, just what you're saying. So please stop explaining. Don't tell me 'cause it hurts. Don't speak, just what you're thinking. And I don't need your reasons. Don't tell me 'cause it hurts. It's all ending. Gotta stop pretending who we are. Reasons. Don't tell me 'cause it hurts. Don't tell
Old man turned 98. He win a lottery and died next day. It's a black fly in Chardonnay. It's a death road party, 2 minutes late, and it's erratic. Do you think? It's like rain on a wedding day. It's a free ride when you're already paid. It's a good advice that you just can't take. And who would have thought it figured? Mr. Play Safe was afraid to fly. Pack his suitcase and kiss his kids goodbye. He waited his whole damn life to take that flight. And as the plane crashed down, he thought, well, isn't this nice? Isn't it ironic? Do you think? It's like rain on a wedding day. It's a free ride when you're already paid. It's a good advice that you just can't take. And who would have thought it figured? Life is upon the way of sneaking upon you when you think everything's okay and everything is going right. Life is upon the way of helping you out when you think everything's gone wrong. Everything goes up in your face. traffic jam when you're already late. No smoking sign on your cigarette break. It's like 10,000 spoons when all you need is a knife. It's like meeting this woman, she's my beautiful wife. Isn't this ironic? Do you think? Isn't this ironic? Ha! It's like rain on a wedding day. It's a free ride, and you're already paid. It's a good advice that you already take. And who would have thought it's given? Oh Lord, at the wedding day.
Take blood keeps on turning round forever. Patience, love is coming round for your pleasure. Wait now, no use trying to push. There's no need. People go against the grain with the greed. I've been here before. It ain't gonna work no more. I've been here before. It ain't gonna work no more. Focus, your mind will be strong. No distractions. Soak up wisdom all year long. And then take action. I've been here before. It ain't gonna work no more. I've been here before. It ain't gonna work no more. I've been here before. It ain't gonna work no more. I've been here before. It ain't gonna work no more. Oh no 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 more. I've been here before. It ain't gonna work no more. No no more. I've been here before. It ain't gonna work no more. I've been here before. It ain't gonna past the windows of the blissfully dead, looking for the victim, shivering in bed, searching at fear in the gathering gloom, and suddenly a movement in the corner of the room. There is nothing I can do when realized with fright the Spider-Man is having me for dinner tonight.
Caymanian female doctors. So Dr. Kimone Fraser and Dr. Kendra Chisholm will be presenting clinical pathology of benign functional ovarian tumors. And I'll briefly introduce both of them. So Dr. Kendra Chisholm, who is originally from Northside, Cayman, she has traveled all over into Europe and South Africa and Tanzania, doing research and clinical work. And she became interested in tropical medicine and decided to then pursue a medical degree at UWI St. Augustine. And after completing her internship at the Eric Williams Medical Sciences Complex in Trinidad, she returned home to Cayman, to the land of soft, fresh breezes with her family. And we are happy to have her with us at the HSA. While she was working in the pediatric department, as a junior physician, she became increasingly aware of the need to strengthen adolescent services for the young people of the Cayman Islands. And she recently obtained a postgraduate diploma in adolescent health and advocacy at UWI, Mona in Jamaica, and while at the same time initiating adolescent-specific services at the HSA. So give a round of applause for Dr. Chisholm. And presenting along with her, I'll just briefly go ahead and introduce Dr. Kimone Fraser as well. She attended the University of the West Indies, Mount Hope and Mona campuses for her medical degree. Dr. Fraser then went on to complete a residency in pathology she went to Jamaica to begin, and that was in 2015, and she completed that in 2019 and came back home to Cayman in 2020, where she joined the HSA as a pathologist. She has a published paper to date in the Journal of Clinical Pathology, and she has 2 more that are in the works, and they're currently being edited for publication. She's married and enjoys reading and exploring food in her spare time, and we're so pleased to have her presenting today as well.
Hello, good afternoon, everybody. I was going to say welcome back from lunch, but hi, I guess we're here to be your in-lunch entertainment, but I just wanted to say it definitely is a pleasure to be here. Can I take off my mask? Yes? Okay. It's definitely a pleasure to be here at this annual Women's Health Conference, really just recognizing leading women, and I would just like to pay special mention, of course, to the Minister of Health, so Honorable Sabrina Turner, as well as our CEO, Ms. Lizette Yearwood, who is here today as well, and just for your guys' continued support with this ongoing pandemic. So thank you. And of course, I would also like to thank Dr. Jefferson, who is always much appreciated at supporting these events, as well as then Dr. Lamsey Ebanks, who is instrumental in the advancement of pediatric care here in the Cayman Islands and has always been supporting us. And also just thank you to all of the ladies here, right? Because we are in celebration of International Women's Day, and a very warm welcome to you and to all of our attendees watching here or watching in some other location, right, virtually. And I just want to say that today we are going to be talking about the benign tumors of the ovaries. So just to give an overview, we're just going to talk a little bit more about what exactly are these tumors and how do they affect us. So what are the treatment options that are available? What really can happen? Like, what are we going to be looking out for? What do we need to keep in mind? And then I'll briefly go through a couple of case reports and then just kind of summarizing with a few suggestions in terms of how can we really improve care? And then, of course, just ending after that. So in terms of what we're really talking about, we are talking about ovarian tumors that can affect young women. I know that sometimes when we hear of tumors, we might automatically think of increased age. However, we found that these tumors are in fact more dominant in the younger reproductive years. We've known that there's about 1/3 of these females with the tumors are actually coming and they're having regular periods. And it's about half of the females with these tumors that are presenting with irregular menses. And what's important to note is that they do have the potential to become cancerous. And the other aspect of that, on the flip, is that, of course, we know that the likelihood is low, and it is especially low for women of childbearing age. So moving on really to the classification of ovarian tumors, this can be done in different ways. So for example, by the cell type. Is it a serous cell? Are they clear cells? Perhaps it's undifferentiated. It could also be via the growth pattern. Is it solid? Is it more liquid? And are we really kind of considering whether there's a presence or absence of invasion? So is the tumor invading the surrounding structures? Are we concerned of this being potentially suspicious? Are we concerned of a malignancy? So these are the aspects that are considered when classifying tumors in this way. Okay, so just this slide really is just focusing on the different types of benign ovarian tumors. So really, in terms of us relating it to the ovaries themselves. So here's the image of the ovary, and we can see that on the surface lining here are the epithelial cells, and then we've got the stroma, and these have the cells that produce the hormones. And then the germ cells are the cells which eventually become the eggs. So in terms of the epithelial cell tumors, so for example, a serous tumor or the Brenner tumors, we know that these are the tumors that end up being the most common. For the stromal cell tumors, for example, like a fibroma, even a thecoma, these tumors secrete hormones in such a large amount that they're the ones that tend to be easier picked up, like on your clinical assessment. And then, of course, just lastly, the germ cell tumors. So, for example, the mature cystic teratoma, or as we better know it sometimes, the dermoid cyst, these are the ones that affect the younger women. And with that, we always think to ourselves, okay, so what about the issues of fertility? Has this female completed her family? But the truth is that if we actually catch these tumors early, then we are able to still preserve the fertility for these females. He's telling me to point down. He's like, just point here. All right. So in terms of hormonally functional ovarian tumors, they do exactly that. They are tumors which function is really to secrete one or more hormones. And with that, we have a variety of effects in terms of things that then become clinically manifested in the patient. And this, of course, has implications for the diagnosis and then the treatment. So one of the common or more common germ cell tumors is a granulosa cell tumor. And we know that in the pediatric population, those tumors can present with precocious puberty. However, in women of reproductive years, they can have irregular menstrual bleeding. And then, of course, in the postmenopausal women, you notice that they would have abnormal uterine bleeding. So just to mention some of the factors that can increase the likelihood of these tumors, we know that with early menarche, so the earlier a female starts her period, then they are at an increased risk of these tumors, and that is mostly because they have a longer period of being exposed to these reproductive hormones. Obesity is another risk factor, so being overweight and being obese, we already know, leads to a myriad of different hormonal imbalances, and that can also lead to an increase in tumor production. And then, of course, we want to consider drugs. So tamoxifen, something that we would regularly see used in the prevention and treatment of breast cancer. Here we've seen that studies have shown that there's a 15 to 30% increase in the persistent ovarian cysts. So we know that those females that are taking this therapy are at an increased risk of these benign ovarian tumors as well. And then lastly, really just to mention, is the genetic predisposition. So we know that in some cases, there's just a family history of these tumors. So for example, dermoid cysts. So really, just to go through and to mention a little bit about how these would present. Well, sometimes they don't present at all, and with that, I mean that sometimes they can be asymptomatic. So for example, a patient would come in for her annual or maybe 3 yearly if she's just coming in with her pap smear. And then on bimanual examination, you really notice it as an incidental finding. Other than that, you can have the complete extreme to this, where patients are presenting with such severe pain. And then, of course, one of the common things to do would be to go to the emergency room. And then when they're there, they have an ultrasound. And then that is the imaging then, which has told us about this pelvic mass. Other than that, we know that abdominal swelling is a common symptom, especially if it is that the tumor is particularly large. They can also have painful menses. They can have pain during intercourse. And of course, hormonal dysregulation. So we know that in these situations where the hormones are being produced by these tumors, you can have virilization. You can have the same menstrual irregularities that we were mentioning before. And in medicine, it's always important for us to consider the differentials. So for example, what would the other causes of pelvic pain be in a situation like this, even if we are quite caught on the idea that it is a benign ovarian tumor? We would still want to rule out some other causes. So for example, is it a complication of a sexually transmitted infection, like pelvic inflammatory disease? Or perhaps it's a tumor in another location, like in the uterus. Or it could be tumors that are related to the gastrointestinal system, so perhaps a tumor in the colon or an appendix mass. So some of the investigations that we were done to either confirm or to rule out whether or not we are thinking of these other differentials or whether it's a benign tumor is things like a urinalysis. So are we considering, is this something else when the patient is presenting with urinary symptoms? We also have to think about a complete blood count. So is this possible that we are trying to rule out an infection? And then we've got the tumor markers. So their levels will be able to guide us in the further management. And then of course knowing that in terms of the radiological investigations, it's really the ultrasound, which is the most effective way of diagnosing these tumors. And other than that, we know that some may need diagnostic laparoscopy. And then the fine needle aspiration is really in terms of us getting together, sending that off for cytology testing and being able to determine whether the tumor was in fact benign as what was suspected. So in terms of the management, we know that we can treat these tumors medically, so we know that there's medications that we can give that can halt the tumor growth. Of course, we can surgically remove them. I mean, there's some instances when the tumor is so small or of a certain size that we are actually able to see, okay, you're a candidate for conservative management. So that is an option that may sometimes be preferable. And also just to mention that it's important that we support the aspect of alternative therapy and that we also support the patient's decision in her treatment. So if it is that we know that, for example, they decide that they do not want any treatment at all and we've been able to give as best as we can an overall view of what the care plan would be, then that is something we still need to respect as medical professionals, even if that's a choice that we do not necessarily agree with. So with every medical intervention or with every surgical procedure, we know that there is the possibility of complications. And so with that, we really are thinking about, is this going to recur? What about in terms of the possibility of being infertile, the risk of malignancy, the different complications from the medicine or even the surgical intervention, as well as then the mental health concerns. So with that, we really need to focus on a more holistic approach, because what we're talking about today is not just about a tumor. What we're really talking about is a person, a female with a tumor. And because of that, what we really want to manage is this person as a whole and ensuring that we support their emotional and psychological well-being. And we know that these women are actually in positions right now where they're in very high stressful jobs. They're juggling it all, right? They're doing everything with their family life, and yet they're still in situations where we're not really trying to accommodate as best as we can, and we need to try to support them as much as we can. And ensuring that we have adequate follow-up, things that would be appropriate, and ensuring that we would be able to care for them along this journey. So really, the good thing is that with these tumors, the majority of them actually have a really good prognosis, especially if it is that they are caught and detected early. However, as we said before, there is always the risk of malignancy. And in general, there's not a real classified system, but what the sort of general classification is based on is the type and the size of the tumor, any associated complications, and really the patient's age. So I just wanted to go through the first of the two case reports. So this really is one of an incidental finding. This was in an adolescent female that was having heavy periods, and she was found to have a serous cis adenoma. So what happened is that she was having irregular heavy periods for about 6 weeks. She was having her period ongoing. She was feeling a lot of pelvic discomfort, and she started to feel over the last few weeks, particularly short of breath, having headaches and chest pain, and just really feeling more tired than usual. So she presented into the office, and when she was there, she was hemodynamically stable. And on physical exam, you could see that her pallor was pale. On physical exam, you could see that her pallor was pale, but she did, however, also have an increased BMI. So she was at the 99th percentile. So essentially, she was obese. And the important thing was that on palpation of the abdomen, you could feel a very large prominent mass in the left upper quadrant. So when the ultrasound was done, the ultrasound had confirmed that there was a large cystic lesion. And as you can see here with the CT, really what it was doing was taking up an incredible amount of space in her abdomen, compressing on the other structures as well. And when they did the CT, the actual dimensions were about 25 by 25 centimeters. And in terms of what happened for her, this was surgically removed. So she had a left ovarian cystectomy and a left partial oophorectomy as well. And she had an ultrasound that was done a year later, which showed no recurrence. And 2 years on, she's doing well and has needed no further gynecological intervention. So with that, the serous cis adenoma is the most common form of benign ovarian tumors. As you can see here, they can be uni or multilocular, and many, as with this patient, are asymptomatic, well, prior, and then but they do have the symptoms of mass effect. So in the sense that that's what she was experiencing, and the bloating, and then these patients also have menstrual irregularities, and really the treatment option for them is just removal of the tumor. All right, so just for the other case report, this is of a 16-year-old female, and she was found to have an ovarian teratoma, but this was secreting testosterone. So she presented with a history of asthma. She was complaining of umbilical pain. It was around 7 on 10 in terms of how severe it was. She said that it was burning in nature, but it wasn't radiating anywhere. And she couldn't really identify any exacerbating or alleviating factors. What she did note, though, was that it had started several years ago. It happened several times a month, and that she also recently, in the past couple of months, found that she was getting a lot bigger around the abdomen, so feeling a lot more bloated. Yeah? So on the physical exam, it was a large abdominal mass, which was palpated, and then the patient was sent for an urgent ultrasound. And on that ultrasound, there was already sort of an identification of this being a complex cystic structure. And because of that, she was then sent for a CT that same day. And the CT then showed what we're seeing here, which is the darker areas you can see, and then the lighter, so you know you've got the difference between the solid and the actual fluid component of the mass. There was also calcifications in it, and that would be suggesting of teeth, as we know, because that can also be found in these tumors. And so the only option for her was to do an exploratory laparotomy as well, and it was a 10-pound cystic mass that was removed from her, actually. And as you can imagine, since it was that big, it was removed from the left ovary with the left ovary and the fallopian tube as well. So obviously, a very difficult situation to go through at 16 years old, right? So after that, what they realized, importantly, was that they did a follow-up for her. So initially, there was an ultrasound that was done, and that showed that there was no further tumor at that time. However, 5 months post-op, she did have another ultrasound that was done, and there was a cystic mass. However, it did resolve about 6 weeks later, right? And they decided or diagnosed it as a regressed complex ovarian cyst. And after that, she was lost to follow-up. So really, the mature cystic teratoma, or as we've been saying, the dermoid cyst, is the most common germ cell tumor, and they are usually benign. It's important that we send them for either ultrasound or CT investigation. Ultrasound is completely reliable and very effective. And then to ensure that we treat so that we can prevent recurrence, because once these tumors are removed, they do not recur. And just to remember that they can become malignant even if it is a small percentage of less than 5%, but they do have the possibility. So really, at events like this, we do want to focus on positive change. So how can we better tomorrow? How can we really improve our care? And one way of doing that is by looking at the person as a whole, looking at these females as a whole in terms of ensuring that their mental health is a major part of our care plan. We know that recent studies have shown that supporting these females with, for example, psychological support before and after procedures actually decreases the frequency of anxiety and depression. And it's important to know that some of these females have families who are able to get involved and are going to be there to help with their progression through this diagnosis and treatment. So in some cases, we do need to consider the option of family therapy, and then just making sure that we are there, that we as physicians are available to support them so that we do not miss an opportunity to offer that care, but also to recognize that we as medical professionals do need staff debriefing so that we also, when we're faced with these difficult cases, that we have a situation in which we would be able to benefit from as well, because it is difficult and it is hard. And I think it's something that we should be able to recognize and talk about. So really, in summary, we know that these benign tumors can present in a variety of ways. And it's important that we try to diagnose them as early as possible if we really are going to try to reduce the complications. And understanding as much as we can about the patient, where they're from, the understanding of their psychosocial background, that's really what's going to help us kind of adhere to the treatment plan and offer the best care. And sometimes we know that we might need to involve other specialists, and appreciating that maybe a multidisciplinary team approach is necessary is what we would also be looking forward to doing. So I just wanted to leave with the question, which, are these benign functional ovarian tumors really benign? I'll pass you on to my colleague. Thank you so much.
So we want to thank Dr. Chisholm for that very interesting and informative presentation. And as a token of our appreciation, we would like to give you a little gift. Thank you so much.
Thank you.
And I've already introduced Dr. Cayman Fraser, so I'd just like to invite her to come to the podium and do her presentation. Thank you.
Good afternoon, everyone. I'm Dr. Cayman Fraser, as introduced, and I would like to thank the HSA's Women Health Department for giving me this opportunity for really having my conference debut. So please bear with me if I'm very nervous, and hopefully we can go through this presentation together and learn something. So I have no disclosures. And for the second part of this topic, my job is really to focus on the pathologic side of it, as Dr. Chisholm touched on most of the clinical aspects. So I will be looking briefly on the classification of ovarian tumors, what are the clinical aspects of functional ovarian tumors that are relevant for the pathologic diagnosis, and then go through some examples of functional ovarian tumors. There will be some photographs of gross specimen, You might not be used to seeing these. These are from published images, okay? Not anyone on island. So ovarian tumors, we know the ovaries are the paired reproductive organs in the female that produce the egg. And this is a photo, sorry. Oh, that went by fast. This is a, okay. All right, I'll just do the point alone. This is a photomicrograph of what an egg would look like in the ovary. So you have the inner portion that says O, that's the oocyte, or the actual, where the genetic component of the egg itself is. The CR and the ZG, that would be the granulosa cells. And these would be like the sex cord component of the egg. And the TI would be the theca interna cells, and the outside will be the supportive stroma, where the stromal tumors would arise from. And if you can imagine, when a female is born, we have about 1 million of these eggs. At puberty, they have around 300,000, and during our reproductive life, you can ovulate up to 300 to 400 times, depending on, so it's a lot of potential sources for tumors to arise. So as Dr. Chisholm mentioned, you can have tumors arising from any part of the ovary, and they can be classified as benign or malignant, or they can be classified based on the structures they arrive from. So as she mentioned, if they're from the surface, there will be epithelial. If they're from the oocyte itself, germ cell tumors, from the granulosa layer, sex cord, and from the stromal tumors. And there are like tens and tens of different types of ovarian tumors, because you can have pure tumors or you can have tumors in combination. So if you look at the WHO classification, there are many. And WHO doesn't recognize all of them, so there are lots and lots of ovarian tumors. However, our focus today are functional benign ovarian tumors, which is a small subset of all the possible ovarian tumors. So most of the functional benign ovarian tumors arise from the sex cord stromal component, because in the normal ovary, these are the parts of the ovary that will be predominantly responsible for hormone production. So as expected, a tumor that resembles or arises from these structures will also have the potential to still continue functioning and producing hormones. One of the germ cell tumors, struma ovaria, which I will go into later on, these also produce hormones, and we will see. As I said, functional ovarian tumors are very rare, and again, you can have benign and malignant, as shown here. So why is it important to note? Because they may the first clinical presentation may be signs and symptoms related to the hormone production. And signs of estrogen and androgen excess, they have many different causes. So if you do not keep in the back of your mind that a possible tumor could be the cause, you may have delayed diagnoses. Signs of estrogen excess, abnormal uterine bleeding, endometrial hyperplasia and neoplasia, as well as precocious puberty in those that are prepubescent. Signs of androgen excess, also called virilization, where you have hirsutism, acne, alopecia, menstrual abnormalities with our irregular or absent menstruation, enlarged clitoris, or deepening of voice. This sounds like PCOS, right? You want to think about a tumor first, but you have to keep it in the back of your mind as a possible cause. This is a table that I grabbed from UpToDate, just to give an example, just to show the different type of hormones that can be produced by different tumors of the ovary. On the left panel, those are the malignant, and those tend to produce alpha-fetoprotein, beta-HCG, LDH, as you can see. And for malignant tumors, these can be used to monitor during management. Tumor markers, tend to be called. However, on the right side, the benign sex cord stromal tumors tend to produce varying amounts of estrogen, progestin, testosterone, and the component, the ratio of each histologic type will tell the predominant manifestation, whether estrogenic effects or androgenic effects. So why do we care? As I mentioned, if we don't have a high clinical suspicion for a possible benign tumor or any tumor, we may delay the diagnosis and the institution of appropriate management, which may affect outcome. So if you have adnexal mass in someone who has signs of estrogen or androgen excess or increased serum tumor markers, then you want to consider a possibility of an ovarian tumor. Which tumor it is, you can only tell by a histologic examination. So tissue exam is very important to know exactly what type of ovarian tumor it is, as well as the risk of malignancy. So going into specific examples, our first tumor is a struma ovarii, and this is a type of germ cell tumor where you can either have monodermal, where it's just pure thyroid component, ectopic thyroid tissue, or it could arise in the setting of a mature cystic teratoma or dermoid cyst, where more than 50% of the tumor is composed of this ectopic thyroid tissue. Usually, all of it is benign, and the benign thyroid ectopic tissue produces thyroid hormones, as the thyroid tissue does, and you have the signs and symptoms of hyperthyroidism. Because tumors do what tumors do, there's a risk of having malignant thyroid component, so that's where the histologic examination is important. And even though we're talking about the functioning, just know these tumors are rare, and then of these rare tumors, not all of them will produce the hormones and have the signs and symptoms. Struma ovarii tend to occur on one side of the ovary, and they can have a wide range of sizes, but they're usually less than 10 centimeters in diameter. They have a solid beefy appearance, red-brown, just like the thyroid does. And you can have cysts. You can have, as mentioned, the dermoid cystic component. And histologically, we'll have follicles of varying size, lined by flat to cuboidal cells that are filled with colloid, just as in the normal thyroid tissue. You can have varying patterns, so solid trabecular, pseudopapillary, and so on. So on the left, we have a gross picture of a thyroid with a goiter. So you have the right and left lobes, that's the ends of the butterfly, and the isthmus in the middle. And you can see varying sized nodules, and that's what is a goiter, basically nodular hyperplasia of the thyroid. On your left, you will see an ovary with a struma ovarii, and you can see, let's see if I can get this right now. Right, you can see varying sized cysts filled with colloid. Under the microscope, normal thyroid, these are the follicles, varying sizes, lined by these flat to cuboidal epithelial cells, and this pink homogeneous substance is the colloid. Similarly, in the ovarian struma, you have varying size follicles, lined by cuboidal to flat epithelial cells filled with colloid. And you can have the pseudopapillary and solid areas as described. So the key points for stroma ovarii is a germ cell tumor with predominantly ectopic thyroid tissue. It tends to happen in middle-aged women. You can have features of biochemical or clinical hypothyroidism, but not uncommon. But if it's there, let's say you have a woman, signs and symptoms of hyperthyroidism, you do the investigations of her neck, you're not seeing any thyroid nodules or any radioactive uptake, then you have to think about maybe there's thyroid tissue elsewhere and check the ovary. Histology is very similar to the normal thyroid, and histology is key to exclude malignancies. Oophorectomy is usually curative if it's benign. Our next example of a benign functional tumor is a thecoma and their related tumors. The thecoma, fibrothecoma, luteinized thecoma, these are all benign stromal tumors that the cells resemble the thecal cells. If you remember, the thecal cells are the supportive cells on the outside of the egg in the ovary, and these tumors tend to occur mostly in postmenopausal women who presents with an adnexal mass and they have estrogenic manifestations. These estrogenic manifestations in postmenopausal women tend to manifest as postmenopausal bleeding. They tend to occur on one side of the ovary. They're variably sized again, but tend to be about 5 to 10 centimeters. And they have this lobulated yellow cut surface, right? And you can have areas of cystic degeneration, even hemorrhage within the tumor, and necrosis. Histologically, you have these diffuse growth of almost uniform looking cells with indistinct cell membrane, which means you're not able to tell where one cell stops and the other starts. So that's the syncytial appearance. They all look very similar. They have this pale gray cytoplasm. The nuclei are small, round to ovoid, pinpoint nucleoli, and useful supportive evidence are these hyaline plaques within the stroma, or even more keloid-like appearance. Sometimes you can find some components of other tumors, particularly sex cord elements. So what's important to note for thecomas, they're stromal tumors, predominantly of thecal cells, tend to mostly be seen in postmenopausal women with estrogenic symptoms, and most of them are usually benign, and however, you need to exclude endometrial pathology that can be associated due to the estrogenic effects. Oophorectomy is normally curative. Our next example is a Leydig cell tumor, and this is a benign steroid cell tumor. These are normally located in the hilum of the ovary, and the hilum is just the base where the ovary is attached to the ligament. They're normally just supportive structures, blood vessels, and so on, and not much eggs are found in this region. They tend to be classically described by having these cytoplasmic Reinke crystals, but they're not always there. If you find them, great. If you don't find them, that doesn't mean it's not a Leydig cell tumor. It's just that you have to make your diagnosis on other features. They tend to occur in perimenopausal patients. They have mostly androgenic effects, but you can also have some estrogenic effects, and there tend to be small, brown, red, or even cut on appearance, and well circumscribed. Histologically, they're composed of these large polyhedral or round epithelioid cells with abundant eosinophilic cytoplasm. The nuclei tend to cluster together and create these nuclear-free zones. And as I said, the Renke crystals are rare, but if you do find them, it's great, but you may not find them, okay? The nuclei is round, not atypical, very small, single nucleolus. And other supportive findings is that sometimes the blood vessels within the tumor have fibrinoid material in the wall. So this is a blood vessel. This is the red cells and the plasma. And this smudgy pink appearance is the fibrinoid material within the wall. So all of these help support your diagnosis. Another closely related sex cord neoplasm that tends to occur in conjunction with Sertoli cell tumor. So it's rare to have them purely Leydig cell or Sertoli cell. They tend to occur together. You have Sertoli Leydig cell tumors. What is the distinguishing feature for this tumor are the presence of Sertoli cells. And these can occur in a number of patterns. They occur in younger women, around 30, and you have more estrogenic than androgenic effects. Very rare, you can produce other hormones such as renin, progestin, and aldosterone, and these tend to affect water balance, water retention. Again, they tend to occur on one side, mean size about 8 centimeters, and have a, as you can guess with hormone-producing tumors, they tend to be some type of yellow appearance. As most of these hormones have derived from lipids, so of course they'll have like a fatty type appearance. Again, cystic degeneration, hemorrhage, and necrosis can be seen. So many patterns, histologic patterns for this type of tumor, but what you want to find are some type of tubules, whether they're hollow or they're completely solid. At least you want to see some type of tubules within the tumor. These are the many type of patterns that we can see, and the stroma can be very scant or they can be abundant and hyalinized. This tumor can have malignant potential, and some of the histologic features that clue us into its malignant potential is a size being greater than 5 centimeters, increased mitotic count, nuclear atypia, and the presence of tumor necrosis. So this is just some photomicrographs of Sertoli cell tumors, just showing you the varied appearance of the tubules. So wide variety of histologic appearance, but once you have some type of tubule, that's clue you in to your diagnosis. So those are the main benign functional tumors that I want to highlight of the rare. These are the more common of the rare, but just some special mentions. One is called sclerosing stromal tumor. It's also benign, very uncommon, and it's in a younger population, young women and girls. Hormonal symptoms are rare, but when it does happen, it tends to be virilization, if it's reproductive
I'm joining
age,
with my audio.
or if it's premenarche, they'll have precocious puberty. The other special
I am not
is
hearing
sex cord
anything.
tumor with annular tubules. Again, very rare.
All right, let me mute myself.
But you have annular tubules present within this tumor, and what is characteristic are these sharply circumscribed nests with ring-like tubules with a basement membrane-like material. Rare, can occur at any age, but what's important to note, when this tumor arises in the setting of someone with Peutz-Jeghers syndrome, it tends to be more benign. However, if it occurs outside of that syndrome, that's when you have
So
the
you can hear me,
hormone
right?
effects, and they tend to be more malignant. So in conclusion,
Okay.
there are many ovarian tumors, and they can
Just
be
nod your head if you
classified
can
in
hear
many
me.
ways. The functioning benign tumor subsets
Oh, sorry.
are rare, and even within this small subset,
Okay, try that again.
not
Go
many
again.
of these produce hormones. However, if
Okay, I'm
you
not
have
hearing
a
you.
high clinical index of suspicion. If you see someone
I have to
presenting
unmute.
unknown manifestations,
Yes. My volume is okay?
then that can
Your
clue
volume
you
is
in
very
of a
good.
possible
Okay, then.
functional tumor.
All right. And lighting is good as well, right?
Diagnosis
You're supposed to be able to hear the presenter speak inside.
I'm not hearing anything.
You're not hearing
These
anything?
are
Okay,
my
give me
main
one
references, and I thank you for your time.
Give me 1 second. Let me-
So thank you, Dr. Fraser, for taking us beneath the surface and giving us your perspective from the pathological point of view regarding benign ovarian tumors. And please accept this small token of our appreciation. Thank you. So we will take 1 or 2 questions for Dr. Fraser or Dr. Chisholm, if anybody has any questions for either of them. Okay, and I guess that's because it was such a good and clear presentation. So no questions. Okay, so we're gonna just take a 2-minute break to do another couple of raffle prizes. So if you can take out your raffle tickets, and we'll do a couple of raffles. All right, so we are going to be raffling another couple of gift cards. We'll be raffling a gift card from Kirk Freeport again. All right, so the lucky person is 586873. That's 586873. No takers? All right. So 586840. All right, we have a winner. All right, so congratulations to Miss Marjorie. Oh, she's being very honest. It's for Lorraine, but if I were her, I would keep it. All right, so we'll do another one for Victoria's Secret. All right, so that's 586787. 586787. Woo! Congratulations to Monique. All right, thank you, Dr. McCoy. All right, so don't forget that we still have 2 grand prizes left. So if you stay till the end, we'll be doing that towards the end of the conference. And we're moving right along to our next presenter, who is again one of our HSA doctors. We are very pleased to have Dr. Hermano Cerati, who is a consultant ophthalmologist, doing a presentation on the eyes and STIs. So Dr. Cerati is an Italian national who completed his medical training and specialization in ophthalmology in 1989 and 1993, respectively, at La Sapienza University of Rome. He has been a consultant ophthalmologist in 9 different healthcare facilities, and he's very highly skilled and has extensive experience in endothelial transplant, oculoplasty, and numerous other procedures. He has had a global experience, having worked in Africa, Saudi Arabia, Thailand, and of course now in the Cayman Islands. And so he brings to us a wealth of experience, and we're happy to have him present today. Dr. Cerati.
Thank you, Karina. Thank you, the Woman Cell team that invited me for this important meeting. And I'm very proud to represent the Lion's Eye Clinic and to borrow an eye for gynecology, you know. So let me start because that's, I will present to you the most important infection that we can have by sexual transmission or by intrauterine transmission and by the urinary apparatus. So the sexually transmitted infection, I used to do the presentation always to present the bibliography of the subject that I used to present. And I would like to focus just on the, to focus on the Treponema pallidum global prevalence and Neisseria gonorrhoeae global selection and global evidence. So those are the most important sexual transmitted infections. Fortunately, as you can see later, they are not so dangerous for our eye. That is the Neisseria gonorrhoeae, and that is the clinical evidence that we can have in the baby. Fortunately, those clinical manifestations now are less than previously because of the prevention. So we used to suggest the prevention immediately after the born. And that is the, I'm fighting with this. That is the Hodelt clinic. That is very bad situation. If you look the corneal ulcer, that is very bad because there is an infiltration of the limbus, and this, the prognosis of this eye is very, very bad because this eye is candidate for corneal transplant. So the diagnosis, obviously, the correct diagnosis goes through the PCR and the culture. And so usually the antibiotic, we have a good response to the ceftriaxone, but obviously the best is waiting about the result of the antibiogram and the culture and to get the antibiotic that is the best and can get it sorted out. That is the Treponema pallidum, syphilis. So we have conjunctival manifestation that is not very bad, the hyperemia, but this one is completely different because we have a very huge hemorrhage in the back of the eye, in the center. We can't see the macula, and in this case, the prognosis of the vision is very, very bad. So the blood test confirms the presence of the antibodies, and the treatment usually is by penicillin. So I will be very happy to describe for you a case that I got exactly last week. That was very difficult management of the case because we got a patient. I got the referral from the A&E, a patient that was pregnant 17 weeks. She got a very bad corneal ulcer that I can show you later. Very bad corneal ulcer in the center of the cornea, low vision, and so after the culture, it was the Pseudomonas aeruginosa, the cause of that infection, and that was difficult management because, as you know, the most important antibiotic that we can use for the Pseudomonas, they were not they didn't fit very well with the pregnancy. So that was very difficult. And anyway, today, this morning, I was not here because it was planned the check of this patient. This patient started to recover the vision because fortunately we stopped with the wonderful cooperation with the pharmacy about the preparation of a special antibiotic by topical, and the patient started to see something and the healing process is going on. So another one is the chlamydia. Chlamydia trachomatis is one of the most common that was one of the most diffused in the pool, especially for kids. This is the chlamydia, and that is the conjunctivitis. You can see that usually the bacterial conjunctivitis starts from the fornix, and then when the conjunctivitis became severe, we have the limbus that is injected. When the limbus is injected, it means that the conjunctivitis is very severe. And the cornea is at risk to be infiltrated. And in this case, we are at risk of having poor vision as a result of the infection. That is I want to say for you the diagnosis, like the general diagnosis of the chlamydia trachomatis, but the same. For the right diagnosis, we need to get the swab from the conjunctival fornix, and then we can give the patient the proper medication by the proper antibiotic. In this case, I would like to show you that one of the most important for most of those infections is the propamide isotoniate. The name is Brolin. It's very difficult to find in the highland, but fortunately, with the cooperation with the pharmacists now, we are going to get Brolin more available for patients. Especially, Brolin is very effective. That is not proper for this presentation, but just for letting you know as a general culture, one of the most important germs of corneal infection is the acanthamoeba. The acanthamoeba is very often can attack the cornea of contact lens users. And that is a very bad infection, and Brolin is one of the best drop that we can use immediately to get this sorted out. So, Candida vaginalis, that is the bad corneal ulcer, very similar to the Pseudomonas that I managed last week. That is the corneal melting. When there is this ulcer and the melting, it means that we are very close to the corneal perforation. Very close to the corneal perforation. If we get the corneal perforation, we are at risk of having hypopyon, so the transmission of the infection inside the eye, and that is a very huge issue. That is the acute, that is an emergency, and that is the process of healing, not completed, but much better than this one, because in this phase, we are much calm, because in this case, we don't be concerned about the corneal perforation. So, in general, all of the fungal infection of the cornea, they are very, very aggressive and very bad. In few days, we risk to lose the vision, and we risk to lose the eyeball sometimes. So the diagnosis, obviously, is the PCR and the culture of the melting tissue, because that we can save time in this case. And by doing the correct diagnosis, I remember that for that lady last week, I did the culture at 11 p.m. Immediately, and the day after we started with special preparation that I got by the pharmacy. One of the sexual transmitted infection is by the HIV. So the HIV can give this kind of clinic evidence. Not very, very bad, but this one, if we don't start immediately the medication, or the patient is not covered by the general medication for the HIV, the proper antiretroviral medication, we can get the ischemia of the optic nerve. So the diagnosis, very important, and in this case, for the high diagnosis, we have just the clinical evidence. So when we get the fundoscopy, the image like I showed you before, we need to think about that could be diabetes, that could be the blood pressure spike, that could be a lot of things, but we need to, if the patient has the lab test that is suspect, we should think about the HIV. One of the sexual transmitted infection is cytomegalovirus. Cytomegalovirus is very bad because usually the cytomegalovirus can cause vasculitis. And we have two different vasculitis. This one is central, and the prognosis, the visual prognosis of this eye is bad. The vision is completely gone in this case. But sometimes, if we are lucky, like in lupus, we have the peripheral vasculitis, and then in this case we have just the edema, we have just some scotoma in the visual field, but fortunately the vision, we are not at risk of losing the vision. The diagnosis, laboratory test, obviously, and the same, the clinical evidence of eye lesion that we can see as I showed you before. Intrauterine infections, I would present to you just the most common. Toxoplasma. Toxoplasmosis is one of the, unfortunately, I got 2 years ago, one lady that told me in the anamnesis, maybe I went to the ophthalmologist 8 years ago. He told me that I have a scar in the retina, but I didn't understand very well what he said to me, and okay. So the vision of this eye is so about 2100. 2100 and movement is quite the same, because we have the Toxoplasma gondii attacks the macula. The macula is the center point, this one, because in the macula we have the most important quantity of blood in the eye. So our eye, the outflow of the eye, usually try to save the macula. So if we have a vascular problem, we can have around the optic nerve here, but our body try to save the macula as the most important organ of focusing the image. but the Toxoplasma gondii want to hit very well, and then he tried to get the central position to get more blood is possible. But that is the result of the, and most of times we can have this kind of clinical manifestations in baby. And just monolateral, fortunately. The diagnosis, maybe I don't need to teach to the gynecologist, which is the diagnosis of the Toxoplasma, but for us, so when there is a scar, the central scar in the macular area, that is, even if there is a patient that doesn't have any evidence, asymptomatic, so that is Toxoplasma. So, go ahead. That is another important Zika virus that is transmitted by the mosquito. That is the geographic area, and I think that we are included. That is the Zika virus, that is the scar on the retina and the hemorrhage, and that is the baby. So, you can see the lesion on the macula. You can see the scar. That is the acute manifestation, and that is the chronic. I think that that is not very well known, but we need to pay attention for that, because unfortunately the area is that one. The diagnosis is obviously the blood or urine test that confirm the diagnosis, and the clinical evidence by the fundoscopy that I told you, but sometimes we need to make the difference with the toxoplasmosis. And that is the urinary system, because sometimes the sexual transmission could come even from the urinary system. So in this case, I would present just the worst, Klebsiella pneumonia, because I got 3 cases of that when I was in the casualty in my hospital in UK, and 1 case in here. So the Klebsiella pneumonia, that if you look at that patient got the cataract surgery recently, because there is the stitch here, and that is the initial endophthalmitis. That eye can't be saved. When we have the hypopyon inside, it means that the transmission by the iris to the back of the eye, to the vitreous, the vasculitis. So if we are lucky, in this case, we need to do, within 24 hours, we need to do the vitrectomy. We need to take the vitreous out. We need to wash by antibiotic, and then we can save the eyeball. Sometimes, if we are able to do the early diagnosis, in this case, we can save even the vision, partially. But we need to be very, very fast, and we need to be very well equipped. That is the Klebsiella. The problem of Klebsiella, that Klebsiella pneumonia is very resistant to the antibiotic. That is the problem. In conclusion, because the window that I opened about the eye in this meeting, I would like to give you just a concept. This quick trip along the infection that can be transmitted by the urinary apparatus, by the genital apparatus, and so on, we need to understand that all the infection that come from the anterior segment, because we can divide the eye in anterior segment, posterior segment. Anterior segment, the prognosis is quite better, because if there is, so conjunctiva is a tissue that doesn't support the vision, and then we don't have the risk of losing the vision. Cornea, supporting the vision, but I'm very proud to say you that we can do the corneal transplant, and last week in this room there are 2 scrub nurses and the team. I'm very proud about that, because last week we did 2 corneal transplants for 2 different patients, and so you can understand that if we have the compromission of the cornea, we can save the vision, we can save the eye through the corneal transplant. But the problem is when we have the lesion in the posterior segment. Most of the times when we have the damage of the posterior segment, if we are lucky, as I told you, in 24 hours by doing the vitrectomy, by taking the vitreous out, we can save the eyeball, sometimes the vision. But most of the time, we lose the eyeball. So just another pearl about the clinic pearl. I had a patient last week, was in the clinical unit. That patient fell down from 6 feet, and he got a very bad fracture of the bone, frontal fracture, and ethmoidal fracture. So I was called by my colleague, by the neurosurgeon, and he told me, please, can you come, because it seems that the patient can't see properly with the right eye. That was the side of the fracture. And the patient couldn't see the light. So at the end, the result of the MRI, at the apex of the orbit, the bone was broken, touched the optic nerve. That's it. So everything that concerns the posterior segment and the optic nerve is very dangerous. And it's very difficult, very, very difficult to save the vision. So I'm very proud to be here and to share with you some aspects of the eye, and to share with you how the eye could be involved in gynecology, but not just in gynecology. The eye is very small, but through the eye, we can do the diagnosis of several disease of the body, and we can check most of the things. We can guide the internist, the gynecologist, or other specialists to go through the right direction for the diagnosis. And then, once more, thank you for the invitation. Thank you for giving me the opportunity to share with you that important meeting, because it's if I don't make a mistake, it seems that it's the 10th, and that's important tradition of HSA in Cayman Island, but that means that is a very huge job about the woman's health. Thank you very much.
Thank you, Dr. Serati, for that eye-opening presentation. We are very fortunate to have you with your vast expertise on staff at the HSA to help us with all of these eye conditions. And please accept this as a small token of our appreciation. I think we're gonna do one don't go, Dr. Sarati. We might do one question or two. Dr. McIntyre? Question. Does somebody have a mic to give to Dr. McIntyre?
Yes, it's a very brief question. Just that I understand there's a lot of work being done in stem cells and retinal damage, particularly macular degeneration. But my question is, I'm just wondering, some of the conditions that you mentioned, toxoplasmosis, etc., with retinal scars, I'm wondering if stem cells would be appropriate, or would it be that the brain has blocked or not learned to recognize images from that area, and therefore there would be no point?
Yeah, so that is thank you for the question, because that is a very important question about the new technology. And so I know that there are so many centers that are trying to set up the treatment of macula, especially the macular degeneration, because for the scar, I don't think that the stem cells can work properly. But anyway, about the macular degeneration, that is one of the most important causes now, about the poor vision, especially in the elderly people. Personally, I got an experience with a center in Germany. I sent some of my Italian patients when I was in Italy to Germany for that treatment. And there were 3 patients. And personally, my experience is that the stem cells, retinal stem cells, that we can implant the retinal stem cells for the macular care. But the problem that is in 4-6 months, we lose the function of those cells. And then we need to repeat again. Why? The problem is because we were cooperating with this center, try to understand. The problem is the cell need the basic membrane. If the basic membrane doesn't work because we don't have any vessel, we don't have the nerves, in 3-4 months, the stem cells, the new stem cells, they go to die. And then we don't get it sorted. So that is the problem, not just for the eye, but that is the problem for most of the tissue. So the stem cells care is one of the most important care that we need to study in deep for the future, but I think that is not enough at the moment. And the problem is that in the eye, for example, the stem cells, they work very well in the cornea. Let me say you that we are going to do the first stem cells implant in one patient because that patient got a very bad infection by the herpes virus. The right cornea is full of vessels. If I will do the corneal transplant on that cornea, it's sure that in 3-4 months we get the cornea rejected because there are the vessels on the cornea. Usually on the cornea we don't have vessels. Cornea is transparent. So in this case, if I want to avoid the corneal rejection, I should do the stem cells from the other eye, a small tissue from the other eye that is good. I need to implant this tissue on the limbus, taking cornea, limbus, and conjunctiva. I need to wait 6 months that the vessels disappear, and then I can do the corneal transplant. That works very good for the cornea, the different tissue than retina, because cornea is like connective tissue. Retina is is the brain. So I used to call the eyes the guardian of the boss. Our boss is the brain, and the guardian are the eyes. You know? So, but it's different about the macula. Anyway, let me say that I would like to encourage the problem. And in that case, it was not the stitch. Okay?
Okay, thanks again, Dr. Serati, for that presentation. So we are now going to just do another raffle right before the coffee break, and then we'll come back to do the home stretch of this conference. So we are going to be raffling 2 gift cards to Cayman Bay, right? So pull out your raffle tickets. All right, so the first one is 586864. 586-864. Okay, so 586920. Anybody have that? 920? Oh yeah, we have a winner. All right, congratulations.
Here's the thing, Edward, you got to give it to somebody because you work here. I'm joking.
Thank
All
you.
right, thanks. Okay, we'll do another one, and that is 586932. All right, we have another winner. All right, congratulations. So thank you. We're going to break now for a very short coffee break. We're going to keep it to 10 minutes and have you come back in at 3:10 for the last two presentations. Okay, so see you back in 10 minutes. Mackenzie, as well as Ms. Denise Casterly, who is a clinical psychologist with the HSA part-time. So Ms. Casterly will be presenting first, and then Dr. Brooks Mackenzie will be presenting virtually from Jamaica via Zoom. So Ms. Denise Casterly received her training in clinical psychology at the University of the West Indies, the Mona campus. She subsequently then received training from several organizations, including MIT, in various specialty areas in mental health, and that includes teen mental health as well as ADHD. She is a member of the educational psychologist team at the Department of Educational Services in the Cayman Islands, and she's also a part-time team member in the Department of Psychiatry and Behavioral Health Services at the Cayman Islands Health Services Authority. Her dual role encompasses both of her passions, which are good mental health and the well-being of teenagers and women across their lifespan. I will also introduce Dr. Verna Brooks Mackenzie at this time as well. And Dr. Brooks Mackenzie is she graduated from the University of the West Indies with honors in obstetrics and gynecology. She is a certified menopause specialist, certified by the North American Menopause Society. And she opened the first menopause center in the English-speaking Caribbean in Mandeville, Jamaica. Dr. Brooks Mackenzie is a board member of the Red Hot Mamas, which is the largest menopause education program in the United States. She has trained medical professionals in many different countries, as far as Ghana, which is in West Africa. She has received numerous awards, including awards from the American College of Obstetricians and Gynecologists, the West Indies Section Award for Outstanding and Distinguished Service in the Field of Women's Health. We are pleased to have both Ms. Casterly and Dr. Brooks Mackenzie present to us on this very interesting topic.
I just like it right in front. Oh, right. What's happening? Okay, I think we're there. I'm sure we've all heard that saying that life is a box of chocolates, you never know what you're gonna get. Well, I think for us women, it's more like a bag of M&Ms. Menstruation, men, motherhood, marriage, and then the icing on the cake, menopause. From age 20, you're pretty much guaranteed to have 4 of 5 colors in your hands for a very long time. On the upside, I hope we won't have menstrual cramps and hot flashes simultaneously. Okay, we all know this. I mean, some of these slides, please, I'm not trying to offend anyone. We know that everybody in this room is very well aware of what menopause is, but it's typically, though, there is also perimenopause, which I think is important to know because true menopause is, the diagnosis is made after missing menses for 12 consecutive months. And in the context of this presentation, women could be perimenopausal and present with symptoms. So what happens is that there are lower levels of estrogen and progesterone production by your ovaries. And there we have it. Our childbearing years are over. Never again to worry about birth control. Never again to be interrupted by a period. So why aren't we celebrating? I am not sure why it is called a pause. When you think of novels set in the early 20th century, and there's this surreptitious reference spoken in very hushed tones about the heroine who happens to be going through the change, that sounds entirely more accurate. Low estrogen results in fatigue, cravings for sweets or carbohydrates, weight gain, hot flashes and night sweats, feeling depressed or overwhelmed, mood swings or irritability, insomnia, headaches, low libido, fuzzy thinking, stiffness or joint pain, anxiety, heart palpitations, breast pain, and adult acne. Low progesterone may result in anxiety, depression, weight gain, hot flashes, excessive menstruation, mood swings, insomnia, headaches, low libido, a repeat of low estrogen. According to a friend of mine, she says, "Oh my God, I feel simultaneously pregnant and old." A woman is, or I should say can be, because we all have very individual experiences, but you're catapulted from energetic, vibrant, consistent, or more or less consistent in activity and mood. And suddenly, she just can't seem to find herself anywhere. Hot flashes, weight gain, anxiety, depression, insomnia, and exhaustion are the psychological factors which really come to bear on a woman. It doesn't feel gradual. It feels like last year, you were just grown and living your best life. A year later, you feel old. Not like 50 years of experience and wisdom gained, just kind of all exhausted and just really trying to come to terms with this change. So there's a connection between hormonal changes and psychiatric symptoms in general, and women are particularly predisposed to symptoms of depression and anxiety. The exact nature of the relationship between emotional regulation and hormones continues to be studied. It's not conclusive. However, it does seem logical that we have been having PMS for 38 to 40 years prior to menopause, and that occurs when levels of estrogen fall prior to a woman's cycle. So it seems logically that as estrogen and progesterone become depleted, depression and anxiety could reasonably become a challenge in this period of a woman's life. And now here I'm speaking of proper anxiety. They cause significant impairment in functioning, disengagement from life tasks and or people. With respect to anxiety, women in the perimenopausal period are more likely to experience panic attacks and other anxiety symptoms than other women of the same age who are either pre or postmenopausal. Now, that relationship is actually very important because it's very easy when a woman presents that we think, okay, it's about her hormones, or okay, it's about, she needs an SSRI. And of course, in the dialogue with your doctor, it will become clear if you need one, the other, or both. So this is what it feels like for many women. You go to work and you complete work tasks, but your colleagues would really prefer if you called in sick for a long, long time. Unfortunately, your children and your partner would prefer if you just worked late and weekends. You are unreasonable, you're agitated, you are mean, and you are very inflexible. And guess what, though? If your truth be told, they think having to deal with you is something big. You wish they knew exactly how hard being with you all the time is, and you have nowhere to go. You're not functioning interpersonally at this point. If your emotional functioning is putting you at risk of losing regard of your peers, losing their confidence in you, losing the affection and communication of your family, it's time for a dialogue with a psychologist, at least as a starting point. We must, of course, the space of sex in a woman's life is very different from woman to woman. Sorry, I went ahead to the next slide. This whole experience of menopause is very different from woman to woman, right? But most women will have symptoms that negatively affect their personal, family, and work lives. The association is hot flashes and night sweats. That's a big one. But what can be really devastating are the psychological symptoms. Low mood and feelings of depression can be very common symptoms in the menopause and the perimenopause. Other psychological symptoms: low self-esteem, reduced motivation, anxiety, irritability, panic attacks, poor concentration, and low energy. But, as I said previously, we have to be careful that we flesh it out and we know what we're talking about. Is it a combination of depression or a response to change in hormones, or both happening simultaneously? And boy, as I say, those 5 M's, they're rough. If you had postnatal depression or a history of PMS, it is probably more likely that you will be adversely affected in the menopause. Depression and sex can be both a cause and a result. A woman's loss of desire may contribute to her depression, yet she may also see her desire decline as an effect of depression. Mood affects emotion, which affects relationship issues, and he didn't want you coming home. So that in turn has implications for sex, and low desire is the most frequent sexual side effect of depression or anxiety. In women, orgasm may be more difficult to achieve when depression is present. As many as half of patients taking SSRIs can have those same effects as side effects of taking the medication. However, and I want to say this, a woman might absolutely decide not to be depressed and have those side effects because she had them before anyway. But more than that, usually there are a number of options. Invariably, a patient will be able to work with her psychiatrist, and in many cases, her gynecologist, if the gynecologist does that, to find the SSRI that really works for her. Right, so I was saying, I'm always noticing that hot flashes is like, the only thing that women discuss with each other. And I was like, is this just about the stigma surrounding mental health disorders? And here again, I want to talk about, we have other causes of anxiety, right? Because a woman is experiencing menopause doesn't mean that they are all related to that, to the hormones. So we need to look for what exactly is causing the functional impairment. Interestingly though, when I have initiated the discussion of anxiety, the whole story comes spilling out. And it bothers me actually that women are so prepared to live with this level of discomfort. And there are also many other factors that contribute to anxiety or depression during menopause. Negative life events. Women who are less functional are definitely more likely to develop an anxiety than women without these additional stressors. And it makes sense, right? If you were susceptible before and then you have hormonally induced responses, it's going to be stacked on. It is, as I said, we want to always be working out the pharmacological aspect of treatment. So that's why the differentiation is so important. Hormone, this is a reference. Dr. Louise Newman, she seems to be quite a pioneer in HRT. And she says categorically, HRT is the best treatment for menopausal symptoms as it replaces your body with estrogen. Taking the right type of estrogen helps improve low mood and other symptoms related to menopause. Women feel calmer, have more energy, are more motivated, and generally much happier when they take HRT. I suspect so may their families be. Some women also take testosterone, which is given as a gel but can be given as an implant. I've actually known women who had this treatment and they were very, very thrilled with it. Testosterone is produced by our ovaries as well before the menopause. And it's very important for libido and helps to improve mood, energy, and concentration. Very beneficial for younger women, and they describe that their emotional energy has returned. Well, there is a story though, right? And we know that there's a backstory. The very, very negative reports in the media just resulted in women running entirely scared when HRT came up. And the biggest worry they have is associated with breast cancer. There are some very important facts about this. But I'm going to segue a little. I want to share my story. I had this like scary, unbelievable anxiety. It felt like it was out of the blue. I was just very sure something catastrophic was about to happen, like all the time. I wanted to ask my adult daughter not to go out at night. Me, who had slept very soundly through adolescence, I challenged the reality of my thoughts. I told myself I was catastrophizing, but that nothing had changed because nothing had changed. It was just like last week, this week. I wasn't going to do a mammogram or a colonoscopy. I'm not even joking. I really remembered having this thought. Was I going to start thinking I was having some kind of premonitions in like the next 5 minutes? Fortunately, and before it failed me, I had sufficient insight to recognize that I felt very unsure about my judgment. So it wasn't easy for me to say that nothing is about to happen because my feelings were so intense and felt so real that in spite of any rational basis, something awful was about to happen. And then the penny dropped, the missed periods. Yeah, there were like some very, maybe some warm, somewhat personal summer feelings, but I wouldn't have, nothing that I would have thought was complaint worthy. There were no sweat-drenched nights, and I was like, wow, I'm not gonna have that. And I remembered a friend who had had a hysterectomy, and I went to see her, and I was like blown away, because this was a hugely vivacious person. And she was there, it was like you could feel her anxiety coming off of her in waves. I said to her, you have to go to the doctor. You have to do something about this. And she says, yes, I am in the process of starting HRT. So what happened with the HRT? We all know about the Women's Health Initiative study, and wow, that everybody was just running scared. However, wait, I think a slide has been missed. Okay, I'm going to take you back. So there was an awful experience with the Women's Health Initiative study, but follow-up was continued for 13 years. A reanalysis of the trial with new studies and a meta-analysis showed that the use of HRT in younger women, 50 to 59, that was one of the big problems with the WHI study. It was in older women. So we're talking about women within the 10 years of menopausal onset had a beneficial effect on the cardiovascular system, reducing coronary diseases and all-cause mortality. I don't want to go into the physical evidence, but it is important to note that HRT actually has a whole lot of benefits. the other presenter, I'm sure, is going to speak to that, so I'm not going to speak to it. But we are talking about reductions. The thing is, the onset of mood and anxiety symptoms associated with HRT remain underdiagnosed and undertreated. Regardless of all the reviews that were done, there was just a stain, and that it's like it just wouldn't go away. I'm talking to a friend about HRT, and she says to me, that thing that causes cancer, and I'm like, well, it's not exactly just, that's not like how it goes. We have a full-length discussion, and she says, well, it wasn't really explained to me like that. I think I'm going to go back and talk about it some more. So the potential effects of hormone replacement on mood may be beneficial to estrogen's antidepressant effect. I promise myself all the time that no matter how excited I am about something, I want to have some measure of objectivity. There is a depressogenic effect of progesterone that can be experienced, and it may precipitate non-compliance, right? So remember, we're always talking about fit of patient to pharmacology. Everything is not going to be the same for every single person. In a meta-analysis of studies examining the effectiveness of HRT on menopause, the suggestion was that estrogen reduces depressive symptoms in non-clinically depressed women, whereas progesterone alone and in combination with estrogen is associated with smaller reductions in depressed mood. As I say, I think, again, it's very important. Are we talking about depression that's occurring just as a result of menopause, or is it residual depression from a mood disorder? Remember, a woman with an intact uterus is not going to take estrogen alone. Androgen alone and in combination with estrogen is associated with improved mood. Anyway, the underpinning of any decision to take medication, assess the risks and the benefits in the context of your reality. Breast cancer. Let's talk about breast cancer. By virtue of being alive and being a woman, we are at risk. In the Caribbean, and I'm very nervous about this statistic, it actually sounded low to me. 50.7 in 10,000. That's like half a person in 100. I honestly don't know. However, the fact is, we as individuals are really not even interested in how many out of 10,000. What you want to know is your own individual risk. And that's important. You're obviously going to be talking with a gynecologist who is happy to have this dialogue with you. You are going to establish what your personal risk is. So the point is, you should not be having any of these things dictating the decision to explore HRT. Even that decision comes later, after you have made an assessment and seen, well, is this for me or is this not for me? So this was a table, and we are so much lower than the US. In the Caribbean in general, and I'm not sure that we need to think of, in this slide, we need to think of the Caribbean woman and not women living in the Caribbean. It's not the living in Cayman that's going to change your risk, right? It's certain things that are very specific to being Caribbean. And much, much higher in more developed countries. That may have something to do with the fact that women may have children later. They may not have a child. It's a very, very big demarcation. And as I said, I don't feel totally convinced. Docs in the house, what do you think of that statistic for the Caribbean? Okay, I absolutely think so too. However, the actual risk associated is an increased risk. Some studies have shown 2%, right? Who started early with a much lower percent, 0.5% if you were taking estrogen only, which means that your uterus is no longer intact. Right? So over the years, the data on breast safety and breast cancer mortality have been controversial. Most of the studies support that it is very safe to use and safer in the woman who does not have a uterus. As I said though, and I love this statement because it really puts it in perspective, the increased risk of breast cancer demonstrated in some studies has shown that this risk is lower than the increased risk of breast cancer if you are overweight or drink a couple of glasses of wine a night. So there we go. So you're going to find the best product and delivery method for you. It can be a cream, it can be a vaginal insert, pill, patch, gel. If vaginal symptoms, of course, then usually it's a low-dose vaginal cream tablet or ring. Obviously, like for any other medication, you want to take the least possible amount of medication that you have to, and you also, though the recommendation is to take it for as short a time as you can, there is also the possibility that if you really have bad symptoms that you are going to continue. I'm stopped again. Always seek follow-up care. Any kind of chronic management should mean that you are having regular visits with your doctor and that you're doing all of the things you must be doing, screening such as mammograms and pelvic exams. And I have to say, women's health, and I have said it to them in the clinic here, I said, you know what? This feels like a Park Avenue private clinic. It is so caring. It is so warm. You're never rushed. Everybody is just very lovely. And as I said it to them already, so I didn't just say that to say it here. Healthy lifestyle choices, physical activity, and exercise in your daily routine. Eat a healthy diet, maintain a healthy weight, don't smoke, limit alcohol, manage stress, and manage chronic health conditions such as high cholesterol or high blood pressure. There are alternatives. Some people like bioidentical therapies, and there are other treatments. Antidepressants, sometimes actually paroxetine in particular, has been shown to have a very good effect on hot flashes. We understand that there may be sexual side effects. There are homeopathic remedies. The psychological input, I think, is really incredible. Well, quite frankly, from your 12, maybe the earlier the better, but if you've gotten here, it's really worth considering. CBT, mindfulness, relaxation techniques are what I consider the mainstay of therapeutic interventions in general. Hypnotherapy is very well regarded for anxiety, and acupuncture. Acupuncture has benefits alone, but I think it's definitely considered to have the best benefits in combination. So as I said, for our psychological interventions, those serve us well across the lifespan. Am I going the wrong way? Yes. Sorry. So, I think you get it. I am kind of like the poster child for hormone replacement therapy. The change, the pause, well, can I tell you, I wasn't doing that change thing, right? I have 5 years dedicated to old age, albeit I did come up with that notion way before menopause, but they were scheduled to start 25 years from 50. So the change thing was just not an option as far as I was concerned. It was very unbearable. I did not like it. And I said, is a pause. I said it was a pause, so I'm going to find the play button. And I'm here to say, HRT, I wanted, the way I'm so excited, I want to say it is the play button, but was definitely my play button. In the context of healthy lifestyle and good psychological work, antidepressant therapy, if that's what you need as well, I would almost say that HRT is to women what Viagra is to men. No, and sure, you're going to get your libido back if you want it, but more importantly to all the other waking moments of the day, to be vibrant, to be physically and mentally well, free from depression and anxiety and fear. It is a great time to be a woman. And 50 is a great age to be a woman. 30 years ahead, we have all the way till 80. It's a bit of a journey. Some lessons learned, a renewed lease on life. We have possibility of generativity in a period that has historically not been good for women. Through the sheer luck of our births, in the right countries in the world, we are free women, free from external impediments anyway. At 50, some of us are just coming into our own. Many women have just emancipated themselves from the external noise of social expectations. Many of us are more excited about doing new things than we are afraid of failing. We are freer from the commitments of parenthood. Well, if you took your freedom early and adolescence is looming ahead of you, clearly nobody told you about menopause. And menopause and teenagers are just not compatible, so. But don't let menopause steal these years away. What am I? So, these are my travel recommendations for the journey. Decide to be mentally free. Exercise, take your meds, eat to live 80% of the time, 20% of the time, have a ball, enjoy every sensory moment of sight, smell, taste, and touch. Open your mind and heart to the reality that everybody's truth is not our truth. Our way may be the best way for us. We do not get to impose our value system on the rest of the world. Also, be honest with yourself. We're halfway through our adult lives now. Is your way being right for you? We are free women. We are not trees, and we are allowed to move. Make yourself a priority in your own life. Reorient your thoughts. You can learn how. It's not our situations that define us. It is the way we experience them. Experiencing bad times as growing spaces, that's my thing. It really is a game changer though. It means we only have good days and growing days. Bad days are all gone. Stress. It is unavoidable. It is a part of life, and that's not the problem. Stress is not the issue. It's how we manage it that is the issue. So this idea of re-experiencing things is really quite important. Cardiovascular disease is still the leading cause of death for women, and how we manage stress absolutely affects our mental and physical well-being. So it's not something to be taken lightly. And you know, we've been kind of doing it from birth. I don't know if you ever thought that the birth canal must be pretty awful for the baby, right? Some of them fly out though. Some of us have to be pushed, and some of us have to be pushed and pulled. But here we are. If fear is stopping you from whatever you want, think of fear only as an opportunity to grow courage. Lace up those traveling shoes and get moving. Make your decisions from an authentic place. Own the decision. We're grown. Listen to your inside voice and believe what it tells you. Yes, we all want a guarantee that things are going to work out. Well, guess what? Nobody can tell you that. It's not true if they even try. What we can give ourselves, though, is that regardless of outcome, even in retrospect, we were at that space in time when we made the decision complete with what we did. We weren't second guessing, we weren't hedging, we owned it. We can live with a bad outcome once we feel good and believed in the decision we made. And if you struggle with just being, if you just explore therapy, and guess what? Even if you're limited by financial resources, explore CBT techniques, mindfulness, and interpersonal therapy online. I'm telling you, it's really a great time to be a woman. You can access a whole lot of things. Develop or discover your creative genius. Write, sing, dance, paint, color, cook, bake, decorate. Share your art with the world. Art heals the artist and it heals the audience. Find every opportunity to be kind. Look for them. The world needs kindness. I am so shocked by people's response to such small kindnesses. I'm like, boy, we've really become mean. And we are the world, by the way. You know, we all like to talk about the system and the world, like who are we? What are we? Just spectators? We are parts of all of the things that we think are wrong. We cannot forfeit our opportunity to make the change for whoever we can, whenever we can. We don't need to worry about the whole world. It's doing its thing all by itself. So, and we don't seem to have very much control over that. So, in the individual spaces that we occupy, we really have to do the absolute best that we can. No. I swear they went to all this trouble for limited engagement with the technology, and there we are, right at the end. Thank you very much.
When I was young and free. Thank you very much, Ms. Casterly, for that great presentation. And I'm sure the men in the room who have partners who are going through this menopause transition are very grateful to you because this might encourage their partners to go and get some help. All right, so to show a small token of our appreciation, I want to present you with that. And I know you all may have questions, but we have our next presenter on Zoom. And so if Ms. Casterly will be here, we're going to wait until after that presentation to do the questions. So without further ado, I think Dr. Brooks McKenzie is ready to present, okay?
Good afternoon. I hope you can all hear me. Thank you very much thank you so much for inviting me to speak on the physical aspects of menopause on the whole body in recognition of International Women's Day. It is so great to be here again because some of you who may know that I actually presented at one of your conferences a few years ago, And it's great to see Dr. Denise Casserly, who I know very well. When I used to live in Jamaica, I'm actually beaming to you from the United States, from New Jersey. So at the end of my presentation, you should have a better understanding of what is menopause, what are the stages of reproductive aging, the physical aspects of menopause, and menopause management, and I'll be highlighting what are the current trends. Now, the normal menstrual cycle is a complex interplay between structures in the brain, the hypothalamus, and the pituitary gland. The hypothalamus sends signals to the anterior pituitary, so it releases follicle-stimulating hormone that causes one of the follicles in our ovaries, where the eggs are, to produce estrogen while the follicle is growing. Estrogen is a hormone that is produced in the first half of the menstrual cycle. And then when enough estrogen is produced, another signal is sent back to the brain where luteinizing hormone is produced. And this is the hormone that stimulates the ovary to cause ovulation to occur, where the egg is released, and the next hormone that is produced by the structure that is left behind, the corpus luteum, it maintains the lining of the uterus, because estrogen is a hormone that causes the lining of the uterus to get thickened, and then progesterone is a hormone that is produced to prevent it from not getting too thick, because if you have unopposed estrogen, then later on in life, then it may trigger endometrial carcinoma. The body is also preparing itself for a pregnancy, and if that does not occur, then the hormone levels fall, and then everything breaks down, and that process is called menstruation. So what exactly is menopause, and what are the types of menopause? Menopause, as Dr. Casserly told you, is the final menstrual period. It is, you stop menstruating for 12 consecutive months. Operative word, very important word, consecutive. And you have to have no bleeding, because while we are approaching menopause, the period will stop and start until it finally stops. So don't rejoice as yet. Menopause is a normal natural event, and it is due to ovarian aging. Natural menopause is said to have occurred between the ages of 46 to 54, with an average age of 51. Premature menopause, if you stop menstruating before the age of 40 years, usually as a result of primary ovarian insufficiency. A surgical menopause is when both ovaries are removed, usually at the time of a hysterectomy. And medical interventions such as chemotherapy and radiation to the pelvis to treat pelvic cancers can permanently damage the ovaries and cause menopause. Now, by the year 2060, it is projected that in the United States alone, 90 million women will be living in a postmenopausal state. 290 new independent genes have been identified that influence ovarian aging, and this can affect the age of menopause. So a high polygenic score is important for determining the age at which you see your menopause. And the SWAN study, the study of women's health across the nation, showed a longer menopause transition in women who have many of these genes. The menopause transition occurs about 45 years before the final menstrual period. It is a portal to the second half of a woman's life, and it provides a critical window for assessing our lifestyle and recognizing potential health concerns. One of the things that happens during this time is that there is a redistribution of fat in the body. Fat accumulates inside the abdomen, in the abdominal organs, and that sort of fat is called visceral fat. And if you accumulate too much, that's not good, because that sort of fat can put you at risk for getting the metabolic syndrome, which is a precursor for diabetes and heart disease. And heart disease is the #1 killer of women. At the last North American Menopause Society conference that I attended in 2021, a paper was presented that showed that there's also an increase in the amount of fat that is accumulating in the pericardium, which is a covering of the heart. And this increase in pericardial fat is what is associated with the accelerated risk of cardiovascular disease, mainly in women with a premenopausal women with premenopause, and premature menopause or a surgical menopause. There's also an increase in what we call arterial stiffness. The blood vessels are not as elastic as before. They're not as supple. And these changes actually occur before you see any changes in your blood pressure. In the liver, there's also an increase in the production of what we call bad cholesterol, which is LDL cholesterol and apolipoprotein B, and a decrease in HDL, the good cholesterol. Now, in the past, we used to think that it was a good cholesterol that had that protective effect on the heart. But now research is showing that women, even if you have a high HDL level, it may not necessarily reflect good cardiovascular health. And all of these changes are seen about a year before menopause. And most importantly, these changes are independent of aging. One of the things that occur is that there is loss of lean muscle mass, and this is called sarcopenia, which increases your risk of falling as you age. So what are the stages of reproductive aging? The Stages of Reproductive Aging workshop, STRAW, was convened in 2001. It established a nomenclature for reproductive aging. So it has become a staging system, which is a gold standard for defining all reproductive stages in women. And the model was updated and modified in 2011. This staging system provides a more comprehensive basis for assessing reproductive age in research so that we are comparing the same thing, using the same terminology, comparing apples to apples instead of apples to oranges. It also improves facilitates clinical decision-making as well. There are 7 stages of reproductive aging. 5 stages occur before the final menstrual period, and 2 stages occur after menopause. Stage -5 is a menarche, which is the start of the menstrual period, and stage 0 is menopause. Now, 2 terms, the menopause transition and the perimenopause, have been used interchangeably. But with this staging system, the menopause transition ends with the final menstrual period, and the perimenopause refers to 2 years before and 1 year after the final menstrual period, so it includes the menopause transition. During this time, that is when women start seeing irregularities in the cycle and the hot flashes and different changes that occur in the menopausal period. There are 2 hormones that are produced in the ovaries, 2 other hormones, anti-Multiorgan hormone and inhibin B. These hormones give us what we call is a measure of our ovarian reserve. It gives us an idea of how many eggs are left in our ovaries. So a lot of women who have delayed childbearing because you're pursuing your career and you wonder if your biological clock is running out, then fret not thyself, because we can now measure AMH, and the FDA has approved a kit where we use the AMH as a marker to predict the timing of menopause within a 5-year period. So you will know how much time you have left. Now, as we see women approaching the final menstrual period, we see that the estrogen level gradually starts to fall, and then about 2 years before menopause, it declines rapidly. And then while the estrogen level is falling, we see the FSH, the follicle-stimulating hormone, is also rising, and then it levels off about over 2 years after menopause. So what are the physical changes that are occurring in the body? And for you to understand what is happening, you have to understand how estrogen acts in the body. Estrogen acts on what we call receptors, and they are present all over the body. Estrogen acts on alpha and beta receptors, and depending on which receptor estrogen stimulates, it has different effects. So we see that receptors are in the brain, in the breast, the eye, the genitourinary tract, the heart and blood vessels, the liver, the ovaries, the skeleton, skin, and hair. And what is important is that the impact of menopause on disease appears to be related to the duration of exposure of organ system to circulating estrogen. And as Denise, Dr. Casserly pointed out, that when a lot of people are afraid of taking hormones because they think they are going to get breast cancer. So now we know that in the breast itself, it actually produces its own estrogen inside of the breast, but that's for another lecture. So the first thing that women may notice are changes in the menstrual cycle. So you get changes both in the flow and the frequency of the bleeding. These changes are common and they're normal. So you may notice that the bleeding will be lighter, heavier. The duration of the bleeding might be longer or shorter, and the cycle length may also be longer or shorter. So for example, if you're accustomed to having, say, a 28-day cycle, then you will notice that your periods might be coming, say, every 21 days or every 30 days, and then you start skipping periods. And when I said, don't rejoice yet, because you have to wait until that 12th month before you say this is it. Because I've had women in my practice when I used to practice in Jamaica who they are rejoicing and the period stops and they are pregnant. And when I tell one particular lady that she was pregnant, she fainted. So if you don't want to get pregnant during the transitioning period, then you should use birth control. You can track your cycle on what is called a menstrual calendar, because sometimes abnormal changes can be occurring at that time. For example, if you have stopped menstruating for 12 consecutive months and then you start to bleed again, that is not normal. That's postmenopausal bleeding. It may signify that a pathological condition is occurring, so that needs to be investigated. Vasomotor symptoms or hot flashes are the most common symptoms affecting about 60 to 80% of women, although 70% of women remain untreated. They are recurrent, they don't really last too long, but they are like flushing, so you feel like a heat that is arising in the region of the cheek, the head and neck, and then you feel very hot. And then when all that heat is building up in the body has to cool itself down, and then you get very cold and you start to shiver. So this minute you're hot, and then the next minute that you're cold. And if it occurs at nights, you sweat a lot, so we call that night sweats, and that can interrupt sleep, so you get what we call fragmented sleep, and that has adverse effects for mood and your metabolism. Black women seem to have more hot flashes than Latinas, white, and Asian women, and the reason for these ethnic differences are unknown. Hot flashes are also more severe in obese women, women who smoke, women who have had a surgical or a premature menopause. Hot flashes normally last for about like 7 to 10 years with a duration of about 7.4 years. And in some women, it can last up to 15 years. And in about 9% of women, they don't seem to go away at all, but they usually decrease in frequency and intensity. Now, vasomotor symptoms are not as innocuous as we once thought, because now we realize that vasomotor symptoms increase your risk of cardiovascular disease. Remember, cardiovascular disease, heart attacks are the #1 killers of women. So we have to manage the hot flashes to prevent heart disease in women. And now research is actually showing that hot flashes may be a marker of cardiovascular disease risk in women, similar to hypertension, diabetes, and the metabolic syndrome. One of the more profound effects of estrogen loss on the body is its effect on the skeleton. We reach our peak bone mass by age 30. By age 30, we are building all the bones that we are going to have for the rest of our lives. And then thereafter, it steadily declines. But the greatest bone loss occurs in the first 5 to 7 years after menopause. And by age 80, many women have lost 30% approximately of their peak bone mass, resulting in a condition or a disease called osteoporosis, brittle bone disease, where the bone gets so thin and weak that it breaks very easily with the minimum amount of trauma. Estrogen deficiency is the main pathophysiological mechanism of bone loss in women. Genetic factors account for about 50 to 85% of the variabilities in bone density, and lifestyle factors such as nutrition and exercise contribute the rest. Osteoporosis is the most common bone disorder affecting humans. It's a silent disease. It's called the silent robber, similar to how hypertension is called. A lot of people don't know that they have high blood pressure, so they call it the silent killer. And the first presentation, unfortunately, is usually a fracture. So it's defined as a generalized skeletal disorder with low bone mass and microarchitectural deterioration of bone tissue, leading to an enhanced bone fragility and compromised bone strength. So what does that mean? You see here that the bone has a lot of cross linkages, which gives it its strength. But you actually start getting micro cracks and micro fractures in the internal structure of the bone. And then the bone gets very, very thin and weak. And when you see it occurring, say, osteoporosis in the spine, this is what the normal height of a bone in the spine should be. And then the bone gets all squashed up. When you break your spine, usually thoracic spine, then you start to lose height. And then you start to bend forward until you get like a hump on the back, which is called a dowager's hump. Hip and spine fractures are the most common osteoporotic fractures. And in the United States, they have over 2 million osteoporotic fractures per year, resulting in 500,000 hospital admissions. And 25% in women who break their hips, they usually die within a year of having a hip fracture. And 50% lose their mobility, resulting in permanent disability. Many spine fractures remain undetected unless specifically sought by doing either a DEXA scan or a spine X-ray. The biggest risk factor for getting an osteoporotic fracture is if you're age 65 and older, or if you have had an osteoporosis-related fracture after menopause. If you had a DEXA scan, and your T-score, which is how it is reported, says that your T-score is minus 2.5 or less at the lumbar spine, the neck of the femur, or the total hip, which is the sites in the body that are measured, then you are at risk for getting an osteoporotic fracture. And there are certain ethnic groups, such as non-Hispanic whites and Asian women, who are more at a higher risk of getting osteoporosis and a fracture than Black women. So to make the diagnosis, we do what is called a DEXA scan, and you can see the DEXA machine here with the operator measuring the hip and the spine using dual energy X-ray absorptiometry. So the indications for a DEXA scan are having a fracture since menopause if you're 65 and older. And before, we used to say anyone under age 65 should not get a DEXA scan because osteoporosis usually is not as prevalent in that age group. But the North American Menopause Society, they updated their osteoporosis position statement in 2021 to include women who are age 60 and older. And if you have one or more of these additional risk factors, then this will put you at a higher risk of getting a fracture. So if you have your body weight at less than 127 pounds, if your body mass index is less than 21 kilograms per meter squared, if you have had a hip fracture in a parent, if you currently smoke, and most importantly, if you used to take hormone therapy and you stopped it because of the WHI study or afraid of getting cancer or for whatever reason, estrogen keeps the calcium in the bones, and when you stop suddenly, all of that calcium leaves the bone, and that protective effect of estrogen on the bone is gone, and you are at an additional risk factor for fracture. Now, we don't treat a T-score. So because your T-score might be minus 2.5 or less, it doesn't necessarily mean that you're at a high risk. It depends on your age, because age is the biggest risk factor for getting an osteoporotic fracture. So there are several tools, including this one, FRAX, that you can use to calculate what is your risk of getting an osteoporotic fracture in the next 10 years, whether a hip fracture or a spine fracture. So we have several questions that you can fill out that information, because these are the risk factors for fracturing. You put in your T-score, the type of machine that did the bone density test, you put in the BMD, and then it can calculate what is your risk. And the risk of getting a hip fracture, if it is over 20%, then over 3%, then you should be treated. And if your major osteoporotic fracture, so for example, spine wrist fractures, if it's over 20%, then you should be treated. Now they are putting the trabecular bone score, because in the past, we never used to have risk factors for spine fractures. So now with the trabecular bone score, that can even tell you what is your risk of breaking your spine, and it's reported on this chart here. So if you're in the green zone, you're fine. If you're in the yellow zone, then that's low bone mass or osteopenia. And if you're in the red zone, then you're at risk for getting an osteoporotic fracture if, as you look at all the risk factors for fracturing together. We see that tooth loss after menopause has been associated with osteoporosis involving the jaw, although periodontal disease and tooth decay are the leading causes. The risk for tooth loss more than quadruples every year for every 1% decrease in bone mineral density in the body. So therefore, regular dental examinations are recommended. The genitourinary syndrome of menopause describes the signs and symptoms resulting from estrogen deficiency on the female genital tract. This terminology was developed during a consensus conference of experts in 2014, and it is the preferred term accepted by the North American Menopause Society and the American College of Obstetricians and Gynecologists. The older term was vulvovaginal atrophy, and that didn't sound too nice, and that's why we decided, and I actually voted for GSM because we had several options. So vulvovaginal atrophy is a component of GSM, but vulvovaginal atrophy just describes the appearance of the genital tissues, but it is not associated with the symptoms, and it does not include changes in the urinary tract. Estrogen is a dominant regulator of vaginal and lower urinary tract physiology. It maintains a thick layer of vaginal cells, which are thrown into folds that are called rugae. The vagina is a muscular tube, and when it's thrown into folds, during sexual activity, it actually causes the vagina to stretch and expand. So it is said that if you don't use it, you may lose it. So after menopause, you can see the lining gets very thin, and it does not have that distensibility. Estrogen also keeps the vaginal lining well lubricated and well vascularized with blood vessels. So the signs of GSM are you get shrinking or atrophy of the vagina, the labia minora and majora, the clitoris, the mons pubis, and you can even start seeing sparse hairs on the mons. The vagina actually gets narrow, and in some very older women, because I've seen it, the vagina can close off. And what happens now with the urethra, it becomes very prominent, and the posterior wall can actually protrude on the outside, giving an overgrowth of inflammatory tissue, which is called a urethral caruncle that we can see here. And this is very common in postmenopausal women. The most commonly reported symptoms include irritation of the vulva, inadequate vaginal lubrication, dyspareunia, which is sexual pain, especially on penetration. There's a lot of burning in the vagina, and because the vaginal pH is now more alkaline than acid, and you get an overgrowth of the flora in the vagina, then women are more at an increased risk of getting vaginal discharges. And when estrogen levels fall to less than 50 picograms per mil, we see that all these symptoms of dryness and burning and pain gets worse. Urinary tract infections occur more often because there's incomplete emptying of the bladder, putting women at risk for getting infections. And sometimes you have prolapse of the urethra, prolapse of the bladder, and then you get dysuria. There's pain when you pass the urine, and urgency. That's a common complaint. You feel like you're going to wet up yourself if you don't reach the bathroom in time, and sometimes you do. And women who have had a surgical menopause, they present with more severe symptoms because they just have an abrupt loss of all the hormones in their ovaries at one time. And symptoms affecting sexual function are usually often the most distressing. Estrogen receptors are present in significant numbers in the skin, and there's a 30% decline in skin collagen in the first 5 years after menopause, and thereafter about a 2% decline per year over the next 20 years, resulting in wrinkles and sagging, which may affect body image. There's a greater correlation between the thickness of the skin and skin collagen with the year since menopause than with your chronological age. So it's not your aging that will determine your wrinkles, but your age of menopause that will determine your wrinkling. There are hair changes because there's an increased ratio of the amount of androgens to estrogens during the menopause transition. It's not that the androgen levels increase, but because estrogen levels fall, then there's an a difference in the ratio. And this happens during the transition and may influence hair changes in some women. The most common diagnosis is what we call female pattern hair loss. Baldness is for men, female pattern hair loss is for women. And the most common presentation is that you get thinning of the hair on the crown, and sometimes you get widening of the part, or you might have some large rogue hairs growing on your chin. The menopause transition seems to act as a trigger of a rapidly age-related hearing decline in healthy women. Ocular changes can occur during certain phases of the menstrual cycle and the perimenopause. There is increased swelling of the cornea, the eyelids, the conjunctiva, and this can result in altered vision, dry eye syndrome, blurred vision, and watery eyes. And the prevalence of cataract is higher in women than in men of the same age, and the reason is unclear. Estrogen stimulates the formation of the milk pads and growth of milk ducts in the breast. If we had no estrogen, we would have no breast. Let that sink in. Estrogen also keeps connective tissue of the breast hydrated and elastic. So in the absence of estrogen, the ducts and the mammary glands, they shrink, and the breasts also shrink. They become less firm, they lose their shape, and they sag. So now, let me just give you a few highlights of menopause management. Now, Denise went into details on hormone therapy, so I will just do some highlights here. The FDA has approved indications for the use of hormone therapy, which are: hormone therapy is the first line of treatment for vasomotor symptoms in appropriate women, and I will expand on that. It is also FDA approved to prevent bone loss and reduce fractures in postmenopausal women who are at an elevated risk of getting an osteoporotic fracture. Raloxifene and bisphosphonates are also FDA approved, both for prevention and treatment. Estrogen is not approved to treat, it's only approved to prevent. Women who have hypogonadism, such as women that have what we call Turner syndrome, which is a genetic disorder where these women are born basically without any ovaries. So we give them estrogen to help them to develop their secondary sexual characteristics. Women with primary ovarian insufficiency, premature and menopause and surgical menopause without contraindications. Hormone therapy in these women, according to NAMS and ACOG, is recommended for the health benefits. And NAMS recommends that when these women, when you start treatment, that treatment should be continued until the age of menopause, which is average age 51. Low-dose estrogen is recommended for first-line treatment of GSM to treat vulvovaginal atrophy. This is just to show you that estrogen, some women might get concerned that if you use estrogen in the vagina, especially women with breast cancer, that it might get absorbed into the systemic circulation. Postmenopausal range for estrogen is about 10 micrograms. And it's just a minuscule amount that may be absorbed by these preparations, as you can see, which is even less than the circulating estrogen. So that will not stimulate the endometrium or the breast. The benefits of hormone therapy, as Dr. Casserly said, in healthy women with symptoms generally outweigh the risk, and we use it in what we call the window of opportunity, which if you start it before age 60 and within 10 years of menopause, then your risk of getting breast cancer is extremely low, less than 0.01%. Hormone therapy, estrogen therapy, is the most effective treatment of vasomotor symptoms. It improves sleep and quality of life. Progesterone treatment is not recommended if you use low-dose vaginal estrogen because hardly any estrogen is absorbed to stimulate the endometrium. But if a woman has her uterus in and she's taking systemic hormone, that she's taking it by mouth, because it has to pass through the liver where it might, cause that cascading clotting event in susceptible women, then we should give progesterone to protect the woman, the endometrium, so that it doesn't get too thick. And most importantly, because risk can change over time, there should be continued assessment as to whether women should continue or not, and it's shared decision making. So who should not use hormone therapy? If you have unexplained vaginal bleeding, or if you're pregnant, if you have coronary heart disease, stroke, venous thromboembolism, a blood clot, liver disease, or dysfunction. Systemic hormone therapy is not recommended usually for survivors of breast cancer, but they are saying people with triple-negative breast cancer, that's enough for another lecture. Hormone therapy is not recommended for women to start it for the first time after age 60. And Dr. Casserly said that most of the women who were in the WHI study, they were over 60 starting hormone therapy for the first time, and that's why we saw all of those results that occurred. But for those women who are unable to take hormone therapy or who don't want to take it for whatever reason, there are non-hormonal options. Paroxetine mesylate is the first antidepressant that the FDA has approved for the treatment of hot flashes. And then other products can be used, what we call off-label. Gabapentin, I used to use it a lot. It's very good because it causes, it helps women to sleep when you take it at night. And you have other antidepressants that can be used as well. Oxybutynin, a drug that is used for bladder, overactive bladder. They show that it's very good for treating hot flashes if you use it short term, and also clonidine. There's also some benefits for cognitive behavioral therapy, mindfulness-based therapies, and women who use compounded hormone therapy is prescribed on the basis of salivary hormone testing, which is unreliable, and the dose is not necessarily the same. It is now recommended that the focus for osteoporosis treatment should be on diet and exercise first, lifestyle. So calcium 1,200 milligrams a day is recommended. Try to get it mainly from food and supplement the rest that you're short. Vitamin D, 1,000 to 2,000 international units per day is recommended to keep the blood levels at about 30 nanograms per mil in persons with a high risk of fracturing. Protein is extremely important to prevent sarcopenia. So you should try to eat about 1 to 1.5 grams of protein per day. It is not recommended that you routinely screen women for their vitamin D levels if they are healthy, and exercise is recommended to prevent osteopenia. So the type of exercise is like strength training, resistance training 2 or more times a week, and balance training about 15 to 20 minutes per day. So as I wind up the presentation, I just want to mention that scientists are always looking for new options for women. So I want to just tell you about 2 therapies that are on the horizon, estetrol and fezolinetant. Estetrol, E4, is a naturally occurring estrogen with selective action in tissue, and this class of drugs, we call them NEST. This is produced by the fetal liver, E4. It crosses the placenta. It's excreted in maternal urine at about the 9th week of pregnancy. There is minimal first pass in the liver, so that takes care basically of that clotting problem. It minimally stimulates the breast, so all those women who are afraid of breast cancer, this would be a very good option for you to consider. It significantly reduces hot flashes, and it improves the symptoms of GSM, and it also decreases bone loss, so you get a lot of bang for your money with this product. Now, fezolinetant is what we call an NK3 receptor inhibitor. There are some neurons in the hypothalamus in the brain called kisspeptin, dynorphin B, and neurokinin B and dynorphin. And collectively, we call them the candy neurons. They play a role in the development of hot flashes. And we now have a product, fezolinetant, that blocks the receptor because they produce neurokinin B. And if you can reduce the neurokinin B production, you effectively cut off the source of the hot flashes where it generates it at the level of the hypothalamus. And it has been shown to decrease the severity and the frequency of hot flashes, and it also improves sleep and quality of life. And I think by now that they have sent the research information to the FDA, and we are awaiting to see whether the FDA will approve this product or not. Another exciting thing on the horizon, you are now discovering that estrogen not only acts on the alpha and the beta receptors, but it also acts on what we call the G protein coupled estrogen receptor called GPER. This is a membrane receptor, and estrogen binds with the same affinity as with the other receptors, but it works in a different way. Through a series of complex chain of events, there's a production of a substance called cyclic AMP, which is like a second messenger that signals to different parts of the body what should happen. So in this case, it promotes the blood vessels to relax, and it decreases the blood pressure. So there is a hypothesis that GPER protects from vascular aging, and if they can find therapeutic products targeting this receptor, it should improve the cardiovascular health.
I believe she got cut off from the Zoom call, so we're going to try to get her back. But in the meantime, we can have some questions for Ms. Casterly, our previous presenter. So we'll take a couple of questions if anybody has any. Yeah, absolutely. Dr. Alexander just said that it was a very good and relatable presentation, and definitely I agree. Dr. Brooks McKenzie, Miss Casterly, Dr. Casterly, did an excellent job, and I'm sure many of you, like myself, are so thrilled for what awaits us.
Don't worry.
Any questions at all? Okay, so that means she did an excellent job explaining everything. Okay, I think they're getting her back. Okay, so yeah, let's do a raffle prize. We have 2 more. We'll save the grand prize for the end, but in the meantime, we'll do 1 more before the last presentation. Oh, so we have 2 grand prizes, but we can do 1 now and 1 at the end while we wait. Okay, so one of our grand prizes is a spa certificate for the hibiscus spa. I'm sorry. Yeah, it's a hibiscus spa. So we are going to draw the ticket for that. If you can get your tickets out, and we will do that drawing now. And I'll take a minute just to mention and say a big, big thank you to our sponsors for the raffle prizes. Our sponsors for the conference, yes, but also for the raffle prizes. The HSA graciously provided most of these prizes, and specifically for one of our grand prizes, we want to thank Ms. Brooke Moore for sponsoring our big prize, which will be the one done at the end. So give a round of applause, please, for that. Okay, so this one is for the spa gift certificate. All right, so that is 586859. Anybody have that number? Oh yeah, we have a winner. Okay, so I think I made a mistake with the spa. Hibiscus is Westin, so this is the Marriott spa. Okay, so congratulations. Do we have Dr. Brooks McKenzie back? Yes, so she's back on. So if anybody has any, oh, I'm sorry. She's not back. Okay, so I hope you have been enjoying the day. Our presenters or presentations have been wonderful in my opinion, so let's give a round of applause to all of our presenters. And we again want to thank all of our sponsors, Health City, Cayman Fertility Clinic. I don't know what I did with my list, so I forgot them all, but you have them in front of you. We want to thank them so very much. Baptist Health, of course, thank them so much for partnering with us to make this day possible. Okay, so we have Dr. Brooks back on. So anybody have any questions that they would like to ask her?
Yes, I was just wrapping up with my last slide.
Okay, yes.
Yeah. Sorry, so can I just get back to it? I just had, just to finish up that one slide that I was talking about. Can I do that? Right. Yes, I was just wrapping up by saying that this new receptor that they have now discovered that estrogen acts on the G12 receptor, that this would be a game changer for women because it would have ramifications for heart disease protection in women, and women would have fear getting breast cancer, heart disease, blood clotting, and all of those things. And just to end by saying in the words of this ancient Greek philosopher, Heraclitus, he said, the only thing that is constant is change. So therefore, we should embrace the change of life and not be fearful of it. So menopause is about healthy aging, and it is not just about hot flashes. Thank you very much for your attention.
Thank you, Dr. Brooks McKenzie, for that very excellent presentation. And so we would like to take a couple of questions, if anybody has questions for her. Yeah. Can somebody please take a mic to Caroline?
Hi, I'd just like to ask, because I hit menopause at the age of 40 and I've been on HRT for 10 years now. I'm still waiting for that Viagra effect, unfortunately. But I sort of, it was two questions really. Is it worth considering changing my HRT because I really would like that effect? Is it worth taking HRT maybe till I'm 65 because I've been on it for 10 years now? That would be 25 years of taking HRT. Is that a possibility or not?
Yes. What they say is that you should not start it after age 60. But if you're already on hormone therapy and you're not having any problems, because remember I said that every year you should really be visiting your doctor just to look and see if anything is changing, because risk can change over time. So if you're happily taking your hormone therapy and you're not getting any problems and it's relieving your hot flashes, although you're waiting on this sexual part to click in, but that's a different question, because I actually did a presentation for the Caribbean College of Menopause, the Caribbean College of Family Physicians on sexuality in the postmenopausal woman. So that's a completely different story as to why you might have, not having that sexual feeling. So that needs to be investigated. But happily take your hormone. And for those women, say, for example, suppose it's vaginal dryness and sexual pain that is causing you to sort of get, you don't want to have sex because it hurts too much. There is a product, DHEA, that is FDA approved, and it works, what we call it, has an intracrine effect in the vagina because it works on all the receptors. It's actually the androgen receptors in the vagina that gives you that sexual excitement and stimulation, and estrogen also does that. So the DHEA, it will increase the production of the androgens, which actually act on the area of the introitus. And you have to know, like, the embryology of how the vagina and the uterus, what parts of the endoderm, ectoderm, mesoderm form what parts, what different tissues, to show you where all those receptors are. So, you know, unfortunately, men have Viagra and women have nothing. But testosterone therapy is not FDA approved to treat women, but in the United States, they use it off-label. They don't use the same dose with the men. And there are some pharmacies that try to compound, you know, testosterone products, but that's usually not recommended.
Thank you very much. Thank you.
Thank you. Any other questions? We'll take one more if there's any. All right. So I think that means that Dr. Brooks McKenzie did an excellent job, thoroughly gave us all the information we need. And so thank you once again, Dr. Brooks McKenzie.
Thank you.
All right. So give yourselves a pat on the back. You have made it to the end. We are at our last presentation. And as I said, I think we've had an excellent day and a great representation for our 10th year doing this. So let's move right along to finish off the day on another excellent presentation. So our next presenter is also part of our HSA family, is Dr. Colin Charles. He was born in Jamaica and grew up in the Cayman Islands and attended Lawrence University, where he majored in physics and pre-med. He earned his medical degree from the American International School of Medicine in 2009. He is currently completing his final year of residency training in obstetrics and gynecology at the University of the West Indies, Mona. He has a particular interest in minimally invasive gynecological surgery. After working on the hospital front lines, managing COVID-19 patients over the past year in Jamaica, as well as surviving a very severe presentation of the virus himself, Dr. Charles has become a passionate advocate for vaccinations and public education of the COVID-19 virus. So without further ado, I'd like to invite Dr. Charles to come and present pandemic times, pregnancy, childbirth, postnatal, and vaccination.
Thank you. Good afternoon, everyone. I'm Dr. Charles. I am very happy and grateful to be here with you today. I'm especially grateful to be able to speak on a topic that is near and dear to my heart, and that's on the topic of the COVID pandemic and pregnancy. The COVID pandemic has affected our world in an unprecedented manner. It's impacted almost every facet of our life, even the things that are most dear to us. It impacted the ability for us to physically spend time with our family, to travel, even leave our homes. Some of us even lost our livelihood. Most importantly, millions died. After a long, arduous 2 years dealing with this pandemic, we are only now beginning to feel a little loosening of the tight grip of the restrictions of the pandemic. Borders have reopened, people are traveling again, we are able to congregate in groups. We're able to congregate in groups. No longer are we looking at the prices of masks and sanitizers any longer. Now it's just the gas pump. But that's a different crisis for another day. But COVID is still here. It's still real, and it still kills. but we've lived with it, and we've learned to live, and we've learned. We learn not just to live with it, but how to efficiently treat our patients as healthcare workers to keep ourselves safe as well as them. It is this acquired knowledge over time that us as healthcare workers have now used and implemented in our care of pregnant women. But during this pandemic, all the struggles that we've experienced, there's a unique cohort of persons who experienced unique challenges with unique anxieties, unique fears. And as healthcare workers, we had unique considerations to make. And that's the cohort of the reproductive woman. It was young women who want to get pregnant, who had concerns. What if I get COVID? How would this affect me? How would this affect my unborn child? For those women who were pregnant, if I get the vaccine because I want to protect myself, what would this possibly do to my child? For those women who delivered and had their bundle of joy at home and want to do everything that they can to provide for their child, wondering, do I have to make a decision about getting the vaccine because I'm breastfeeding or not? It is those concerns and anxieties that in this presentation we're going to attempt to alleviate, while we also discussed as healthcare providers, what are the considerations that we make in managing pregnancy in a pandemic. So as we go through the presentation, we'll go through the steps of labor in terms of the considerations made antenatally, intrapartum, as well as postpartum. We'll spend a little time talking about venous thrombosis prevention, or as we say, blood clot prevention, and we'll also talk about vaccination in pregnancy. So we'll commence with the antenatal period. What are some of the considerations that we have to make as an organization, as healthcare providers and facilities? What about patients who have suspected COVID or confirmed COVID and need a hospital assistance? How would they be advised to be cared for? And what about the women who have recovered from COVID? What are they supposed to do? Well, from an organizational standpoint, it's important for us to remember continuity of care. Even though it's a pandemic, to still continue routine antenatal visits. We should be able to implement changes and modifications to accommodate the needs of pandemic protection, which includes social distancing, as well as good ventilation. There are also practical measures that we need to keep in mind, which is that in wearing masks, that persons who are hearing impaired may have inability to read lips. So these are some of the considerations that we should make. Whenever it's needed, for persons who may be in lockdown and self-isolation and aren't able to do in-person consults, it's important for us to implement alternative modes of consultation, whether through telemedicine or remotely. In particular, persons who may have comorbidities or other risk factors that may predispose them or increase their risk of contracting COVID or presenting with severe symptoms should be screened and looked for. We should also be careful for those particular patients to treat them, to protect them and treat them in a single room. Persons who are been non-attendant to the antenatal care, there should be systems in place to be able to continue antenatal care through telephone consults and being able to implement them into follow-up care as soon as practical. Clear pathways of communication via handheld notes and electronic records for patients who may be seeing multiple units or areas of disciplines of care should be available. There should always be easy 24-hour access to care for maternity patients. And continuity of care, as I said before, is very paramount. In the event of emergency, they should be able to have a contact number that can be easily accessible for all antenatal patients if there are any concerns of the maternal concerns of COVID or for the well-being of their baby. We should be careful to continue and ensure that our patients, antenatal patients, continue to supplemental intakes in terms of prenatal vitamins or folic acid, as well as follow through with their antenatal vaccinations. Pregnancy, the needs of a pregnant woman before the pandemic are just as important, if not more so, during the pandemic, especially for those who may be socially vulnerable. It's important to note that there's an increased risk of domestic abuse in pregnancy, which has escalated during the pandemic. It's important for us to maintain in-person appointments to create a safe environment where patients can comfortably express their concerns in confidence. There is evidence that the pandemic has resulted in a greater level of anxiety and mental health problems in pregnant women than in overall population. Women should be asked about their mental health at every contact. Women who require further support there should be signposts and resources readily available for them to utilize, and if be, an immediate referral. It's important for us as healthcare providers as well to look out for the red flag symptoms, such as patients presenting with suicidal thoughts or sudden mood changes, or if their families express symptoms as such. There should be urgent support that is able to provide for those type of patients, and as I said before, in severe cases, with immediate referral. For women, pregnant women, who may suspect that they may have symptoms of COVID, we suggest that you contact your health facility immediately. And we beg you, please, do call ahead. If one were to call ahead, we can go ahead and make the appropriate mode of transportation to be arranged for you. If an ambulance is required, our call handler will be alerted and able to make accommodations. It's important to alert family members of maternal staff by telephone numbers on arrival at the hospital entrance, where the appropriate staff with appropriate PPE will be able to meet the patient at the entrance and escort them very quickly into an isolated room where we can minimize transmission in admission, as well as protect them and surrounding staff and other patients. It's important as healthcare facilities, when we're managing these type of patients, to also remember, when we're dealing with patients with suspected or confirmed cases, to put them in isolation rooms where there are non-essential items. As I said, face masks should not be removed for these patients until they're in an isolated area or suitable room. Only essential staff should enter these isolation rooms or bays. Visitors should be kept as a minimum in accordance with the local policies. All clinical areas should be cleaned accordingly. So what are some of the considerations for antenatal patients who have recovered from COVID-19? Well, it's reassuring to know that those patients who had mild symptoms, who have recovered without requiring hospital care, there are no antenatal changes moving forward. Their antenatal course remains the same. For those who have missed appointments due to isolation, they should be streamlined into continued follow-up care as soon as possible. For those who were hospitalized, however, it should be important before being discharged that obstetricians make a plan in terms of their antenatal care for follow-up. Additionally, for those who are hospitalized, it's important to know that an ultrasound scan to assess the fetal biometry should be done after 14 days following the recovery. Now, that's just a little bit about venous thrombolism prevention, as laymen know as blood clots. Pregnancy in and of itself is a hypercoagulable state. Most antenatal patients will be annoyed by their doctors who constantly tell them, stop crossing your legs. But we know in pregnancy that you have an increased chance of developing clots. So we gently remind you not to cross your legs. We've also noticed that patients who are hospitalized with COVID, with moderate or severe COVID, they have also been found to be in a hypercoagulable state. So clearly, there's a link between COVID and an associated risk with maternal venous thromboembolism. With that in mind, patients who are in isolation, we encourage them to hydrate appropriately and to ambulate and be mobile as much as possible. Where normally indicated, thromboprophylaxis or blood thinners should be offered and administered. A clinical venous thromboembolism risk assessment should be performed, and thromboprophylaxis should be considered and prescribed on an individual basis. Thromboprophylaxis initiated for pregnant women who are self-isolated should continue until they've recovered from the acute illness. All pregnant women who have been admitted to COVID-19 admitted for COVID-19 should be offered prophylaxis by low molecular weight heparin. For women with severe complications of COVID-19, the appropriate dosing regime of low molecular weight heparin should be discussed with a multidisciplinary approach. All pregnant women hospitalized and have confirmed with COVID-19 should be offered thromboprophylaxis for 10 days following hospital discharge. If women are admitted for COVID-19 within 6 weeks postpartum, they should be offered thromboprophylaxis. Labor and delivery. Showtime. What are some of the considerations that we have to make as healthcare workers during labor and delivery? What do we do for women who are asymptomatic but have tested positive during COVID, or symptomatic during COVID, who have recovered from COVID-19 and recovered? What about the birth partners who are presenting with the mother? What are the considerations we should make regarding the timing and mode of birth during COVID-19 pandemic? What are the considerations in terms of pain medication, analgesia, and anesthesia? What is the proper PPE that should be used? And how should obstetric theaters be managed during COVID pandemic? These are some of the considerations that we have to make as healthcare organizations. For women who are asymptomatic but tested positive for COVID, no change in fetal monitoring or assessment during labor is advised. Skin-to-skin contact following delivery should be encouraged as normal. Mothers suspected of COVID-19 or confirmed and are symptomatic. In mild cases, they can remain at home in early labor. But for those who have visited the maternity ward and usually advised to return home until established labor can be advised to continue to do so. On admission, a full maternal and fetal assessment should be undertaken, including assessment of the severity of the COVID symptoms, maternal observations looking at your respiratory rate, oxygen saturation levels and temperatures, confirmation of onset of labor per standard care, and continuous electronic fetal monitoring. Electronic fetal monitoring offered for symptomatic patients should be offered, and while we minimize the amount of staff that is exposed during these exposed to these patients while they're admitted. For women who have recovered from COVID-19, it's reassuring to know that if they did not require hospital admission, there's no change to their labor and delivery. For recovered patients following hospital admission for serious COVID, however, there's needed supportive therapy. Healthcare professionals should make a personalized assessment considering the fetal growth. Now, what about the birth partners during labor and delivery? Well, we strongly recommend and advocate that birth partners be present during labor and delivery. Birth partners who are symptomatic, however, or in self-isolation should not come to the hospital. We strongly encourage and we currently practice the testing of both the woman and the birth partner on admission to maternity ward. Birth partners not isolating should be allowed to stay with the mother with the woman through the labor and birth. Wearing face masks, of course, staying by her bedside and not allowed to walk around the hospital, and we often recommend frequent hand washing. Restrictions on visitors are per hospital or clinic policies. What are some of the discussions and considerations that we make in terms of the timing and mode of birth during the COVID-19 pandemic? Well, for patients who are asymptomatic, there is no change to the timing or the mode. But for persons who are symptomatic, we take a client-based approach to regarding the delivery. Women with worsening symptoms should have a multidisciplinary approach in their management. Where possible, the woman and her partner should be involved in the decision for expedited delivery. It's important to let family members know that donning of PPE for emergency cesarean sections is time-consuming but essential, and it may impact the time it takes to assist the birth. What are some of the considerations that we make in terms of pain, and analgesia, and anesthesia during labor? Well, we commonly give Antinox with nitrous oxide and oxygen combination, and there's no evidence to say that there's a contraindication in administering this with COVID. There is no evidence as well that the epidural or spinal analgesia or anesthesia is contraindicated in the presence of coronavirus. What about the operating theater? What considerations should be made? Well, in cases where we have suspected COVID-19 or confirmed COVID-19, and these are elective obstetric cases such of that nature, it is best that those cases are done at the end of the operating list. We should also limit the number of staff to essential only and keep it at a minimum. It's also very good for us to practice having a checklist, which we have implemented as well, to close the loop of communication. So postnatal, we have our bundle of joy, now, but we're still in the pandemic. What are some of the considerations that we have to make? Well, we have to consider what is the neonatal care during the pandemic. We'll also consider feeding of the infant during the pandemic. And we'll also consider what mothers and babies will do after they're discharged. A lot of mothers, especially those who have tested positive, are very concerned in terms of their exposure, direct exposure to their neonate. Well, there's a prospective cohort study done in the UK that investigated maternal infection and also neonatal infection within the first 28 days of life. And what they found is that neonatal infection was very uncommon. As a matter of fact, in this study, the incidence was 5.6 in 10,000 live births, which is very, very low. Additionally, in terms of severe cases where the neonate contracted COVID severely, the incidence of this was only 2.4 in 10,000 live births. So the infection of neonatal admission following birth to a woman in perinatal COVID infections was very unlikely, which supports our guidance to avoid separation of mother and baby. Mothers and babies should remain together immediately postpartum. We encourage skin-to-skin care, but we still recommend taking precautionary measures. Women who choose to breastfeed should be encouraged to do so. While breastfeeding, we recommend taking an individualized approach. It's important to note to mothers that COVID-19 is not a contraindication to breastfeeding. As a matter of fact, if one mother is unable to breastfeed, we encourage that they use breast milk expression to get breast milk. That's for these. However, when handling with our neonates, we want to limit the virus spread to the baby, so we strongly encourage hand washing prior to touching the baby, as well as the pumps and bottles. We recommend avoid coughing and sneezing while feeding the baby, and we encourage wearing a face covering that is fluid resistant while caring for the baby. We strongly discourage babies wearing face masks. We recommend having a dedicated breast pump that is cleaned accordingly. And if the mother is unable to feed for whatever reasons, we recommend that someone who's capable can do so. So what are some of the postnatal considerations for mother and baby after being discharged from the hospital? Well, all women of the household, all women and their families should be advised about safe sleeping and smoke-free environment, along with the provision of clear advice about careful hand hygiene, infectious control measures when caring for and feeding for the baby. Families should be guided as to how to identify signs of illness in the newborn, as well as worsening signs of the mother. Women who have recently given birth and tested positive should also receive all recommended advice, guidance, and support in relation to their postnatal physical and mental health and well-being for themselves as well as their newborn. In-person home and clinic appointments should be offered to allow overall assessment of physical and psychological health and well-being for the woman as well as her baby. All pregnant women who have been hospitalized and have had COVID-19 should be offered thrombophilaxis for at least 10 days following hospital discharge. Now let's talk a little bit about vaccines and pregnancy. So this is a hot button topic, and there's a lot of concerns and anxiety, especially in pregnancy, about the vaccine. And there's a lot of questions. What are the vaccines that are available to us? Who's eligible for the vaccine? What are potential risks to the mother or to the baby? When should you get the vaccine? The timing in the pregnancy that you should get the vaccine. And for us in particular, how should we counsel our patients regarding the vaccine? I will talk a little bit about the latest research where that's concerned as well. Well, on this side of the world, the most prominent vaccines that are available, as we all know, there's the Pfizer vaccine, there's the AstraZeneca, there's Moderna, and there's the one-dose Janssen. We know in the 3-phase trials, the Pfizer, which is predominantly what's offered here, has had an efficacy of 95%. However, in real-world monitoring, we know it's more like 60%. We also know with the addition of the booster, there's an 88% less likelihood for patients to be admitted to the hospital with the Omicron variant compared to those who have not been vaccinated. The UK Health Services Agency has also given us some data in terms of the booster that we found to be very valuable as well. We've noted that with the Pfizer booster and protection, with the Pfizer booster, there's a boost in protection against symptomatic Omicron infection from a 0 to 10% protection pre-booster to a 50 to 80% within 1 week. The protection levels of about 40 to 70% will persist for 10 weeks after booster vaccination, depending on the exact vaccination regime administered. In general, what are the general vaccine safeties? Well, for the most part, most of the vaccines that are available to us have a very similar profile based on the 3 trial phases. Most cases, the adverse effects are very minimal. This includes minor local reactions to the injection site, such as pain and redness in the injection site. There tends to be mild systemic adverse effects like fatigue, headache, myalgia, which are less common and last for a few days. And about 10 to 20% of persons who've been vaccinated had a fever. And more commonly, however, in the AstraZeneca, persons tend to get a fever in the first dose. After the second dose, more commonly in the Pfizer vaccine. And in very rare cases with the AstraZeneca, there's serious thrombosis in context of thrombocytopenia. Once again, that is very rare. And also, even more rare, there are cases of myocarditis and pericarditis after the vaccination. So who is eligible to get the vaccine? Well, we recommend vaccination of the COVID-19 vaccination to all women. And this can be given at the same time as per your national guidelines. We do recommend the use, if you are going to offer the Pfizer or the Moderna for pregnant women, just for the mere fact that there's more information in terms of testing in pregnancy compared to the others. So what are some of the effects, potential effects in terms of maternal or fetal effects? Well, we know for more than 270,000 women in the UK and the US has had COVID-19 vaccine in pregnancy with no concerning safety signals. Pregnant women were not included in the large randomized controlled trial contesting safety and adverse effect profiles of the COVID-19 vaccines. However, as of November 2021, 177,000 pregnant women from diverse ethnic backgrounds in the USA had received the Pfizer vaccine or the Moderna vaccine with no evidence of harm being identified. In general, there are no known risks from giving inactive or recombinant vaccines in pregnancy while breastfeeding. So what are some of the maternal effects? Well, as I stated before, some of the maternal effects include minor short-lived adverse effects with soreness to the injection site, such as headache and fatigue, which are common. Pregnant women did report nausea and vomiting more frequently after the second dose of the Pfizer, and a reduced incidence of systemic features such as fever in pregnant women. Now, there's the concern of vaccine-induced thrombosis and thrombocytopenia. This is very rare, unpredictable, idiosyncratic vaccine reaction. The first dose of the AstraZeneca, there's an incidence of approximately 1 in 100,000. It's not associated with the usual venous thromboembolism risk factors, and there's no evidence that pregnant or postpartum women have a higher risk of developing vaccine-induced thrombosis and thrombocytopenia compared to that of non-pregnant women. So those were the maternal effects. What are some of the fetal effects? Well, preliminary findings from the USA have not identified any safety problems regarding to maternal or neonatal risks. Spontaneous miscarriage occurred at a similar rate in women who received COVID vaccines compared to the women who were unvaccinated. The most common adverse outcomes there's a study where it shows that the most common adverse outcomes of 724 live births in a study in Shimabukuro et al. Were preterms, where there's an incidence of preterm births at 9.4%, small for gestation at 3.2%, and major congenital anomalies at 2.2%, which are all consistent with published rates. None of the mothers whose babies were born with congenital anomalies had received the COVID vaccine in the first trimester or in the preconception period. Just a little bit in terms of antibody transfer. We know that vaccine-elicited antibodies have been found in infant cord blood and breast milk following the administration of the COVID vaccine. In terms of the timing in relation to the stage of pregnancy or breastfeeding for when one should receive the COVID vaccine. There's excellent real-world evidence of vaccine efficacy, with 98% of women admitted to the hospital developing severe infection having not received the vaccine. Pregnant women should be supported to come and be informed on the decisions of vaccination. Breastfeeding women can receive COVID-19 vaccine. There's no need to stop breastfeeding to have the vaccine. There's no evidence that the COVID vaccine affects fertility, so there should be no need to delay conception. So in terms of counseling, as healthcare providers, how do we recommend counseling for our patients? What are the concerns that we recommend? What are the options that the patients have in terms of counseling for the vaccine? Well, patients have the option to receive the vaccine. Patients have the option to decline the vaccine. Patients have the option to delay taking the vaccine. These are all part of the counseling that we should offer our patients. We also should let them know that in the event, what the benefits are of the vaccination, so they can make an informed consent and decision. They should be informed in terms of the benefits of the vaccination, includes reduction in severe disease of a pregnant woman, with potential reduction in the risk of preterm births associated with COVID-19, reduction in transmission to vulnerable household members, reduction in the risk of stillbirths associated with COVID-19, and potential protection of the newborn from COVID-19 by passive antibody transfer. We also should counsel them, as we discussed before, on the risks of the vaccination. We know from maternal cases that there's minor local reaction, mild systemic adverse effects like fever, fatigue, and myalgia, thrombotic adverse effects with the AstraZeneca vaccine or the Janssen vaccine, which is very rare, and there's been no evidence of suggested fetal harm following the vaccination. In terms of fetal risks, oh, sorry. Right. Now, in our counseling, if, more importantly, the person declines the vaccine, it's also important to let them know of those risks. Most women who have COVID-19, they'll have no symptoms. However, in some cases, some women will develop critically ill symptoms. And the risk of severe illness from COVID-19 in pregnant women is higher than that of non-pregnant women, particularly in the third trimester. And there is consistent evidence that the pregnant women are more likely to be admitted to the intensive care unit than non-pregnant women. In terms of the fetal risks, if one were to decline the vaccination, we know that symptomatic maternal women who have contracted COVID-19, there's an association that is 2 to 3 times greater risk of preterm birth. Stillbirth, though the risk is stillbirth, the risk is approximately doubled with the COVID-19 infection. And these risks should be personalized with individuals considering their exposure in the occupation, as well as comorbidities or severe illness or medical conditions. So in terms of research, what is the latest research in terms of, well, some of the latest research in terms of COVID vaccines in pregnant women? Well, there's research that is ongoing. Pfizer is conducting a worldwide research project, including several UK National Institutes of Health research sites, in which pregnant women are being randomly assigned to receive the Pfizer vaccine or a placebo. Those who have received the placebo during the trial will then be offered the vaccine once they give birth to ensure the participants have the opportunity of being vaccinated. There's also the Horizon 1 study, which is also planning by Janssen, which all participants will receive the Janssen vaccine. Finally, the PregCov-19 LSR pragmatic trial, in which pregnant women who are receiving different vaccines in different schedules depending on their gestational age at enrollment. The aim is to identify the most effective schedule in order to protect pregnant women as well as other aspects such as whether or not the vaccine improves immunity conferred by breast milk. So in conclusion, as we've looked at all the different aspects within half an hour of pregnancy, what are the take-home points that will be pertinent for us to learn and go with? Well, pregnant women are no more or less likely to contract COVID than the general population. The Omicron variant may be associated with less disease than the Delta, but it's more infectious, especially in pregnant women who are unvaccinated. The reported increase in congenital anomalies incidence of COVID-19, there's no reported increase in congenital anomalies incidence for those who have taken the COVID-19 vaccine. Maternal COVID infection, which is associated with a double risk of stillbirth, increased incidence of small gestational age, and preterm birth in women with symptomatic COVID appears to be 2 to 3 times higher than the background rate. Vaccination in pregnancy against COVID is strongly recommended. It's safe and reliable. COVID vaccines can be given at any point in time during your pregnancy, and pregnant women receiving a COVID-19 vaccine should show similar patterns of reporting of adverse minor effects compared to that of non-pregnant women. Breastfeeding women can receive the COVID-19 vaccine without having to stop breastfeeding. There's no evidence to suggest that COVID-19 vaccines will affect fertility. And for those women who would like to get pregnant, trying to get pregnant, no need to hesitate, no need to delay. Just a reassuring word to that cohort of women who want to get pregnant, who are currently in the labor room. Shout out to Nurse Julie, see you soon, or who have already delivered. I'd like to just say to you, I wish you an uneventful pregnancy, I wish you a safe delivery, and I hope you have a safe child that you can love for a lifetime. I'm Dr. Charles, thank you very much.
So we want to thank Dr. Charles for that very informative presentation. We appreciate you being with us today. And as a small token of our appreciation, we'd like to give you this small gift. All right, so thank you. And if there's anybody who has any questions for Dr. Charles, we'll take maybe one question before we wrap it up for the day. Any questions for him?
Or I'll be outside.
Yes, so that was excellent. Thank you so much again. All right, so it's the time of day that I know you have all been waiting for. This is the final raffle prize that we will be drawing just before we do the closing remarks. And I gave you a hint before as to what it was. And so it is a grand prize of a 2-night staycation at Breezy Bay, which is a 3-bedroom, 3-bath, private oceanfront, single-level home in North Side, belonging to our very own Brooke Moore. She has graciously offered this prize for our grand prize. And so without further ado, we'll do the drawing for that. All right, gave that a good shake. Let's see. So the winner is 586867. 586867. Any takers? All right, let's go again. All right, so next is 586823. What? Whoa. This one we definitely have to check. Yes, so congratulations, Dr. Felix. Okay, so thank you all once again for joining us for today's conference. I hope you had a wonderful time and learned a lot. Reminders to please take a few minutes for the in-person attendees to complete the feedback survey to help us improve on future conferences. And just remember as well that you can scan the QR code on your tables to be able to access your CME certificate. And I would just like to invite now Mrs. Yearwood to give the closing remarks.
Thank you, Dr. Palmer. Wow. It's been an incredible day, hasn't it? We've learned a lot about the issues and research advances associated with reproductive health, how to use this information and achieve better health outcomes. And I think many of you are probably ready to pack your bag and go on the trip with Dr. Casserly, right? I'd like to thank everyone who's had any part to do with today's event and making it a huge success. Thanks, first of all, for being a fantastic audience. Thank you for staying engaged and supportive. Help me also to thank the Women's Health team for their detailed planning and hard work. Their passion is truly inspiring, and especially to our competent and flexible MC, Dr. Karina Palmer. Thank you so much for a job well done. Thanks also to our marketing team, who has worked alongside the Women's Health team in helping them to create their vision for today's event. Especially, many thanks to Ms. Brooke Moore, who has assisted with the audiovisual all through the day. A huge thanks also to all of our speakers, both local and international. Your insightful presentations were well received. Thank you so much. Thanks also to our very informative exhibitors, Ocean Med, Cayman Rehab Services, Progressive Distributors, MSD, Senka, Public Health, HCCI, Miami Cancer Institute, Cayman Fertility Clinic, Cayman Clinic, the Cayman Islands Breast Cancer Society, and last but not least, Cayman Islands Cancer Society and Breast Cancer Society. They go hand in hand, don't they? I was happy to see many of you visiting these booths and taking the opportunity to learn more about the services they offer, as well as networking. As you heard from our lovely Dr. Palmer, today was an educational event, but also a day of celebration. A celebration for the women and their achievements, as well as our 10th anniversary of the Women's Health Conference. So I hope you've had a fun day while networking and learning. A huge thanks also to our sponsors, who have truly helped us to elevate this event with your contributions. Thanks to our silver sponsor, Miami Cancer Institute, bronze sponsor, Cayman Fertility Clinic, Ministry of Health and Wellness for our Wi-Fi access today, Cayman Clinic for helping us be refreshed and stay alert with the morning coffee, Health City Cayman Islands for the delicious lunchbox that helped us get back on time, the HSA for being our title sponsor, and a special thank you to our CIG TV partners for live streaming the event today. Thank you so much. So I sincerely hope that today has been an inspiring and stimulating for you as it has been for me, and that we can build on this partnership and the information shared today and move forward with improving the health of all women here in the Cayman Islands. Have a wonderful evening, a restful weekend, and I look forward to seeing each and every one of you and your friends to next year's Women's Health Conference. Thank you so much.